Hearing of the committee's inquiry into foundational and disability supports available for children and young people in New South Wales. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians on the lands on which we meet today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal people and their ongoing culture and connection to land and waters of New South Wales. I also acknowledge and pay my respect to any Aboriginal and Torres Strait Islander people joining us here today. I'm Natasha McLaren-Jones and I'm the chair of the committee. Could I ask everyone in the room to please turn their mobile phones to silent? And parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses may say outside of the hearing. And I urge any witnesses appearing today to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants, and I encourage committee members and witnesses to be mindful of those procedures. First of all, I'd like to welcome our first witness here today from Marathon Health. Before we commence, I would like to ask you to state your name and your position, also either swear an oath or take the affirmation. I understand the words are in front of you as well. Thank you.
Good morning, my name is Kylie Irvin and my position is Portfolio Manager for NDIS Services in Western. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you very much. I might start with questions and then I'll hand over to my colleagues. As I mentioned a little earlier, we have two colleagues online as well, Mr Scott Barrett, member of the National Party, and also Mr Mark Buttigieg from the Labor Party. Could you give a bit of an overview of the challenges that families have raised with you about accessing services, particularly from a rural and regional perspective?
Yeah, absolutely. Shall I start with my opening remark would you like me to jump straight into questions? No. Sorry,
I should have said that. Do you have an opening statement you'd like to make?
Yes, I do. Thank you. Thank you for the opportunity to appear today. I'd like to start by acknowledging the traditional owners of the land on which we're meeting, and I pay my respects to elders past and present. Marathon Health was established in Western New South Wales in 2015 to address gaps in high-quality, community-based health and wellbeing services for people living in regional, rural and remote areas. We now deliver face-to-face services across 75% of New South Wales and a virtual service Australia-wide. We are a non-profit organisation with a vision for empowering these communities to thrive through equitable health and wellbeing. All of our 300 employees live and work in regional New South Wales, which gives us unique insight into the challenges and barriers families living in regional, rural and remote New South Wales face. Marathon Health is a key provider of community-based early intervention supports to children across regional, rural and remote New South Wales, and I welcome the opportunity to provide information that will support equitable access for families no matter where they choose to live. Today I will speak from my perspective as a speech pathologist with more than 18 years experience delivering services to children living in communities such as Dubbo, Cobar, Nyngan, Lightning Ridge and Walgett. From this experience, I can testify the difference that early intervention supports and services make in a child and family's life if they can access them, and unfortunately the impact on children and families when they are unable to access these services. Over the last year, I've had the privilege to lead the co-design and delivery of the Flying Start paediatric service in collaboration with remote communities in Western New South Wales. This service provides families living in rural New South Wales with free access to a paediatrician in their local community, unlocking access to ongoing health, education, carer and social supports based on each child's needs. To date, over 60 children have accessed this free holistic assessment by a paediatrician and allied health team. More than 80% of these children identify as Aboriginal or Torres Strait Islander. Unfortunately, despite us being ready to scale, at this stage, sustainable funding for this service has not been secured, leaving many children on wait lists and no guarantees for service. With the current foundational support reforms and through these inquiries, I believe that we have a unique opportunity to create a system focused on collaboration, universal access, early intervention and evidence-based practice, particularly for our most vulnerable in our regions who are often overlooked.
Thank you very much. And also thank you for coming to Parliament and to Sydney to appear in person as well. It's greatly appreciated. And also the work that you do, particularly supporting rural and regional families. So I might go back to my first question, which was around the challenges that families have identified in being able to access those services.
Yeah, absolutely. So there's probably a few barriers that exist out in those more rural and remote communities. Larger regional centres like Dubbo do have access to a number of different services and service provider options, but the further remote you go, there might only be one provider in the community, and they might only see children with an allied with a NDIS plan. So I guess that's one barrier is being able to meet the eligibility criteria to get the supports that you need, as well as understanding how to get into those systems when there's not diagnostic services available and there's not those people that they can walk into the offices of and ask the questions, where do I find this help? My child has a developmental difference. Who can I go to for support?
And you mentioned in your opening statement the Flying Start paediatric service, and also in the submission, the Waratah for Kids. Could you outline what those two programs are? And you said that, are they self-funded or do you get state or federal assistance with it?
Yeah, so I'll speak about Flying Start first because that's one that I've been primarily directly involved with. So the funding for that initially came through philanthropy, through Variety the Children's Charity, and we worked together with them to develop this model based from community need, identifying that there was many children in some of these remote communities who didn't have access to disability supports or early intervention supports. And a big reason was they weren't able to see a paediatrician, they weren't able to meet the criteria that the NDIS requires to get ongoing supports in place. So, and we also recognise, the travel distance is a big barrier for those families living out in those communities as well. They can't easily come into metropolitan assessment services to get those supports. So they're just staying in community and they're not able to get any access. And sometimes what we see is those children arriving at kindergarten and having quite significant developmental delays. And so I'm talking about children coming to school who aren't toilet trained, they haven't maybe accessed preschool. In some situations, they aren't able to communicate very well. They might have 10 words and they're entering the kindergarten in formal schooling with that sort of level of delay without having access to any supports. So we designed this model to go out and start working in community and identifying these families and these children who need support and bring the supports to them. And so we've been working with local GPs, working with child and family health nurses, with wellbeing nurses who are based in the education system to collaborate with families and get them to see a paediatrician to unlock the access to NDIS supports, education supports and things like that to get better outcomes. Waratah for Kids, and the Rural Doctors Network also came on board to help fund that in the last 6 months as well, which has been a great help. The Waratah for Kids program has been funded by the Murrumbidgee Primary Health Network, and that is working with GPs and allied health supports and a community-based paediatrician to upskill GPs in providing supports to early childhood and in terms of understanding developmental milestones and referral pathways and families and putting health linkers in to help families navigate what supports they need, where to access them, and as well, an add-on as the program has been evaluated, the newest part of the program is adding some intervention into that model as well, because we recognise that it's good and well to identify where there are developmental differences, but if you can't provide support to help children get on the way to catching up with their peers, it's really disheartening for families. Just to say your child has this diagnosis or they have this, significant delay, here's some options of service providers, but they're $271.59 an hour in a remote location. You can pay privately. If you have an NDIS plan, you can do it, but otherwise there's nothing for them to access.
Thank you very much. I might hand to my colleague.
Thank you. And good morning. Thank you so much for your submission and for coming along. One of the things that stuck out in your submission was this bit about how prior to the NDIS, you had this network of allied health assistants based in preschools and schools, but that's not really been possible since NDIS came in. I think we've seen in quite a few of the submissions this kind of, I guess, unintended consequence of NDIS, where it's led to quite a lot of fragmentation in service provision. Can you explain to us kind of what that looked like prior to NDIS and what makes it hard now?
Absolutely, yeah. So prior to the NDIS, there was lots of block-funded programs where we could have community-based models of service, working with preschools and schools and having allied health clinicians and in this case allied health assistants in community delivering supports and services that children and families needed. When the NDIS came in, it very much removed those sorts of funding models and put it into specific individualised funding packages for individual children. And so there has only been, there are some situations where we're getting some funding through primary health networks to be able to go into small communities and work with children in those preschools. So little communities, for example, outside of Dubbo, maybe between 30 and 60 minutes outside of Dubbo and working with those children. But again, it's fairly individualised and there's not enough focus on capacity building, being able to run groups, work with the educators in those settings to identify children. We are doing some referral pathways where we see children with complex needs, but there's not enough flexibility or enough funding to spread around really since the NDIS.
I've spoken to a few different people who were disability ministers in different states and territories at the time NDIS came in. There seems to be a general acceptance that they thought NDIS was going to cover a lot more than what it's ended up covering. And if we're only looking at sort of 1 in 10 people with a disability being covered by NDIS, now that we are focusing back again at the states providing this so-called foundational supports, however we want to define it, how do you, I guess, see us taking this opportunity to go back to having some of that block-funded approach where you can go out and actually run sort of more community-wide, generalised programs to capture more people?
It's quite exciting, I think, the opportunity to be able to get back to doing some of that type of work where, you know, because we've just seen these huge gaps now that come out. It's either you have an NDIS plan or you don't. And if you have an NDIS plan, you're almost one of the lucky ones because you're able to unlock that access. I think, I just lost my train of thought, my apologies. I think that, I think it needs to be a collaboration in community. I think there needs to be a lot of consideration for what is in each individual community already, because what we know is that local health districts are quite stretched and they're not able to provide services in all the communities that other not-for-profit organisations might be in. So I think there needs to be a real collaboration and not necessarily sit funding with one particular agency, but rather looking at what all of the services are that are available and how they can work best together. And I think very much having community-based locations like health linkers, allied health assistants, those sorts of positions that can work across agencies. They might sit in education or they might sit in health, or they have that frequent contact with allied health clinicians to be giving that targeted intervention when that's required for a particular child, but also helping families understand referral pathways, get referrals actioned, linking them with the other supports that they need, capacity building opportunities. I think distance is also a significant barrier in our areas as well. That we have clinicians based in, I don't know if you know the town of Canamble in the northwest, We have a few OTs based in that office, and they might travel 400 kilometres in a round trip in a day to go out and see families in remote communities and provide services. But again, that's usually in that NDIS model of service delivery, and we're in preschools and we're in schools and we're in families' homes, and we're seeing children who have a plan. But what we can also see is lots of other children who need some supports, but we're not able to because of the rigidity of that NDIS funding model.
So, yeah, I mean, I sort of admit to being a critic of that sort of market-based service approach that has come through, quite unfortunately, I think, through the NDIS in a way that has led to that, the fragmentation, but also the making it more difficult for people to then navigate and find the services that they need. But also some of the submissions have spoken about a breakdown then between a lot of the sort of private providers of services through the NDIS and the public school system. In our previous inquiry that the Chair and I were both involved in, we were looking at the experiences of children with a disability in the education system. And one of the obstacles that kept coming up was a reluctance of schools to allow speech pathologists and other sort of allied health professionals coming into the school. Was it easier before NDIS, or have those obstacles sort of always been there?
I think in some respects it may have been easier before. I think one of the things that the NDIS has done is it has meant that families who have been able to navigate this system have been able to access more therapy. So there are more clinicians on the ground, and there are more clinicians going into schools and wanting to see children. I actually worked for ageing, disability and home care, so I was sort of part of that before the NDIS rolled out. And I think what we really only saw was those more severe end people with a disability, whereas I think now there is some opportunity for the moderate level of disability clients to get access. So I think there are more clinicians. I say that, however, in like very rural and remote, that's not the case because there's just not the providers out there. And I think in those communities, there isn't a reluctance from the Department of Education to have clinicians coming into the schools. They're excited to have an OT or a speech pathologist come in and work with their teachers and with their children.
Thank you.
Thank you. I might see, do you have any questions?
Look, I wanted to explore something that you've raised in your submission around Medicare bills. I think you've touched a bit on this about Medicare billed services. I mean, you've raised the whole issue around, I suppose, the structure of the NDIS model. It's very individualised, and you're advocating for a more sort of collectivist. And I think one of the tensions was that the NDIS model was built on the premise of giving people with a disability choice.
Yes.
And if you move back to a more sort of collectivist model in terms of foundational supports, obviously there's more rigidity and less choice. Perhaps you might want to offer some comments around that.
Yeah, I can. I think in the regional, rural and remote, there's probably less choice anyway, because there's not the range of providers that are available in metropolitan areas. I think families would be very happy to get any kind of support in that 0 to 9 age group from the providers that are available in the community. And I know that some Aboriginal controlled health organisations, for instance, have found their own funding and are purchasing in allied health supports to come into community to be able to deliver some of that free community health type intervention for children and families. So I think it's less about taking away choice and control in those regional, rural and remote communities. I think, yeah, just having a service that can provide intervention for that early intervention age group without needing to meet all the criteria that's needed for NDIS access would be brilliant.
I mean, you raise in your submission also the issue around the limited availability of specialists and allied health providers. I mean, this is just an inherent problem, not just in disability, but in health provision in rural and regional and remote areas. What do you think the solution is? I mean, it's the eternal problem that we face.
Absolutely, it is. I think Marathon Health, as a not-for-profit, we are quite committed, because we are so passionate about regional, rural and remote. We're quite committed to trying to develop our workforce and try to attract graduate clinicians. We have some structured pathways for psychology interns. We supported 61 student placements in 2023-2024. So I think it's about investing in those workforce development career pathways for young professionals, getting them to come out to our community, giving them a really good experience and good opportunity to see how good it can be to be out there, and then working with what's in local community as well, so that you don't need all of the services to be living in Walgett or to be living in Nyngan or Brewarrina. If you have access to some of those in your larger regional centres, or nearer to where those communities are, but then you have some living in community that you can build the skills and have a local workforce, I think that's probably going to lead to best outcomes.
Do you want
to? We might pass to Mr. Barrett.
Thank you, and thank you for tolerating me being online. Ms. Irving, in your submission and in lots of other places, we hear the disparity and vulnerability in regional areas and remote areas versus metro areas. How big an impact is the lack of providers having on that? Is that because of the lack of the providers, and or what are the other factors that lead to that disparity?
Yeah, I think that's a good question. It's not just the lack of providers in some of these communities that's leading to the disparity between metro and rural remote children. Some of the families in the communities, in the most remote communities that we access, they're just not engaging with health and education and preschool settings like you see in other regional settings and metro settings. Part of that might be culture. We often see they have, as a community generally, it's just quite a low health literacy and understanding of different systems and what they can be doing to support their child's development. There's, other socio-economic factors at play as well in terms of living a far distance from their nearest preschool or services like that. I know there's the Brighter Beginnings program that operates out through Western New South Wales communities, and that is really, from what we've observed, targeting those 4-year-olds who are in the preschool environment and trying to make sure they screen 4-year-olds in terms of capturing them then, supporting their transition to school, making recommendations to, have a positive transition to school. Sometimes children aren't at preschool in the communities where we're living and working. And also 4 is quite late to be trying to identify developmental concern. It doesn't give you much time to have an impact before they get to 5. That really needs to be a focus on getting in there earlier and having those points of contact with allied health earlier on in the journey to have better outcomes.
Would there be people in these communities that, I guess, first of all, aren't aware that their children do need this extra assistance, and then also that this extra assistance is available for them?
There would be people, I think, that fit that category. And I think that's where we find it's really great to work across as many different agencies as we can and figure out who has the local relationships with these families and try and capture them wherever they're at. So working with the Aboriginal medical centres and working with, different contacts at the preschool and at the health service and wherever they might access to try and build capacity of other people in the community so that you don't need to rely on visiting allied health professionals. But yeah, there's a lot of work to be done in that education space in terms of building capacity of communities locally to be able to support the families who live in those towns.
You talked about so you mentioned Dubbo, Cobo, a lot of as well, but there's a lot of the communities around that. So how much is the effectiveness of services lost, first of all, when you're doing these sort of fly-in, fly-out visits to smaller communities? And then I guess further exaggerated when people need to travel into places like Coonamble or Walgett or Dubbo away from their home communities to access these services?
We really prioritise delivering services in families, in the places where families and children are playing, working, living. So we like to do home visits, we like to do preschool visits, because we need to see what functional skills those children need. We need to see how they're communicating with their friends. We need to see how they actually behave in the environment, not in a clinic setting. So we very much are the approach of we will do the travel and we will see families in community. I don't know how that might change with the recent NDIS price review, which is making it really difficult for providers to travel because of the caps on travel, and how viable that will be for providers to do that. And there'll be, I think, certainly an increased expectation for families to travel to services. And I think what will happen is that many families won't be able to do that.
One more, Chair, if that's okay. We've talked about the gaps in some of the services now because of the lack of coordination around the broader picture of it. Is there also duplication in some areas? And that must lead to a fair bit of frustration if there's an oversupply in some areas and non-existent in others?
I don't think there's an over-duplication in the areas that I'm aware of. I think in our local areas we have some really nice paediatric allied health networking meetings where we really try to collaborate, share information, service map. We discuss what communities we're visiting, who's going where, what programs we're running. So we are on a local level really trying to meet the need of these communities together. So yeah, I don't think there's an over-duplication. I think we always say it's not a competition. There's so much work to go around in our communities. It's just let's work together to find a best fit for each individual community and family and child.
Thank you. Thank you, Chair.
Thank you very much. I've just got another final question in relation to the gaps you were talking about and the pressures that may now be on families to travel to access services. What role can telehealth play in that, or is it it just doesn't work compared to being able to have a face-to-face?
I think we place a lot of value on face-to-face intervention. In our experience, it can certainly complement face-to-face service delivery, and I think there's probably different options to be explored that do work well. For instance, if we're working with a family or a child for therapy, there needs to be somebody there with the child to support that. So whether that's their family in a home environment or whether it's an educator in the preschool environment, sometimes that is a barrier, having someone on the other end to help support the telehealth. But I think, having a local person to be able to support that telehealth is really important. I think, you just can't replace face-to-face. It's just so valuable, and what we hear from the families that we work with, because there is plenty of telehealth providers around that will just do telehealth therapy and they'll never come out into community and actually meet the child face-to-face and see the environment and the landscape out there, is that they just really love the relationships that they can form with their therapists and how much that supports their therapy goal achievement.
That's great. Thank you very much. One more question. Yep.
Thank you. It just occurred to me, someone came to see me. I'll get this question out. Someone came to see me recently, who was talking about the difference between learning disabilities and learning difficulty, or learning, basically the lifelong learning, whatever you want to call it, difficulty or disability, in terms of dyslexia or dyspraxia or a bunch of other learning disorders. And this person was talking about the need for there to be foundational supports for people once they've left school. So we think about those things as something that's applying only to people while they're sort of at school and jumping through the hoops of exams and everything else. But there's a sort of increasing awareness that they are lifelong disabilities and there is a need for foundational support that doesn't get caught with things like NDIS. So it's a little bit outside the scope of this particular inquiry, but I'm curious, do you have any sort of thoughts on what those kind of foundational supports could look like, and do you agree that we need to be a little bit more inclusive when we're talking about disabilities?
It's an interesting concept, and I think we, as Marathon Health, we do provide services to people across the lifespan, and so we are seeing adults in those environments after school. And again, because of the NDIS funding, it is very individualised, and when we're going into community access type programs, supported employment environments, and accommodation providers, I think we are in there to work with one person in that environment rather than the whole cohort of people, and there would definitely be merit in capacity building and upskilling the providers and the communication partners and the people who are around every day, because they have the most impact on that person's ability to do things and their functional skills. So I think a lot of the things that we're talking about for the early intervention age group in terms of foundational supports could very much be applied to other age groups as well. Yeah.
Thank you.
Well, thank you very much. Unfortunately, our time has expired, but again, thank you very much for coming and everything that you do as well.
My pleasure. Thank you for having me.
And safe travels back.
Thank you.
The swear the oath or take the affirmation. I understand those words have been emailed through to you. We might start with Dr. Kennedy.
Thank you. My name is Dr. Niroshini Kennedy, and I'm appearing here as President of the Paediatric and Child Health Division of the Royal Australasian College of Physicians. I'm a developmental paediatrician based in Victoria, working across public and private settings, as well as the Aboriginal community-controlled health sector. Shall I proceed with the oath?
Yes, please.
Yes. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Dr. So?
Thank you. So my name is Dr. Lydia So, and I am a developmental paediatrician working in southwestern Sydney Local Health District, New South Wales Health. And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much. Do you have an opening statement that you'd like to make?
Yes, I do. Thank you.
Thank you.
The Royal Australasian College of Physicians welcomes this opportunity to appear before the Select Committee and strongly supports the efforts made by the New South Wales Government to improve foundational and disability supports for children and young people in New South Wales. I'd like to begin by acknowledging that I'm speaking to you today from Melbourne on the lands of the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to their elders past, present and emerging. The Royal Australasian College of Physicians, or RACP, represents over 28,000 Australian and New Zealand physicians across over 40 specialties, including 8,500 members in New South Wales. We have over 5,000 paediatricians and paediatric trainees nationally, of whom about 30% are based in New South Wales. The Royal Australasian College of Physicians is the key training body for physicians and paediatricians in Australia. I'm speaking to you today in my capacity as President of the Paediatrics and Child Health Division of the RACP. I am a paediatrician in Victoria, specialising in developmental paediatrics. I have worked in both public and private settings, including the Royal Children's Hospital in Melbourne, where I have practiced for 25 years, and over a decade in the Victorian Aboriginal Health Service, which is a community-controlled Aboriginal health service in Melbourne. In my clinical work focuses very much on vulnerable children involved with the child protection and out-of-home care settings. I'm joined today by my colleague, Dr. Lydia So, who is a developmental paediatrician in southwest Sydney, who also has experience across both the public and private sectors. The RACP acknowledges the New South Wales Government's pivotal role in fostering inclusive environments for children with disabilities. Central to this is prioritising early intervention and integrated services. As paediatricians, we know that delays in care can lead to poorer lifelong outcomes. Systemic barriers must be addressed through clearer pathways, easier access, and better support for families. Our submission outlines 31 recommendations across 8 domains, calling for a more equitable and coordinated system of early childhood and disability supports. The key priorities include strengthening early intervention as a core part of healthcare, expanding screening and timely diagnosis and support for underserved communities, addressing workforce shortages across sectors, improving system navigation and reducing service fragmentation, and finally, aligning the New South Wales policy with the recommendations from the NDIS review and the Disability Royal Commission. The advice we have provided in our submission is grounded in the deep expertise of our physician members. I will now invite Dr. So to speak to the New South Wales experience.
Thank you.
So thank you for the opportunity to be of service to the Select Committee. In the interest of time, I'll keep it brief. So in New South Wales, there's 6.8 million people aged between 0 and 65. And we have 1.4 million children aged between 0 and 14. That's 20%. However, 43% of all active NDIS participants are aged under 15. So to me, this represents a cry for help. And I want to acknowledge the work of my colleagues in producing this fantastic submission. It gives recommendations for what to do next. And so just to reiterate what Dr. Kennedy has said and what our college members have said, is that the first 2,000 days are critical. We want early childhood intervention and support to be recognised and funded as essential care, not something that children need to qualify for through a diagnosis. And we need to strengthen access to early intervention, especially for priority populations. We need more diagnostic capacity, and the ACI Clinical Practice Guide provides a very useful framework for this. And finally, systems need to stop working in silos. Health, education, and disability sectors must collaborate. We need better coordination between NDIS and non-NDIS supports, and families can't be expected to navigate these systems alone, and we risk more children falling through the gaps. So like Dr. Kennedy said, we strongly support aligning reforms with national recommendations and co-designing services with those who live the experience, children, families, and frontline professionals. Just as a small edit, I also work as a team leader for a developmental assessment service. It is my public role. And I no longer work in the private sector. So we now welcome questions from the committee members.
Thank you very much. I might start before handing over to the Deputy Chair. One of your recommendations is around expanding respite care services. I'm interested to know where you see some of those gaps existing at the moment.
I might let you take that, Lydia.
Sorry, I couldn't see across the room. I was wondering if I could take that first question on notice.
No, that's fine. Any question,
I-
happy for you to take on notice.
Yeah, I'm not too familiar with the landscape for respite services, but I agree that it's very important.
Yep. The other one is in relation to the mobile outreach services. Interested whether it's also from a Victorian perspective, but also New South Wales, what services are currently available and where they provide that service, like what areas? Happy for you to take on notice. I understand it's submission from organisations, so more than happy if you would like to take that on notice.
Lydia, are you able to comment on the New South Wales services? I can speak to, in general terms, the role of outreach services, but it may be useful to hear from you about New South Wales.
I would say that my experience is also more generalised. I'm not aware of exactly the landscape in terms of outreach services. Certainly, my service doesn't provide outreach.
I suppose perhaps if I could just add, in general terms, we are looking at reducing barriers for vulnerable families to seek care early, and sometimes where services are located are not always accessible to families who might have difficulties with transport, who might have caregivers, parents and caregivers who struggle to access services. So certainly in Victoria, in the Aboriginal community-controlled health sector, outreach is a really important part of the work that we do. We take the care to the families. What that means is that we have in the past run screening programs at local Aboriginal kindergartens. We have run them in community centres. So in general terms, when we're talking about screening and particularly equitable services for vulnerable groups, outreach is a really, really useful tool that we can use.
Thank you. And my final question, Dr. So you talked about workforce shortages, particularly in certain sectors. I'm interested to know what those sectors are that you're aware of, that there are particular workforce shortages in being able to service the needs of families.
Would it be okay to add to what Dr. Kennedy had said in the earlier question before I answer the workforce shortages? I did say that our service doesn't provide outreach, but actually we are embedded in the community. So we're a community paediatrics service, and we are based across different community health centres. So I suppose in a way that is providing outreach. Mm-hmm. In relation to workforce, I was wondering maybe Dr. Kennedy, you might be able to talk a little bit more about that one.
Of course, Lydia. And while I can't speak to the exact services in New South Wales, in general terms, what we're hearing across Australia is there are great waiting lists for children with developmental and behavioural conditions. And the waiting lists are linked to a number of things, a growing need, but also workforce shortages across diagnostic services, treatment services, follow-up services, and allied health. Certainly there is a huge inequity as well in terms of access. Many families choose to use private services when the waiting lists at public services are insurmountable, but that is not an equitable option for a lot of families, and that means that the most vulnerable are missing out. So certainly there is a lot of concern amongst paediatricians about workforce shortages and the maldistribution, particularly across rural and regional areas, and in particularly for priority populations, so in the Aboriginal community-controlled sector and in other vulnerable populations. We can certainly take this question on notice and give you some more specific data around New South Wales. We'll be happy to come back to you on that, but that's in broad terms what we were referring to in our submission.
Thank you very much. I might hand to the Deputy Chair.
Thank you. One of the themes, I guess, that's been coming through in a lot of the submissions and is also mentioned in yours is in relation to the need for an integrated service. And we've spoken a lot about fragmentation of services, not just between NDIS and non-NDIS, but as you said in your opening statement, with health, education and disability. What does it look like in your mind of the ideal kind of integrated model? If we had a magic wand and we could create something tomorrow, what would it look like?
Thank you for that question. This is something that I'm really passionate about. I think when we look at the health needs of children in Australia, the growing burden of developmental and behavioural conditions, the growing mental health crisis that our children are facing, we need to deliver healthcare differently. We have a wonderful health system in Australia, but it has been very hospital-centric. And what that has meant is that we haven't been able to develop the sort of community-based wraparound teams that can really address the core drivers of the developmental and behavioural concerns that these children and families are facing. So I think when I think of what an ideal service is like, my views on this have really come from the time that I have been privileged to spend in an Aboriginal community-controlled health service. So we have in Australia for the last 40 or 50 years this remarkable Indigenous-led model of healthcare that we see in Aboriginal community health services. So really, Aboriginal community-controlled health services have pioneered integrated care in Australia. They've been running this model for over 50 years. And in a way, the mainstream system is now catching on to the benefits of that model. That model is grounded in the community. They're based in the community. They're not based in hospitals. It's grounded in primary care and screening. So there is a system of annual health checks that involves screening, health promotion, increasing health literacy, and building a relationship with health providers. And certainly the best integrated care models internationally have that at its core as well. You have from there a team-based delivery of care that follows that can really match the child. So this is patient-centered care. So for one child, it may well be that what they really need is to link in with an educational liaison officer. For another family, it might be about a social worker to help that family source secure housing, which is going to be really the key plank to that family linking in with appropriate services. For another family, it might be about addressing specific speech therapy. So really you have this coordinated team that wraps around a child and family and the family's needs, rather than what we have at the moment, which can be provider-centered care. We have one clinic that might be for a particular health condition, and people come to that clinic and get the care, but it's not really patient-centered. So I think when we're looking at ideal models, firstly, I think what we need to do is to go to Aboriginal community-controlled health services, support them sustainably, fund them, help them to develop their model, evaluate them, and then support them to develop the model to the point that we can actually learn from the mainstream system.
So how much of the obstacle at the moment do you think is a product of everything being funded on a sort of per item basis, as opposed to funding professionals to do everything that's required within a community to, do that preventative work and the outreach work and everything else. Is there, I think I fall into the trap of thinking of these magical good old days, which I don't know if actually existed, but we hear a lot of talk about, there used to be community centres with doctors who were funded to do that sort of broader outreach rather than having to worry about a per patient, per item funding model. Within the disability services space, do you think, and that interaction with health and education and everything else, how much of the fragmentation is as a result of that funding model, do you think? And should we be looking then towards putting in block funding now to try and build these so-called foundational supports going forward?
I think I agree with you. I think that without the right health infrastructure, it's really hard to deliver effective foundational supports, and that health infrastructure is community-based care. And I think you're right. The funding models can sometimes encourage what is more siloed care. And that's something that occurs across every state. Every state's health system has addressed that in a different way. And my colleague, Dr. Lydia So, might be able to speak to the New South Wales experience, but certainly in the state that I practice in, Victoria, it's a major barrier to us addressing these problems effectively.
Dr. So, did you want to contribute there?
I think reflecting on what you've said about the good old days, in preparing for this inquiry, I actually went to look for where our early childhood intervention services were. And so there's the Reimagine website, which used to be CIA, and they used to have a list of early childhood intervention services. And I couldn't find it. I had to go back on Wayback, and I found the list for our local area, for example, was say Bridges for Learning or Mater Day, and we had MECIS, which was the MacArthur Early Childhood Intervention Service. But we've stopped referring to them. Some of these providers have reoriented to the NDIS, and some I don't think exist anymore. I don't actually know how these early childhood intervention services work now, because they were based on what Dr. Kennedy is talking about, this team-based, multidisciplinary approach. And my concern is that, I guess with the privatisation of ADAC, we are disincentivising or creating barriers to that multidisciplinary collaborative approach. Like you're saying, it's sort of this user-paced system. And so that is, in a way, I believe, contributing to fragmentation of care.
Thank you.
Thank you. Mr. Diana.
I sort of want to pick up on the themes that have been covered so far. Particularly, I'm interested in your recommendation 10, which is about advocating for a shift in the NDIS away from therapy-centric interventions towards promoting inclusive environments for children with disabilities in schools and communities. And I wanted to pose to you, and I raised this with the previous witness, it seems that the NDIS system architecture is premised on an individualised model and individuals making choices in a market, and that's derived very individualised based system as opposed to a more collective based system of provision. So I wanted to ask you about how you envisaged this shift actually occurring, given it seems to run contrary to the kind of basic system architecture of the NDIS. So perhaps you might want to elaborate on how you think we would shift the NDIS away from this therapeutic centric model.
Thank you. That's a great question. Thank you. I just want to start by saying the NDIS has revolutionised support for children and adults with a disability in Australia. I have been practicing paediatrics long enough to remember what life was like and what the options were for young people before the NDIS, and it certainly has been revolutionary. Having said that, it has to be a sustainable system and an equitable system, and I think that's where some of the concerns have been, and that has driven a number of reviews and certainly the reflections that no doubt have come in front of this inquiry. I think a key plank of what the NDIS set out to achieve was to increase the participation of children and adults with a disability in society. And I think a key plank of that is making sure that our community is also inclusive enough to include people with disabilities and developmental differences in the community. And I think a good question that we ask of our schools, our workplaces and our communities is how much of that has changed. And I think that's what we were aiming to open a discussion about in this conversation. So as well as focusing on the individual, we need to build a society that is more inclusive.
And so how do you, are you suggesting that the state effectively fills the sort of collective action gap, or do we try and encourage the individual choices that are being made by NDIS participants towards more collective approaches?
I think the detail of that is probably outside of my scope in my role here and expertise, but in general terms, I would say there is a very well established body of literature around the social model of disability and what that means in terms of the changes that need to happen in a community and in schools and in the workplaces to make places more receptive and inclusive for people with a disability. And I think the point we were hoping to get across that as well as individual therapy, we do need to ensure that there are measures taken to ensure that the society is more inclusive and that people with disabilities can participate to their fullest.
Thanks. I'm mindful of the time, so I might give Mr. Barrett a shot.
Thank you. We'll now pass to Mr. Barrett, who's online as well.
Thank you. Dr. So, you mentioned that 2,000 days and how critical they were. I presume that is the pre-school days. Given the issues we're identifying as far as the identification of developmental vulnerabilities, there's also a bit of lack of awareness about the services available to these people. What efforts and resources are needed to bring someone, I guess, back on track if they get to these 2,000 days without the support that they need, without the identification of those issues?
That's a very good question. And I suppose if I can come back a little bit to that previous idea about making sure that the environments are right too, I think that is part of the responsibility. I was thinking about the ideas in a simple analogy. Thich Nhat Hanh would say, don't blame the lettuce. And so it's about the environment and the supports that we're putting around children to support and nurture them to help with their growth and their development and their outcomes. And so I think we've been thinking about these ideas for a long time about how to support children. And I wanted to draw attention to the paper that was produced in 2013, Strengthening Supports for Children and Families 0 to 8. And it already talked there about this tiered early intervention system. So we are using those principles of universal proportionalism to support people at different levels of that tier. So universal, targeted, and intensive. And I think, pointing out correctly the first 2,000 days is that 0 to 5. We do worry about children who are perhaps not getting that early intervention soon enough. In the ideal world, we would have more capacity in the tier 1 and 2 levels to identify, to screen, and to provide early intervention before children get to beyond the first 2,000 days. But, beyond that, we obviously still need to continue to support these children. And I don't think it's a matter of saying, oh, it's too little, too late. Certainly we would want to support every child and every family. But I think being able to have more of these wraparound supports is really important.
I asked that wondering how much of a drain past those 2,000 days is getting put on our schools and our teachers to sort of right the ship. How much resourcing is required from our teaching staff who are not, necessarily equipped to do this. How much of a drain it is on them at this point?
I agree. I'm thinking of a case example of a child who's now 7, but he presented at exactly that age of 5 with his child protection caseworker, who was worried. How was he going, about his behaviours? He had a lot of adverse childhood experiences, family violence growing up, housing instability. And just to point out that the NDIS was helpful in this instance, we initially were able to get him into early childhood intervention through community allied health. And then also NDIS were able to come in with supports. But as he had his assessment through our developmental assessment service, but as he turned 7, I think these are the concerns that we have, is that he would be moving out of the NDIS potentially as a participant, and that the therapies, for example, were able to be put into the school setting to help. So that is something that we could be doing to work with education, is to actually embed allied health and supports into education. Sorry. Dr. Kennedy, I think you wanted to add to that.
Thank you. Look, that's a wonderful question. We know that we now have decades of research from neuroscience and behavioural research that shows that the first 2,000 days are absolutely critical in determining future health, development, learning, on every health outcome. And we know that early intervention works. So the return on investment for intervention early, so there's something called the Heckman curve that describes the impact of early intervention. So in terms of when we're looking at the cost of services, we really should be investing early in life, in the first 2,000 days. The early childhood checks, which the college has previously provided a submission on, speaks to that, the importance of early childhood and screening, so that we're not left with children who have issues down the track that can take a lot more work to address.
Thank you.
Thank you very much. Unfortunately, our time has expired for this session, but thank you, Dr. Kennedy and Dr. So, for appearing today. Thank you.
Thank you.
I have representatives here from the Allied Health Professionals Australia and also from the New South Wales Nurses and Midwives Association. And we have some people appearing online and also in person. Before we commence with questions, I will need to ask each of our witnesses to state their name and organisation and title, but also to either swear the oath or take an affirmation, the words of which I understand are in front of the witnesses here today and has also been emailed to everyone online. I might start with Mr. Nichols.
Great. So I'm Anthony Nicholas, representing Allied Health Professions Australia, and I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Mr. Murphy?
Hi, yeah, my name's Dean Murphy. I'm here from the New South Wales Nurses and Midwives Association, where I work as a professional officer. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. And then we'll go to our witnesses who are online, starting with Miss Brodie.
My name's Lynette Brodie, and I'm the Chief Executive Officer of Speech Pathology Australia. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Mahoney?
I'm not sure. I can't see the unmute button. Can you hear me?
Yes, we can.
Oh, great. Thank you. My name's Carolyn O'Mahony. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Mrs. Oliver?
Hello, I'm Michelle Oliver, Chief Occupational Therapist at OT Australia. Apologies, I don't have the piece in front of me, but I solemnly and sincerely swear that the evidence given by me today will be the truth, the whole truth, and I'm hopeful that I've covered all of bits that I need to, but otherwise can if I need to.
I'm getting a nod, so yes, that's correct. Thank you.
Excellent, thank you.
And finally, Mrs. Callan. I'm sorry, I think you're still on mute.
Better?
That's it, thank you.
Hi. Hi, my name is Nicole Callan. I'm a child family health nurse working in Western New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. I'm also a member of the New South Wales Nurses and Midwives Association.
Thank you very much. Before we commence with questions, would any of the organisations or witnesses like to make an opening statement? Yes, we might start with Mr. Nicholas.
Great, thank you. And firstly, I'd just like to acknowledge and pay our respects to the traditional custodians across the lands that we meet today. All children and young people in New South Wales should have the right to access allied health services to support and optimise their development, health and well-being. For those experiencing developmental delay and disability, access to the right service, including allied health, can mean the difference between achieving goals and outcomes and not. We thank you for this opportunity, and we hopefully will be working closely with the New South Wales Government to make sure that every child and young person gets the chance to thrive. Allied health professionals currently deliver comprehensive assessments, facilitate access to assistive technology, and provide evidence-based implementations tailored to meet the unique needs of individual children, young people with development delays and disabilities. Evidence shows that a child's early years represent a critical development window. Once that development window is closed, achieving development outcomes is much more difficult, which we sort of talked about in the recent evidence. Feedback from practitioners in New South Wales have made it clear that not all children and young people can access the services they need. Targeted therapeutic interventions delivered by Allied Health are often only available to children and family that can afford to pay privately or have access to NDIS due to lack of funded alternatives. Where services do exist, long waiting lists and delays for assessment and diagnosis can impede timely interventions. Also, workforce shortages have an impact. ARPA recognises that New South Wales has begun investing in supports that help address these, such as Brighter Beginnings, but this needs to be supported by a broader system of accessible supports, including ones that improve identification in early years. A more efficient system will require focus on improving accessibility to allied health at all stages, from early identification to supporting parents through coaching and education, and developing and delivering therapeutic interventions that address physical, speech and other delays. To get that system right, the allied health sector must be engaged with collaborative co-design of future foundational disability supports in New South Wales. Working with the Commonwealth, New South Wales will need to fund and deliver a system of foundational supports based on a nationally consistent framework. The volume of funding will need to ensure that targeted foundation supports delivered by allied health professionals are a genuine alternative to those unable to access the NDIS or mainstream services, and that there is a choice of services for families and children. The establishment of these new foundational programs will need to define the skills, knowledge, scope, capability and needs for those different roles to ensure the best outcomes and most effective use of the workforce. And we can probably reflect on some of the recommendation from Professor McCormick's scope of practice work, which also helped map out how that can be utilised to maximise or optimise the workforce. To ensure children and family can access these services, new models will need to allow flexibility to engage allied health professionals, including those working in primary care or the private sector. We welcome the opportunity to talk about that collaboration and welcome any questions. And my colleagues online will have some great clinical examples as well.
Thank you very much. We might, Mr. Murphy, are you doing an opening statement?
I'm happy to go straight to questions and not do an opening statement. However, just one thing I'd like to ask. I've printed off an article. It's a 2-page article from our publication, The Lamp, and that is a story that includes Nikki Callan, who's with us today, was involved in a program to bring paediatric services out to the local community in the Far West. So I'm wondering if this could be tabled and given to you today.
Yes, it can.
Yeah.
That's fine. Thank you. Is anyone online would like to make an opening statement? No? Then we'll move to questions, and I might begin before I pass on to my colleagues. I might start with a question specific to Mr. Nicholas's submission. We have received evidence and heard from witnesses previously around the key worker model as being quite successful. However, in your submission, you've raised some concerns regarding it. Could you elaborate a little bit more as to why that model is not as good as something else?
Great. I might actually throw this to Michelle, who probably, or Lynn, who may be better at answering that question. So,
sure, I'm happy to jump in first, and then if you'd like to add anything. I guess with regards to the key worker model, it's not that it's not necessarily an effective model, but I guess what we're acknowledging is that everyone's needs are different. So with really complex needs, or where there's a lot of different services that are needing to be coordinated, absolutely that's valuable and beneficial. But what we don't want to see is that the key worker is in place of, the expertise of, say, allied health professionals or appropriately trained professionals to provide that, whether it's screening, assessment or intervention. So yeah, a key worker model definitely has a place, but a young child and a family may just need to see, the speech pathologist or an occupational therapist or a physiotherapist as, 1 or 2 sessions to support them to build capacity to do some coaching or knowledge building. It may not need that kind of broader piece. So I guess that's kind of the perspective we're talking to. Lynn, I'm not sure whether you wanted to add anything.
No, I think you've covered it. It does come down to the flexibility and the expertise that each of the allied health professions are going to bring to the table, especially around diagnosis, and that others may not be able to.
And that leads me, I suppose, to the next question, which is around that collaboration. And what recommendations or what advice would you have to see both from a health perspective, education, being able to work more collaboratively, and also then in with the services that are actually already being delivered, whether they're government or NGO funded, and that's to all witnesses?
I think this is a real challenge in the fact that, as we all know, we have an incredibly fragmented health and disability sector, state, federal, public, private, NGO, etc. And this has added to a real complexity of getting fulsome collaboration and co-design, and we've noticed that even within the NDIS. And I think as many disability services diminished with the development of the NDIS, what that meant was a lot of allied health who focused in this area went into private practice to work through an NDIS model. And I think now there is going to have to be, which is great about this inquiry, some real consideration into those diversity of places that are offering services for early childhood and disability now in multiple locations, because they probably are not going to exist in single, go to this centre and do that. That would be optimal, but most of those services are gone now. And so we need to think about models where there is true collaboration and co-design, which unfortunately in our health system rarely exists. It does within medical practitioners and within hospitals or tertiary settings, but rarely in primary care or in the broader environment. So it's the biggest challenge in our health system, we would say, to actually engage the full health workforce who can work with health or disability.
I would say, sorry.
Yeah. You go.
I would say similarly in the nursing workforce, speaking about the NDIS, nurses are currently more on the periphery of that, whereas, certainly child and family health, which is my background, and Nikki's on the front line there, it's somewhat limited in that nurses are often brought in for a specific purpose rather than being more central to that review process and being involved in using the tools that nurses use for screening, intervention, and then appropriate referral. So I think that needs to be looked at. In terms of access for parents to services, there's the idea that's being looked at quite a bit currently around multi-purpose hubs and having different services such as nursing, midwifery, allied health, medical services and so forth co-located. That happens to an extent, I guess, in community health centres, but obviously an expansion of that is being looked at. I'm aware of that and should be looked at. I think that's quite important. In terms of the nursing and midwifery workforce, as we know, there are workforce issues in terms of attracting and retaining staff. As we know, in New South Wales, nurses and midwives are the lowest paid in the country, even though the cost of living, particularly in this part of New South Wales, but more broadly, is among the highest in the country. So, we are losing staff to other states, particularly to the north and the south of us. Nikki, can I pass over to you to speak? Because I interrupted you.
Yes.
Thank you.
No, thank you. So I am a child and family health nurse working in Western New South Wales. I've been in the nursing profession for over 30 years, and within that time spent all of my nursing practice in rural and remote communities. So my role is to complete assessments, blue book checks, immunisations and referrals as necessary, working in partnership with our families. So that's quite detailed in what I do. So I actually refer to the allied health team all the time. I also refer to the NDIS with the allied health team all the time. I do have barriers faced every day with our families, from being in a rural and remote community to not having any access to any services. I know of one community that has no service, no allied health service, no paediatric service. So in the West, we are facing a huge crisis at the moment with nil paediatric access. So, you know, these children are already disadvantaged from living in rural and remote communities and then having nil access to paediatric or allied health services. So in our local community, we worked really, really hard together with every service in the community, from our schools to our health to our GP centre, and created a fly-in, fly-out service with Little Wings, fully funded with no cost to any of our children or families, the gold standard of face-to-face delivery. And, you know, it is successful. We have children being seen, children having diagnosis, children having medication to attend school and support services in place. But sustainably, we're doing this, with, really limited funding. So this is a perfect opportunity for the government to look at this and go, you know what, this is an excellent model where all services are working together. And where there are rural and remote communities without allied health, we're working with, the Fly to Health team that will, help provide those allied health services, speech, OT and psychologies to these rural and remote communities. Every child deserves a right to access healthcare and allied health and paediatric services. And if we do not do something now, we will have poorer health outcomes, poorer educational outcomes, poorer job opportunities.
Thank you very much, and also thank you for the work you do.
And a financial deficit for our region. Now, we are working extremely hard in our communities, and we are doing this with one child family health nurse and one CEO of Little Wings, to make an amazing difference for our communities. We have to act now. We don't have time. We don't have tomorrow. We don't have next week. Children are ageing, and Australia has to stand up and take responsibility for what's happening in our rural and remote communities.
Thank you, and thank you everything that you do, and also with Little Wings. I've got to say I'm biased, having been a registered nurse, so I appreciate particularly everything you're doing in rural and regional areas. Is there any other witnesses online that would like to make answer anything further with that question? Yes.
Hi, Carolyn O'Mahony. I'm a titled paediatric physiotherapist, and I'm the National Chair for the Disability Group with Australian Physiotherapy Association. So I work in a few places. One of them is a GP practice, another one is a paediatrician's office, and a third one is a paediatric physiotherapy clinic. So I think to the points you've already heard, often the children we're seeing who would fall under the foundational supports category are presenting as a movement concern or often a feeding concern. So often physiotherapists are the first practitioner they see, or the maternal child health nursing system or lactation consultant are where these children are presenting. And it's often a teasing out of what's happening and trying to get these children support, trying to get them referrals to paediatricians. Sometimes they do come from paediatricians, but it's often a process of getting those supports in place for them. They are not, there are many children who present that are not eligible for the NDIS, but do have significant issues with feeding or moving. And it is really critical to get to them, as has been described today, before the developmental windows close, those critical developmental windows close. We know there's neuronal pruning that happens around 6 months of age, where a lot of neuronal connections are lost in the brain. And if we're not getting in and helping children move or helping them learn function before that happens, it's much harder to then retrain it and gain that back once it's been lost. So it is, we all in this industry feel enormous time pressures of helping these children when they're in these critical stages of development, and knowing that if we can achieve that, we are preventing the severity of their disease or their delay or their for their condition. So just wanted to add that further. Thank you.
Thank you very much. I might hand to my colleague, the Deputy Chair.
Thank you. And thank you to all of you for making the time to appear and for your submissions. I have personal experience of having had one child in the UK and then having another child a couple of years later in Australia, and I experienced a very different situation when it came to nurses and midwife care in the UK. I note that in the nurse midwife submission, there is comment around this UK health visitor model. Can you explain to the committee what that model is and how we could implement it here?
In terms of the detail of the model, I'm happy to take that on notice and provide more information. However, what I understand of the model is that the nurses over there have increased referral rights, for example. So an issue that we come across here, particularly in rural and remote areas, is the issue of access of both for nurses and midwifery to GPs, for example, or the medical profession, in having to make referrals via the GP, for example, to specialist services such as paediatricians and so forth. Certainly, that could be something that we could look at here, giving nurses, because nurses working in that area have extra training and assessment tools and skills that they possess. So that's something that we should look into, and that's not to replace in any way the medical the GP. For example, nurses are very good at referring and collaborating and communicating with GPs, but particularly in areas where there are shortages, that can lead to significant delays in children that need to be seen. And as we've heard from a number of witnesses today, particularly in the first 2,000 days framework, early intervention and getting in as early as possible is vital. Another aspect in the UK, from my understanding, is the being able to have certain prescribing rights that's related to the work that they're doing from a limited formulary, but I'm happy to provide further information on notice.
Thank you. One of the sort of themes that's been coming through in the submissions is the difficulty navigating support and services for parents and carers when they're looking at sort of where they go, and also you don't know what you don't know, and if you're especially if you're a new parent, you just don't have the knowledge to understand whether early intervention is required, often until it's later than you would want. Certainly my experience in the UK was that the nurse that would sort of come around and come into your home would not only be checking on your child, but on you and a bunch of other things, and was a very good source of referral to say, well, have you thought about, seeing this service, or there's a play group over here, or that's something for your GP, or whatever it happened to be. It sort of seemed to fill that gap. Is that something of some form that you are sort of recommending?
Definitely. Like it's already happening, like central to, and my background's in child and family health nursing, and one of the central components of that role is exactly as you've described. So that is happening now. I guess the issue is that needs to be expanded, so that role could be expanded in terms of referral rights where needed, and certainly access. So I guess the issue is twofold. So if we have a staffing issue, which commensurate pay, for example, with other states could help with that. Increased funding for further training for these nurses and midwives. I know it's been looked at, and some part the way they're particularly for undergraduate nurses in terms of paid clinical placements, but I think that could be looked at, for example, at postgraduate level. It could be important, but until we fix the staffing issues for in the nursing and midwifery area, that's going to provide an impediment to access for these families. But on the other side, you know, there needs to be access for these nurses and midwives to refer people to. And as Nikki's illustrated, in rural and remote areas in particular, that's quite an issue, where they're often in a position where they've done the assessment, they know who the child or these children need referral to, but there's nothing on the other end. Yeah.
Thank you.
And the same probably applies, exactly the same in allied health. It's that ability to refer on, or particularly where there are GP shortages, of that becomes the barrier for people accessing other care, because it's so dependent on the GP or a medical practitioner being that next step to get anywhere else.
One thing I would like to add that I didn't quite get to is that nurses are quite central in terms of, and you alluded to it in your experience, that nurses are often at the forefront or the front line of where they're a pathway to pretty much every other service out there. So, you know, nurses and midwives working in the child and family health arena are really a great resource, in that if they're central to that, then they can identify the needs of the child and identify where that child needs to go, not just for other services such as allied health, the GP, paediatricians, physio, OT, speech pathology and so forth, but they just have the skills to identify that, to refer appropriately, but also things like services such as supported play groups and you know, services such as that, or just general play groups and networking and linking families with other families and things like that. Yeah.
Thank you. Can I just ask one more question? Just given the importance of the involvement across kind of allied health and education and disability services, to what extent has either the federal or the state government engaged with allied health professionals to consult on what foundational support should look like?
This will sound slightly negative, but generally allied health are treated exactly, they're allied over there, and we'll talk to you last after we've designed the whole system. Not always, but most frequently we have to do what about 200,000 allied health that are working across the country in all these different environments? So it is a real challenge, which is why we really appreciate being here today and talking about it at the start rather than at the end. It is a real challenge, and partly that's challenge because we're talking about 30 plus professions, a diversity of scopes of practice, a diversity of working in tertiary care, community settings, education, you know, private care, etc., etc. So it's very broad. So we understand it's a challenging sector, but it's generally been where it's almost like, oh, we'll consult on this little bit here with this particular profession because they're maybe the larger profession that works in that space, but not thinking about the broader sector or that broader workforce, which is again why that scope of practice review and some of the other reviews going on talking about those overlapping of scopes and how we can optimise the workforce for people, particularly in areas of high need or market failure.
Did anyone online want to add?
Yeah, could I just quickly jump in on that? I think we've been trying very hard to I guess, pretty proactive in this space, especially with ever since the recommendation around foundational reports came out. There's been a lot of anxiety amongst the disability sector as well, and it's often the allied professionals who work so closely with or, you know, individuals and their families, they're turning to us to ask questions, and we're feeling like we are being closed out of any sort of decisions or opportunities. We are very open to collaboration. We would like the opportunity to engage and be part of designing and working with state and territories and government to look at how we can best design models to meet the needs of young people as early as possible, and keep people out of hospitals, out of the scheme if that's not where the needs are going to be. So we are very willing to engage, but it's been challenging so far.
Thank you.
Thank you. I might pass to Mr. D'Adam.
I wanted to ask about issues around allied health access to schools. I know the Royal College of Physicians in their submissions suggest embedding allied health in schools, and I wanted to perhaps ask the witnesses about the pros and cons of that particular approach, but also the issues around access as it currently stands.
Yep. And there's a couple of representatives online whose professions work quite a lot in education, so I might throw to Lynn, Michelle or Carolyn.
Yeah. So obviously speech pathologists do work in the education space quite a lot, but I have to say it's not necessarily consistent. Often it does rely on a school principal that has a real passion and is a champion. So there's very diverse systems that work in. And I think there's what we need to look at in the system is there is opportunity certainly for group work with a small group of children, but then there's also the need for specialist services for a child that's going to need and require other help and assistance. In fact, I did have a case study from a young child that was having a range of communication difficulties, and unfortunately the speech pathologist wasn't able to engage in the school environment, and that caused a whole lot of issues. So we are involved, but it's very dependent on principals.
I'll just add to that as well. I think it's really varied across the country, and unfortunately in New South Wales there's much greater barriers. There's far less allied health employed within education in New South Wales than any other state or territory. Certainly there's some states and territories that are more so leading the way in terms of employing allied health within education. But we do work from like a tiered system or a tiered approach to care within and across education. And when we talk about education, we talk about all the way from playgroup to kindergarten to preschool, childcare, primary school, secondary school, and above. There's value of having allied health employed within the school system to work either directly with the child, work with the educators, or work with the whole community to build capacity, whether it's about adaptive environments, coming up with strategies to support children to engage or even to come to school, but then work and learn the most out of schooling. And then there's also the private sector who provides support and that kind of in reach. So a child might be working with a therapist, and part of that kind of really collaborative or comprehensive care and holistic approach we take, we want to work with the individual within the environments that they are, their natural environments, and school is a pretty critical place for young people. So those private practitioners often experience barriers, and so education is hard in this system. The public, is the independent school system, and the Catholic school system, and they all have different approaches. And as we pointed out, unfortunately it comes down to the principal, whether they can understand the value, the opportunities, and want to create those pathways, and that's really just not sustainable. But I would have certainly urged New South Wales to look at the opportunities of employing allied within education, because then systems can be built that they better support either individual therapy or that kind of change or capacity building within the school community. We certainly, as allies, don't want to take away from the educator role. That's really critical. We know that it's such a challenging role at the moment. But if we can add value to support engagement, manage challenging behaviours, meet sensory needs, then there's great opportunities there. But we also have a whole cohort of young people who just can't go to school as well, which is critical. So, yeah.
Could I Could I just say something? So in rural and remote where I am currently working, in 2023, we had 12 children out of 22 kids starting in kindergarten that had severe speech and other concerns. We have a massive need out in the West. The school is now working with speechies and OTs and the paediatrician to overcome this. There is a huge need. We have a high Indigenous population, so we've worked with other services and resources to gain books. So Dolly Parton Imagination Library, Indigenous Literacy Foundation to bring books into children's homes to help these children and to really push the reading and referral rate for services. It is about community working together with all the allied health and with the paediatrician as one. We can't do this separately. We can't do this just by ourselves. We have to all work together. And I believe communities will do whatever they can to help their children.
Can I ask you, so if we did adopt a model like this of embedding allied health in schools, do we have the workforce to be able to implement something like that?
Depends on the region, and all the areas where of probably highest need are the places where, as we know, there will be less workforce. I think partly that was also facilitated by the NDIS funding model almost, and a reduction of state-funded disability service that encouraged allied health and others to move into almost this private provider model that's funded by the NDIS, which meant they either were restructured out of state-run or state-funded schemes and into that model where they've now moved into. But for that to work, clearly they have to be in areas of need where people either have NDIS funding or can pay, which has probably just further exacerbated workforce issues. So workforce is a huge challenge for disability healthcare and these expansions, but there also are a lot of allied health being underutilised because of the way most funding models are structured. Most cannot use their full scope of practice because no one other than a patient will pay them for that. Right. So it's a barrier to patients in need.
What's the solution to that kind of misalignment of resources?
I think there's dozens, there's not one solution, there's dozens of little things that could change, and that's both at state and federal and across different ways, in the fact that, many allied health basically are trained to do certain things, but then whether it's Medicare or the NDIS or other funding models, don't allow them to use some of those skills because different profession may be funded to do X, and so obviously that's where consumers will go because that's where they get the subsidy from, even though there may be 20 other professions also prepared to do that. I think it's also mapping what people's skills are. I think there's very little understanding, even within health professions, of the scopes of practice of other professions. They know some of them, they may have an idea of what it is, but there's almost needs to be this much better understanding of what is the full scope and knowledge of all these different professions and their role within healthcare or disability or education. And I think the overarching one is we've got this fragmented. There's the private health sector and private health insurance and what it will fund. There's Medicare, there's the NDIS, then there's state services and NGOs, etc. And so it is incredibly complex for the average consumer to even know where to go. I think it's got to be multiple things, and certainly for allied health. So using New South Wales as an example, New South Wales has this amazing agency of clinical innovation, and the only people who can access its great resources and training and other things, even though it's been government funded, are people who are employed within tertiary or public health. Even if they don't even sell it to people outside. So all those people servicing New South Wales for better healthcare can't get access to great training and resources that's been funded by the government because they're not employed within a hospital. It's very much the department sees health in New South Wales is who we employ within hospitals or within our systems, and not much outside that.
I'm going to hand to others.
Thank you. I think Mr. Barrett had one question before we conclude.
Sorry, the last couple of minutes has opened up the possibility of many questions. But Ms. Cullen, I just wondered to you, you talk about the school sort of picking up a little bit of the load, everyone's sort of chipping in together, but how much resourcing is going from the school to these areas that could or should be picked up by allied health that is then being diverted away from some of their other functions?
So I'm not quite certain with that because I only look at the 0 to 5 space. When we were looking at getting a paediatric service and working with our allied health team into our community, we all worked together to find a solution. So I'm not sure financially how much is going from the education department into the allied health. I do know that the community that I'm looking at the moment has employed a speech therapist and an OT therapist. The actual local Rotary service is also doing a massive fundraiser to pay for speechies and OTs and paediatric service for the community. Now, this shouldn't be up to Rotary. This should be actually covered by the government. This is our children that we're looking at. So this is a community trying everything to help supply the OT, the speechy and the paediatric services to the local community. So we have a dinner in August and we're hoping to raise $50,000 just to start to help further the speechy and OT services in the schools in the community. So it's a huge need.
Thank you very much. And thank you for your passion and commitment to this as well.
Can I just say one more thing? We didn't talk about our Indigenous engagement with our families. So when I first started in the communities I work for, there was a 12-month and 18-month workforce gap across the child and family health sector. So I've worked really hard. I wasn't known to the community. I worked really hard with our Aboriginal health worker. We created engagement projects such as our Bellies and New Life to engage our women early, to then provide ongoing referral services. So what's happening is our women are being engaged while they're pregnant. They're then coming back to us for ongoing services and they're more comfortable to access our care. And therefore, they're coming back for immunisations. We're picking up, any delay early for our children. We're linking them into the NDIS. We're linking them into the paediatrician and we're linking them into the allied health team. So nurses are so well placed to be the main referral pathway for all of your services. And because nurses and child and family health nurses work directly in community, they, know what's needed, know the gaps, and know the mapping that's available in their communities.
Thank you very much. Unfortunately, time has expired for this session, but on behalf of the committee, I want to thank all of you for the work that you do supporting local communities, but also particularly families and young people as well. So thank you very much for appearing today.
Thank you very much.
And we'll now have a short break and resume at 11:15. Thank you. think we're ready to start. So thank you very much to everyone who is appearing today. We do have a couple of members who are online, Mr Scott Barrett and also Mr Mark Buttigieg. But before we commence with questions and opening statements, I will need to ask each of our witnesses to state their name, the organisation they work for and their position, and either swear an oath or take the affirmation, the words of which I understand are in front of you. And we might start with Ms Eakins.
Aikens,
Thank you.
Hi, my name is Kylie Aikens and I'm a Parent Peer Hub Leader at Plumtree Children's Services in Marrickville, Sydney. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Yes.
Hello, I'm Silvana Marmick. I'm the CEO of Plumtree Children's Services, and I swear that the evidence now that I'm about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much.
Hello, I'm Emily Casca, CEO at Playgroup New South Wales, and I swear that the evidence about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Miss Hester?
Yeah. I'm Ellen. I swear. I'm Ellen Hester from Playgroup New South Wales. I swear that the evidence now about to be given by me and shall be the truth, or the whole truth, and nothing but the truth. So help me God.
Thank you very much. And before we start with questions, would either of you or any of you like to make an opening statement?
Yes.
Yes. Thank you.
Thank you. As I said, I'm Silvana Marmick, CEO of Plumtree Children's Services. Thank you so much for the opportunity to contribute to this process, and I acknowledge the traditional owners on which we're meeting today on their land. I'm here with Kylie Aikens. We are both parents of children with disability and bring lived experience to this inquiry. My son is now 35 years old, and my entire career I have spent in early childhood intervention based on my experience with him. I'm also the CEO of the community organisation that I run. It's a not-for-profit child and family organisation that has supported children with disability or developmental delays for over 40 years. We are also an NDIS provider, but today I'll be focusing on how we build capacity for families of children with developmental delay and disabilities using peer-led approaches, and in particular our approach called Now and Next. Since 2015, we have delivered the Now and Next program, which is a peer-led capacity building program developed and co-designed by families for families. The program equips parents to take the lead in their child's journey, building their skills in goal setting, decision making and self-direction, increasing their hope, empowerment, well-being and goal achievement. It is delivered by trained parent peer workers and paid parent peer workers with lived experience, and over 2,000 families internationally, including in Australia, have participated. Foundational supports like Now and Next program are critical for parents of children who either have an NDIS package or do not have an NDIS package. Such programs build the capability of parents, which in turn improves outcomes for children at a much lower cost than therapy. But as we have learned through our national evaluations, when such programs are not free, parents will prioritise therapy for their child over building their own capability. In our evaluation of 1,008 families recently, in a period of 36 months, who participated in Now and Next, they did not have NDIS funding. Many entered the program with lower levels of hope, empowerment and well-being, and were more likely to disengage compared to our benchmark. They were more vulnerable, that is. However, when they did participate, they made more significant progress than our benchmark, showing that programs such as this work even when the families are overcoming incredible obstacles. We also know this approach is highly cost-effective. A cost-benefit analysis using a New Zealand government model found that the Now and Next program delivered a return of up to $4.70 for every dollar invested, including positive returns to government. What this means is that peer-led programs like Now and Next, they offer real values, not only for families, but also for government and the wider community. They are low cost, but they are far-reaching and lasting in benefits, making them a smart investment for government. Peer-led programs like this also grow the workforce, which is under pressure due to the NDIS and increased reliance on therapy. Through the Parents as Peer Leaders project, for example, we supported 33 parents to become peer facilitators. Many are now working in the sector and leading in their communities, showing the untapped potential of parents as powerful contributors, not just as service users when given the right supports. We urge the committee to recognise the importance of peer-led, non-clinical foundational supports in enabling earlier access, greater equity and long-term service sustainability and system sustainability. If we want to strengthen outcomes and reduce demand for intensive services, we must invest in building the capability of parents and make these services to those parents free. Thank you.
Thank you very much. Ms Casca.
I'm actually going to go to Ellen first, if that's okay. Your voice is more important than mine.
Okay. Thank you for the opportunity to share. Thank you for the opportunity to share with you and my story and why I'm so passionate about it. I am on the NDIS. However, my life is not defined by the NDIS. When I look back to my childhood, there was no NDIS, but that didn't mean that I didn't get services supports back then. Much of the supports for me and my family were through the state government. My Down syndrome means that I do need some additional supports, but that didn't mean that every person with Down syndrome has the same needs. We are people first. That cannot be forgotten in this inquiry. My mum is a speech pathologist and she supported me when I was young, lucky me. But every child who needs this should get it as early as possible. As a child, I would also join my mum at work with other young children and babies. I would see firsthand the huge impact on children in the early years. Research shows us the earlier the better. I remember seeing baby sign and speech tips with parents learning together. I would help a lot as a mentor. I would show children how. All children have families, parents, siblings are just important to support. When I was young, my mum got peer support from other parents, meeting together, supporting each other and sharing knowledge. I know from my experience and talking about my mum that place-based group services and supports are just impactful and just as needed as individual therapy. That's why I'm super proud at work at Playgroup New South Wales in our team of over 90 staff and 650 volunteers. We support a whopping 74,000 children and their families from prenatal to school age across 99% of postcodes in New South Wales, making sure they get the very best start in life. We are not an NDIS provider. Each year, we run 26,000 playgroups and 2,000 peer support groups and parent capacity programs. The best part is they are all local and free. I am really proud to be a role model what a great early intervention looks like through my lived experience without it. My life would take a very different path. I would be more disabled, not enabled. I had a very, very full and fun life. I have 3 jobs at Playgroup New South Wales, at University of Sydney, and the Sydney Swans women's team. Despite what people might jump to think, none of these are supported through the NDIS, and I can do this myself. I can travel to them all myself. I have a boyfriend. I take a certificate in health and fitness. I play netball and I have a great social life with my family and friends, just like my sisters. Soon, I would like to move out of home as my next adventure. I am a great example for the opportunity that this reform brings. Get it right early to fight later. Perfect can't be the enemy of good. Playgroup New South Wales is a great example of financial supports in action, ready to go, plans-based, self-entry point, child, family and community. My friends and I would have a disability, want to make political. I'd just like to see all children with a disability get the best start in life, like I do so. One day, I won't be the only person with an intellectual disability sitting here before Parliament on reforms that directly affects our lives. A seat at the table is great, but wouldn't it get to have people with an intellectual disability as members of Parliament too? Let's get it right early to fight later. Thank you.
Thank you very much, Ellen.
Thank you. And I mean, honestly, what can you add to Ellen's? And here for me to have a formidable colleague in Ellen, a woman with an intellectual disability here presenting in the House of the People and representing those voices. And I think Ellen, for us, has really nailed the essence of what this is about, and I won't go into too much detail, but not all children with a disability need to go to the NDIS. And unfortunately, I think we're in a system at the moment where the construct is it's the NDIS or nothing. And for all best intentions, I think that's become more exclusionary. But I think if we dig down to the layers of where we sit, not all children with a disability also need very individualised early childhood intervention. We see that every day in playgroups and in the great work that Plumtree and our partners and others do. So too, not every child with a disability needs targeted foundational supports. There are things in the community and the general space that we know that not every child with a disability needs to necessarily be an adult with that same disability or developmental delay if we can get some of those early interventions right. And the social model of disability will surely tell us that. And so too, in our own context, some of those biases is not every child with a disability needs to go to supported playgroups. We really proudly run 650 community playgroups each and every week, run by parents in those local communities, and they too need to be just as inclusive of and responsive to the needs of children with a disability, with a delay. Playgroups are absolutely one of the earliest place-based soft entry points that every child and family will access across New South Wales. Like Ellen said, we run 26,000 playgroups a year. We're in 99% of New South Wales postcodes, and by and large, except for some community playgroups who need to pay the bills, we are free. And we are there from the earliest point, and we do also reach in the prenatal stages. And I think with playgroups, what's really unique, probably as opposed to many other models in the early years, is our co-participation model. The parent is there with the child. We absolutely love the work of ECEC and other sectors, but they're there in that co-participation model with their peers, and that really, we think, is the power of playgroups, and particularly the power of parent capacity building. But beyond playgroups, as our submission shows, we also run 2,000 peer-to-peer support groups through my time across New South Wales every year, and we also have a really dedicated parent capacity building hub. Now, also, many could probably argue that playgroups themselves, because of the evidence base that actually does sit behind them, are a parenting program and parenting capacity, but there is no way I'm about to go out to families to say that because we want to maintain that local soft touch. And we think that foundational supports are such an opportunity to finally get this right for children in this state and across this country, because we need health, disability and education to absolutely come together. And when we say children with a disability, I don't mean those with a diagnosis, particularly in these early years. For us, the first 2,000 days, particularly the first 1,000 days, disability, delay, just parents saying, I'm not really sure, my child isn't keeping up. It shouldn't be a diagnostic test. And what we're also excited about is, to my earlier point, I think we can finally bridge this long-held gap between the NDIS or essentially nothing, which so many families tell us. And I think we all here know the why. I think we would really like to, and our submission focuses a lot on the how, not that I have all the solutions, because there are a lot of things and there are a lot of green shoots there to scale, obviously playgroups being one of them. We don't want foundational supports to be another system inserted within a system. The passion, the capability, the capacity is there. It's the resourcing and the investment that actually is needed. And in this, I think I caution as well, foundational supports, very passionate about it, but it cannot be NDIS 2.0. It cannot just be seen in the lens of the kids coming off the NDIS, and that's who foundational supports is for, because I think that would be a missed opportunity if it's just an off-ramp. But so too, it can't also be seen just through critical individual early intervention, which Silvana mentioned as well. It can't just be about diagnostic support and health-based therapies. Foundational supports have to meet the needs of all children who need assistance. And as a non-NDIS provider, we would argue in what we see, particularly in our integrated Aboriginal hubs across New South Wales and other areas, there are children out there who are the most vulnerable and marginalised who aren't even getting any services and supports. And we need to start from them, not the lens of looking at who's coming off the NDIS. Very, very quickly, in terms of what's needed to make it work at a high level, the voice of children and families has to be at the centre, full stop. And I think there's a lot of improvement that we need to do there. We do really want a clear and shared definition, and including not just what foundational supports are, but what are those interface points? Again, not just with the NDIS, but mainstream as well, because that's a bit missing at the moment. We do need a nationally consistent but locally responsive approach, absolutely. There needs to be fluidity and seamlessness for families and for us as providers. And I think if you take an example of a family that might need some really targeted high-level NDIS-based services, the family also needs peer support. They might also come to a supported playgroup and also want to go to a community playgroup. How are they going to traverse those systems? How many eligibility assessments are they going to have to go through? And for us as providers, how many different standards and accreditation processes are there going to be? And so that's a bit of a caution. I think also probably from a government lens in this inquiry, and I saw the briefing paper, a really solid understanding, yes, of what's been delivered now, but where's the unmet need and demand? Because I can tell you absolutely every single playgroup we have is high demand. We are not meeting the need. We could double tomorrow, without a doubt, absolutely, to the point where we've had to, in some of our playgroups, make parents register, which goes against the very ethos of playgroups, because for some of them, and I know the Shadow Minister attended one, that's one where we have 120 families coming sometimes, mainly from a culturally and linguistically diverse background, and we can't cope with that sort of demand. The other part is also probably on the provider side, investing in quality providers and taking a more relational commissioning approach rather than the transactional model that we've all been under to date, and some more timing with some of that would be very appreciated, because providers like Playgroup New South Wales, like Plumtree, like our valued partners, we need to be here to deliver them, and sustainability is needed now. It is at urgent point. For us as well, there must be a focus on place-based, community-led and peer support models that really do link into primary and allied health, but primary and allied health can't be the first port of call. We do think that that soft entry point in community is important. Probably not surprisingly, yes, workforce development, but our lens on that too is the volunteer workforce. I have 650 volunteers. Again, I could double that overnight, many of which are parents. And also we want to see people with a disability, people like Ellen mentoring what this looks like in the early years. There must be a focus on outcomes. And I think we're all looking at, just getting it implemented, but what will it look like when it's there? What's the data sharing, the outcomes reporting, and having open data sets? And finally, we would love to see that foundational supports at both the state and federal levels has a clear agency leading it. I do absolutely love the collaborative approach, and a clear minister that's driving this. Thank you.
Thank you very much.
Can we just have that? Can we have all of that?
If you could all do that, that would be wonderful.
Before I hand over to Deputy Chair for questions, I just have one, and follows basically your last statement around that collaboration. And we've seen a shift at a Commonwealth level. NDIS ministers now under health as opposed to the social service sector. We know governments aren't great working across different departments and agencies. How do we improve that collaboration, whether it's from a DCJ, education, health, but also more importantly with communities, so it is community-led, and with NGOs and the service providers? What needs to be, I suppose, addressed? And that's to both of you.
Prior to the NDIS, there was an ageing, disability and home care service funded called the Early Childhood Intervention Coordination Project. 13 regions across Australia got $12,000 each to have a coordination function. Each of the government departments involved with interfacing with children and services who had developmental delay or disability received that funding. That group brought together everybody in that region, regardless of whether they were government or non-government, and the whole function of it was collaboration and coordination. Each committee had a little incentive of the $12,000, and that brought people around the table to brainstorm what was going to be locally suitable, responsive to local needs. We've lost that collaboration and coordination now. Things have become much more siloed with the NDIS and with governments in New South Wales pulling out of provision of services to children and families where there's a delay or disability to a very large extent.
Thank you. Ms. Casca?
I think the only thing I would add, and absolutely here because I remember that, is the voices of children and families. And I think for too long the sector sort of thinks that providers or services are on the other side of the equation to services and families, but we are the ones that they trust. And so I think utilising us and our networks and through the Child and Family Supports Alliance, which we're all members of, to make sure that we are hearing the voices of children and families, and so too giving them the information. I would like to see, I think, as to my last recommendation, a single minister really start to take this on. I know the Cabinet Office, Health, Education, DCJ are coming together, and I did hear Anne Campbell and Gill speaking, but I think we would like, as a sector and probably as a family member myself, as a sibling of someone with a severe intellectual disability, who is the go-to, who's really championing and guiding this, because across all those portfolios I think we run the risk that this could just be quite far down the rung because they obviously have so much else, so we really want to see it land somewhere.
I agree, Emily, and I think that with that former ECICP committee, parents were welcome to those groups. So there was a parent representative, Kate McNamara, whose daughter Bridget Kelly is an acclaimed artist who happens to have an extra chromosome, and she was the ECICP parent rep for many years. There's absolute value in bringing families and professionals together. The work of Plumtree since 2015 has been to really demonstrate that we really need to increase the level of involvement that parents have in co-design, in service co-design, within organisations, within program development. Parents can offer so much. Of course, children can as well. Our age is birth to 8, so that can sometimes be a challenge, but the parents themselves definitely have got so much to contribute to service design, and our evidence has been to show that it's not just an idea. We have shown that it is possible to identify, train, pay, support parent peer workers within an early intervention organisation, and we feel that model can be scaled up, and we feel that model should be one where, like in the mental health service sector, you wouldn't be able to nowadays go to a mental health service and receive professional services without a person who has a lived experience of a mental health concern in that organisation. Why is it different to early childhood intervention? Wherever families land, through whatever door they enter, whether it's health, education, maternal, child and family health, as we heard this morning, wherever it is, parents should be employed as a parent peer worker. There should be allies for parents to connect with wherever they enter through.
Thank you very much. Deputy Chair.
Thank you so much for all of you for coming. And yes, Ms. Casca, everything you said was everything that I had been thinking but unable to articulate. And I think it's just particularly around the needing to be relational, not just transactional, place-based, community-led, and this kind of what's become the norm towards this individualised, targeted support under the NDIS versus this playgroups and other community-led initiatives that really adopt that sort of social model of disability and are far more inclusive, and I would argue going to have better results. Playgroup New South Wales, my understanding is that it's it's community-run, family-run playgroups that you're supporting, but my understanding is that there's now some private players coming into playgroups or offering playgroups. Can you tell us about that? Is that true? And sort of who are the people offering those, and how is that impacting on the work that you're doing?
There is. So we do both community and supported playgroups, and we've been around for 50 years. And so we traverse a few levels. Peak Body for New South Wales, biggest community playgroup provider, not just in New South Wales, but across the country. And then the supported playgroups have also increased in recent years. So we either provide them directly or we subcontract to our valued partners. And then on top of that, we're also the lead contractor for peer support through My Time and Parent Capacity. So we do all the things plus national research. Are we the only person in New South Wales that provides or contracts out playgroups? No. And do I want to be or should I be? No, that's a bit selfish. So where there are lots that pop up in church groups organically or through other organisations are running playgroups, do we think as a sector, and it's some work we've been doing, that we probably need to come together and better articulate the value of playgroups? Yes. So in August this year, we're launching the New South Wales Playgroup Collective to be that umbrella, but not necessarily the owner of it all. I haven't heard of too many private for-profit providers coming into that space, so I'd be keen to learn more if they are. But I do think where we need to come together better as a sector is to better articulate what the evidence base, what is this magic model of playgroups, and where do we sit when it comes to particularly marginalised and vulnerable people, and in this case children with a disability. And what is it, we're doing some pilots as well, what is it in our model that really is that magic source for children with a disability? So Ropes Crossing in Sydney, great example, where we're parachuting in allied health, because we are hearing from families either they can't access or the format of that individualised therapy not working for them, and it's not really building anyone's capacity, it's too transactional, and it's not a therapy session within a playgroup by any means, much softer touch and benefits all in that group. So that's where we sit in the sector.
I'm hearing that there are some of these ECEC players that normally would run sort of childcare, early learning centres, who are now offering like a fee for playgroup. So that's why I sort of asked whether you'd been aware of that, because I thought that was quite an interesting development. But
yeah, interesting. I haven't heard of the fee component. We do know that either schools or EC providers will provide playgroups, and some of them we do partner with some caution. So we do co-locate with schools as community centres as part of New South Wales Government Start Strong funding, and that's been a really successful model. We find particularly sometimes for children with a disability, so they can have that leeway into school, get familiarity, so to the parents, they can meet the teachers and the principals beforehand. But by and large, is that the full model we're going for? No, that works for some communities, absolutely doesn't work for others. So too, we do work with a range of ECEC providers and ECI disability providers that will also co-locate playgroups, again, because they are already trusted spaces, or it does serve as a natural segue for those families. But I'll definitely like to hear if they are charging fees and using it as a commercial model, because that is absolutely a risk, and we wouldn't want to see it used as that, like a sales pipeline or a commercialised model. Absolutely not. And also overall, it needs to be underpinned by evidence and best practice.
In terms of, I guess, then the funding and the way that playgroups are, I guess, the way that people are made aware of a playgroup in their local area, did it used to be different pre-NDIS to what it is now? How do people know that playgroups exist? And was it, I mean, I've heard, we talked before about the funding, sorry, I wrote it down and now I can't find it. The potential funding for communities to come together, that $12,000. Is there anything like that now? How do people find out, and what are we missing out from that we had previously?
Great question. I'll probably answer it in three parts. How are we funded? By every department known to man, federal and state. So it is very mixed, and I think, in part to my earlier point, playgroups aren't going to be the top macro policy priority in the disability department, health or education, yet we are so critical to them all, and as well as communities. And that funding construct hasn't necessarily changed. It's always been fragmented for the playgroup sector. Pre-NDIS, how did people know about playgroups? Probably most importantly through maternal, child and family health nurses, and probably a stronger connection to health. And is that still there? Absolutely. And we also, as Playgroup New South Wales, have a Find a Playgroup by postcode on our website. And now we've also probably introduced the other layer of a bit warmer support. I don't want families just putting in a postcode and going off to a playgroup. How can we help them understand you might need some peer support? We've got these webinars and real wrap around the family. In terms of how has the NDIS impacted it, I would think that a couple of things that, and I probably speak from my time with Down Syndrome New South Wales, we know of families in hospital who are being handed the NDIS booklet and being told that's where you go now. So it's probably to my earlier point, that system, as well intentioned as it is, has become exclusionary, and so families just go down that path and wait far too long than they should for their assessments and their eligibility. And if we're lucky, playgroups will pick up the pieces, as much as we're still doing all of the work that we're doing. But this inherent bias, I think, has definitely crept in. So too, parallel to it, I don't know if it's as a result of the NDIS, we have seen the growth of the supported playgroup funding and programs and agenda. And again, I get funding for those across a range of streams, federally and state. We would like to see that come back together. And it's probably, again, to my introductory point. And I'll be honest, probably something we've had to address in our own organisation, that if a parent of a child with a disability calls us, we don't just go, oh, great, you go to Play Connect Plus because you have a child with a disability. And so we're being really explicit in addressing our own bias. But again, we are seeing this split that I would argue that community playgroups for parents of children with a disability are sort of seen as the lesser cousin, and that there is a preference for the supported playgroup model. So I don't know if that's because of the NDIS, but it's that same sort of bias that's coming in.
Thank you.
Could I talk about my experience?
Yeah.
As a mother, my children are now 12 and 15. But at the time when my son was first diagnosed, I was funneled into a supported playgroup that had a multidisciplinary team, and I didn't know what I didn't know. So I was lost in that system, and I'd fallen through gaps, and that playgroup supported me. And then the rollout of the NDIS was coming, and that meant that playgroup was shut down very quickly, and I was left just in limbo. I was very, very lucky to have found parent capacity building program led by parents at Plumtree Children's Services with the Now Next program. And very quickly I realised that what I'd been looking for was parent capacity building. My whole family needed parent capacity building. It's not just the parent, it's all those people that are caring for the child. And Plumtree Children's Services were offering that through the Now Next program. It was funded so I could do it for free. My husband and I both did it, and it was life-changing. It changed our whole lives, and I decided that I wanted to be a parent peer worker. And in that time, I came to Plumtree. I was trained. I became a family leader. That family leadership gave me skills that I could use in my everyday family life. I could also do that with other families, so I could support other families. And I went to other playgroups and I talked about peer leadership and the Now Next program. Because it was free at the time, it was able to be offered to all families. I then got to be asked to be a part of the Parents as Peer Leaders project, and I was able then to train more family leaders and more facilitators of the Now Next program under that 36-month project. And in that time, I got to speak to 1,008 families that didn't have NDIS funding. And that really showed me how vulnerable those families are. Many of them could never access NDIS funding because they didn't fit the criteria, but they were left vulnerable and they didn't have supports in place. However, throughout the 8 sessions of the program, they got to build on their empowerment, on their goal attainment, on their well-being, and on their hope. And we all need hope. And that was one of the biggest things that was created. And that was delivered originally face-to-face. We then, through COVID, got to go online. And because it became online, that meant we got to go across all of Australia to the most vulnerable groups of people. So I was speaking to people from every group in Australia, including, we had about 22% fathers come on board, which is a very high percentage of fathers. About 38% were CALD families. We also had Indigenous First Nations people, but overall I got to speak to some of the most remote communities that really were struggling and didn't have programs like that. And building their capacity is very rewarding for me as a parent, but it also means I get to meet these families that are really needing this foundational support. And it was through playgroups that I first started.
Thank you, that's really valuable.
Thank you. We'll go to Mr. Diadam.
I wanted to ask about Now and Next. I see its funding ceased in 2024. It was initially funded under the ILC funding. It's been independently evaluated. You've got a cost-benefit analysis. Why is it not continuing to be funded through the ILC?
I think Emily raised it. I think it's a matter of commissioning and different systems turning over from state-funded services to nationally funded services through the NDIS. Initially, we were funded through ageing and disability and home care, then through a grant through New South Wales Premier and Cabinet. That was a very initial NDIS ILC funding, and then through an ILC funding in and of itself. So we have, as Emily said, with the programs and playgroups that she runs, we have done what we have could in the last 10 years. Now and Next is 10 years old today. It is an internationally recognised evidence-based program, and we do have published peer-reviewed articles and are planning a randomised control trial. So the progress is continuing, but we have had funding ceased in June because the ILC, up until now, NDIS ILC program funds short-term programs. We hope that that will change in the future, and we hope that the evidence and the experience that we have developed in Australia that is internationally world-leading will continue to be funded. Since July, we have, Plumtree is a small to medium not-for-profit organisation. We have fundraised to provide that. Kylie and a couple of other parent peer workers, we continue to employ them, and we have to raise those funds ourselves. It is not an ideal situation. We feel like we have moved with that program beyond a sort of initial stage. We feel like it is well and truly proven with a randomised control trial. We'll be able to compare parents with and without such capacity building efforts and what the impact on them is. But since then, what we have seen is, even though we offer the program to parents who have got NDIS funding and they could pay for the program with their NDIS funding, they don't. And parents are in an untenable and unethical position. We are asking them to choose between services that they see that their child needs, that is often therapy, and parent capacity building for themselves. That is not an ethical decision to ask parents in this vulnerable situation to make. That is even just for parents of children who have NDIS. As Kylie said, our project, which targeted parents who didn't have NDIS funding, now we're sponsoring those families to carry on.
It seems, you've highlighted a broader issue around, you say it's not an ethical question, or it's not an appropriate question for parents to decide. The government's going to have to make the same decision ultimately about whether we allocate funds to allied health or to capacity building. I suppose, why is capacity building more of a priority than funding allied health? We've heard about the difficulties around getting allied health workforce in rural and remote. That's an expensive process. We're going to incentivise people to go out and provide those direct services. In the choice the government has to make, why would we prioritise capacity building over provision of those direct therapeutic services?
Firstly, as Emily said, thank you, it's an excellent question. Not every parent and child will need therapy. Secondly, I liken the experience of family capacity building as not only being best for the child and family. Parents are going to be their child's parent for at least 18 years. It is in the long-term interests of families and of their child that we build the capability and understanding of the family. When my son was diagnosed with a disability, therapy was the easiest thing to tackle. Eat, drink, walk, talk. That was way easier than coming to terms with what it means to have a child who has a significant disability and will have that impairment for the rest of their life. How do you build a great life for that son or daughter? And I didn't want families to have to reinvent that wheel alone. Why do every parent have to reinvent and have to wait that whole 18 years to try to figure it out for themselves? Now and Next programs and other such programs should be auspiced and developed and funded for free so that they're showing families how to get onto a metaphorical bridge. We want, as parents, our children at age 18 to live a life of acceptance, hope and purpose. How do they get hit there? 3 laneways. At the moment, we have 1 laneway, which is the services and professionally led laneway. That is now, through the NDIS, an autobahn, and you jump into your NDIS Lamborghini and you expect to travel along from birth to 18 years and expect that you're going to be able to build a good life for your child through the use of services. That is not reality. What I have found and what other families have found themselves and what the evidence says is we need two other laneways. We need a community laneway. We need parents to jump into the community laneway and into the parent peer-led and peer-led organisation laneway. At the moment, those two laneways are dusty, dirty, bumpy. Parents are not going to want to travel in them because it's hard. It is natural that parents will jump into the services laneway, but we know that staying in the services laneway is not how you're going to get your child to have an independent and inclusive life. Parents have to travel and navigate through those three laneways. They need to be paved well by government so that families can travel into them and stay in them when it's necessary and move into the other laneways when needed, rather than saying that therapy is the only thing and we have to have a service-led life. That's not the answer. And I can say that from my own parenting experience, but from the thousands of parents that I've supported through the Now and Next program, but also through my career in the 35 years in early intervention.
Okay, so, you know, for myself as a family leader and, you know, being able to live this experience with other families, talking to thousands of families in my role over the last 7 years, I know that parents want to be in the lead of their own family, that they want to be able to advocate effectively and know where to spend their time. Where should this time, I'm time poor, I'm busy, we need to make finances, where do we spend our time? And if we're building our own capacity, we can then ascertain what therapies our child really needs. We can be in that seat of control, supporting our child, and over time our child will change, they will develop, and they may not need the therapies as they grow older. Those therapists might become redundant, but if we don't give parents capacity building and help them to advocate for that, then their child might always be in a system where they need care. So I see it that it's empowering for parents, but it's also financially rewarding as a whole country that we can actually support families to build that at those early years. Now, we know some families are going to need to have NDIS support for their whole entire life, but it could reduce the amount of NDIS funding that they need for their child as well. So I see it financially viable to build capacity for families' capacity at the earliest point possible, and to not make families have to choose. Because I know right now if I had to choose, I got to do it for free. It was funded at the time, but if I got to choose, I would be thinking twice. Can we do this because my son needs this much of his funding? You know, families aren't getting a lot of funding a lot of the time, and these really vulnerable families, they're thinking that funding's the answer because they're being told that by a deficit-based model. And I'd be able to go into a strengths-based model when I was building on my capacity. I learned very quickly that the strengths-based model is going to give me the best outcomes for my child and for my family, and then I got to watch that do that with thousands of other families. And I see them today. We have been able to auspice 2 organisations that are peer-led, and that's been so encouraging. I get invited in to talk as a family leader with those organisations, and they're only growing right now. That peer-to-peer connection and family leadership, that's growing. There is a demand by the families. They want to be able to be the ones leading and making those decisions, and they don't want to feel helpless anymore. You know, they want to be able to be taught how to fish rather than to ask to be fed. Yeah.
I was just going to add, sorry, because I think it's a great question. The only other lens I want to add is like every single child needs healthy, confident, thriving adults in their lives, and something we're really conscious of too is not all children, particularly children with a disability because of the overrepresentation, are with their parents. And so we also need to focus on the other adults that are in their lives, particularly foster carers who are often left off the agenda, and building their capacity. But I understand government has budget constraints. I don't think, though, it's an either or, capacity building or therapy. And I also don't think it's, a nice to have capacity building or a really targeted early intervention. Both are early interventions. I would also argue that parent capacity building is a preventative and protective measure far more than therapy would ever be. And I think that around family preservation and some of those bigger issues we're also trying to tackle, where we know kids with a disability are, again, overrepresented and shouldn't be. But also I think, so to that point, yes, the budget constraint, but I think there's a better way to organise it so it's not either or in a budget context, but also to my earlier point, how we structure this system. I'd hate to see therapy in the NDIS stream with a needs assessment and eligibility to get that. And then parents are just structurally, not even budget-wise, just having to choose, is it NDIS therapy for my son or a general or targeted foundational supportive peer support for myself. They should be getting both parallel. And then I think the third part for me that it raises is who's helping parents and families and the adults in these situations make those decisions of which path they should take, because at the moment, like I said, it generally has been in the hospital, newborn baby, here's the NDIS booklet. For those more individualised therapies. And that's why I think getting this peer-led navigation support piece as well for families, meeting with other families who've walked that path and can actually tell you what it means and what the results were for them is also important in who's helping families make those decisions, particularly for us, child with a disability or not. We all know what it's like to have a baby in those early days. And if someone tells you your kid needs 100 hours of therapy a week, you're okay, you're the professional, and we need to look at that as well in this system.
Thank you. We have Mr. Scott Barrett online as well. He has a couple of questions.
Thank you. The chat around the formal parent capacity building and the peer support's been great. I just wonder how that flows in and what's the importance of that informal community that you might have around parents with that shared lived experience. And I guess just to set up what I'm actually asking, what does that mean for people that might live in more remote or rural areas, that to follow on from the earlier metaphor that I love, that might not have access to some of those laneways?
So what I can say is we used to deliver the Now and Next program before COVID, mainly face-to-face, and building family community, building family leadership, building collective capacity is what we're trying to hear. We're trying to develop a ground-up approach to communities and families supporting one another, because professionals come and go, it's families that are with their child, and families have told us that the most that they learn is it's wonderful hearing from professionals and getting support from professionals, but the information and support that they get from other parents who are in this situation, or in Kylie's example, paid family peer workers, paid peer workers, the information they get from them is so vital. So creating those connections, whether they're in person or online, remote, when we shifted just before COVID to online to test whether or not we could get out to some of these rural and remote places and give access to such parent capacity building programs to families who it would not be viable to set up a group like that in their local region because perhaps they were the only person that lived in their area for a couple of 100 kilometres. What we did before we rolled out fully online was we looked at the evidence, compared it to our benchmark, and demonstrated that it did not matter whether or not you were doing such programs online or face-to-face. What really mattered was that you reduced the isolation by meeting other parents, how you met them, whether it was by phone, by meeting and talking with Kylie, or whether it was by joining an online group and talking and meeting with other parents who were in a similar situation yourself. What's important is that link that parents have to one another. They do that through playgroup, they do that when they're standing at the school gate, but for parents of children with disabilities, the barriers can be higher, and reaching out and meeting with somebody who understands what you're going through is what reduces the isolation.
And I think, Scott, for us, I think you've hit the nail on the head. And what I said at the start, not every child with a disability or family needs a formal service or support. And that's where I think we'll miss the mark with foundational supports if we do just see it as that. And with our community playgroups, which are funded through DSS federally, like they don't just happen, and we are doing some advocacy at the moment. That grant ends at the end of at 30 of June next year, because a playgroup can be as simple as 3 parents getting together in their local community. I don't need to overlay a whole program and training and education that they need to do, no. But what I do need to help them with, because of the way things are, as our backbone support, which is why Playgroup New South Wales started in the first place, is their insurances. They find it really hard to find venues. We have a very remote regional rural group of mums. They want to rotate the playgroup around 3 of their farms because there's no community centre, there's no church anywhere near them. My insurer says, no way, Emily. Similarly, I've got some elders outside Wagga who want to convene a playgroup on country in a dried out billabong to get that connection to culture and country. Again, my insurer's like, no way, Emily. And so we need to make sure that, I think that's where community playgroups come in. And at the moment, like I said, I've got one single stream of funding for that through the CAPS program with DSS. access. But I'd love to talk to the state government, because at the moment we run 650 of them across the state each and every week, but it takes a lot of backbone work to make them happen. And that, again, I'm relying on, at the moment, largely parents in those communities to come to us and say, yeah, we've got together, we want to chat. But what we're probably not doing as well as we could, because the investment isn't there, is how do I go out and incubate and reach the really marginalised, really remote ones and support them to get together, have a yarn, share their stories, and not overlay a model. Like I said, yes, playgroups are a parenting program, capacity building program, but I am not going out to say that. So I really think community playgroups really come to the fore in that respect, Scott. And yes, then we can dovetail them into more targeted supports, online supports and other.
Scott, just to reassure you also, in our last 36-month program for families who do not have NDIS, we collect data for all of our programs pre and post, that our participants came from all over Australia in accordance with ABS data. So rest assured that we were able to reach families who lived in rural, remote and very remote areas according to the proportion that the population lives in those areas.
Thank you.
Thank you. I just have one final question just around funding. Plumtree, you indicated that you're now, I suppose, based on sort of philanthropic. We've now heard that the foundational supports or the federal state agreements have been sort of pushed out and delayed. What is the, I suppose, the current landscape for organisations that are no longer able to be funded through other grants that were available, and what is a potential short-term solution to address that gap and avoid organisations going under?
I can speak of the program that we're running. I mean, we're also, as an organisation, financially very much struggling under the NDIS, but our organisation has invested 10 years of government funds so far into the development of this innovative, novel and internationally recognised parent capacity building program. So our board are committed, and our organisation, our parent peer workers are committed to providing a bridge to when sort of reality and sense sort of hits, and hopefully foundational supports is worked out. So we're trying on a shoestring to do what we can to keep the program alive and out there in the public domain so that it does not get forgotten. There's too much money and research that's gone behind it to let programs such as this to fall into array. However, it would be a wonderful thing if the New South Wales government could continue to bridge a gap through programs such as Start Strong Pathways. Start Strong Pathways has been extended on numerous occasions. It funds, as Emily has said, a variety of supported playgroups, toy libraries, all sorts of inclusion supports. It's a tiny amount for the organisations that they're receiving, perhaps $100,000 or $200,000. It's been extended for 18 months till December 2025. It's 6 months out from that extension end now, and parent capacity building initiative, webinars, parent calendar events, programs, playgroups, etc. You know, all of that is in limbo right now because foundational supports has not been put into place. There needs to be a bridge somehow built between what is at least happening in this sort of scarcity mode right now and help us all make that bridge and that, over to foundational supports when it's finally funded.
Thank you.
Yeah, I think some funding is needed now. If I just reflect on us, we've got TEI that we'll know about, well, it ends in December, we'd like to know fairly soon. Targeted early intervention through DCJ. I've got Start Strong Pathways through New South Wales Department of Education. We've got Connected Beginnings through Federal Department of Education, all ending end of December this year, not knowing. Very hard to maintain the very workforce that we need. And then it does feel like we're on a bit of a 6-month cycle. Then June 30 next year, I've got my time through DSS, that funding at this stage ends, and then our CAPS funding through DSS, that also ends. So it does feel like as an organisation we're on this 6 months, it's like, what are we recommissioning for today? What are we doing? I think the other issue is the timeliness of it. And I do understand, like, it is this nexus. We are trying to bring together very fragmented programs, and I welcome it. We need to streamline this, and someone needs to draw a line in the sand at some point. I get it. But for us as providers, juggling that and sort of being thrown 6 or 12 months, if you're lucky, extensions, yes, welcome. The timing of it could be a bit better though, not finding out a week or two prior, or in some cases for some of our, probably the more federal programs, we've found out 3 months into the year in which it's meant to be occurring, and we've had to carry that. And at the scale for Playgroup New South Wales that we're carrying, that is significant. But also I think to my earlier point, stop just rolling over things, because as Silvana said, we're on quite a few rollovers now, but there's been no quantification of demand and unmet need in that. And I think that's a concern, that we're sort of taking, well, what it is now, we'll just federal and state government will bundle it into our buckets and then that'll be enough. All of us have so much unmet need. I do think there needs to be some consideration, like with every big reform, for a foundational supports transition fund, and some of that funding needs to work now and give us that sustainability funding now, because we had it with the NDIS, we've had it with social sector coming out of COVID. I think that that's needed. And I think also it comes into some of the definitions. It would be nice from the federal and state lens, even just at a high level, to understand what programs are they thinking about putting into this mix, and maybe just a bit more of an implementation and timing roadmap so that we can plan ahead, because it is really difficult at the moment for us all.
Yeah. Well, thank you very much. I'm mindful that we have run over time a little bit, but really appreciate your appearing, but also all the work that you do to support families and young people as well. And thank you particularly, Ellen, for coming here today. It is very important that we hear from people with lived experience, so it's great to hear from you today as well. So thank you very much.
Thank you.
Thank you.
Much for coming today. Before we commence with questions and opening statement, can I ask that you state your name, the organisation, your position, and either swear the oath or take the affirmation, the words of which I understand are in front of you.
Happy to, Shadow Minister. Thank you. My name is Ben Fioramonti. I'm the General Manager for Children, Families and Disability Support at SSI, and I'm happy to take the affirmation. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Do you have an opening statement that you'd like to make?
Yes, I do. Please, thank you. Thank you for the opportunity to speak today. I'm Ben Fioramonti, General Manager at SSI. If the Select Committee may indulge me, my speech, or opening statement rather, will take about 5 minutes, and I'm happy to take any questions afterwards.
Thank you.
Founded in 2000 here in New South Wales, SSI began as a response to the needs of newly arrived refugees. Over the years, we have expanded our services significantly, and we now support a range of communities across New South Wales, Victoria, and Queensland, though we still have a strong focus on migrants and refugees. SSI delivers services each year to more than 60,000 people across almost 60 programs. We are known as an organisation that can engage communities considered by many to be, quote, hard to reach. As GM at SSI, I oversee local area coordination under the NDIS in Sydney and South West Sydney, as well as out-of-home care services through our multicultural child and family program across New South Wales, Queensland and Victoria. SSI supports over 22,000 NDIS participants, including more than 8,000 children aged 9 to 15, making up over a third. Despite initial predictions of 20% uptake of CALD participants under the NDIS, the current figure is under 9% after nearly 10 years since rollout in 2016 following the trial. In New South Wales, out of 51,389 0 to 8-year-olds on the scheme, only 12.4% identify as being from CALD backgrounds, underscoring significant access challenges for CALD children and young people with disability. In 2021, over a third of children aged 0 to 4 in New South Wales were from CALD backgrounds, the highest cultural diversity in Australia. Research shows that these children are more likely to face developmental vulnerabilities at school entry, with underutilisation of early intervention services being a key factor. CALD children in New South Wales are half as likely to access these services compared to non-CALD children, which significantly impacts their long-term outcomes. Barriers such as a lack of trust in government services, language barriers, limited services, and insufficient community-based support prevent families from accessing essential resources. In short, without adequate and appropriate services and a foundational support and navigator model that addresses these barriers, CALD communities will continue to sit in the dark. Over the past decade, programs like Ability Links, Community Connectors, and ILC, led by CALD specialist organisations, have effectively engaged diverse communities in New South Wales. They have fostered trust and access to essential supports. SSI itself has broken down barriers by delivering place-based services using a recruitment model that reflects the diversity of the communities served. However, as programs changed and disappeared over time, so has valuable data, including lessons learnt and evaluations that could be used to inform sector changes, networks and vital community connections, and a sense of stability and support for diverse communities. Short-term funding arrangements and instability of programs coming and going have hindered the sustainability of program outcomes. A lack of statewide integration and application of lessons learnt through these services has also been problematic. However, it's also an opportunity and one that I'd like to highlight. For foundational supports to successfully cater to the needs of children and young people with disability, the following ingredients are necessary. There must be a statewide approach to the design, implementation, monitoring, and evaluation of this program, ensuring appropriate services reach the people that need it most, and a navigation model that aligns with true local area coordination, what LAC today under the NDIS was supposed to look like, which is an evidence-based model used around the world, proven to be cost-effective and outcomes-driven. To that end, SSI asked the inquiry to recommend that the New South Wales Government, 1, plays a key role in ensuring the Navigators model under the NDIS caters to diverse communities by influencing federal government to ensure the design and implementation of Navigators is co-designed by people with disability from CALD backgrounds and by CALD-specific organisations, supporting the design of Navigators to be based on true local area coordination. And 2, establish a statewide committee to assist in the design, the development, implementation and monitoring of foundational supports within New South Wales. This committee could be made up of people with lived experience, young people with disability from CALD backgrounds and CALD-specific organisations and agencies. In closing, there are significant access issues for children and young people with disability from CALD backgrounds. SSI is committed to working with community, all levels of government and the broader sector, including peak bodies and key influencers to deliver lasting, meaningful change. Thank you for your time and I look forward to any questions you may have.
Thank you very much. In your opening statement, I just want to clarify for Hansard, when you talked about the LAC model, you were referring to the local area coordinator model.
Yes, that's right.
They just like it for, rather than having acronyms, the full details of anything. Just could you actually outline that model and why it's been successful, particularly internationally?
Yeah, absolutely. Now, I won't claim to be an expert on the true local area coordination, but before I do speak to that, I will provide a little bit more clarification on the differences between local area coordination now within the NDIS and how it was intended to look during rollout. Yeah. So the current model is in local area coordination is very, I would say the way we would describe it is plan-based. So it's very much around supporting people to gather the information for a plan, and for some years we were also doing plan build. It's about implementing those plans and connecting people to community. A smaller part of what we do, but it is connected. And when I say a smaller part, I'm referring to the volume of work that we do, is around dedicated to individual capacity building, community capacity building, really connecting people to mainstream community supports. That certainly does happen, but not to the extent that it was intended to at the beginning of rollout. So true local area coordination was really less about, building plans and so on. It was more about building the capacity of individuals and communities. The model that I referred to, and I'm more than happy to provide further information on this following the meeting today, it's a model that really is it's place-based. It's about being connected and embedded within community. Typically, an LAC would have a lower caseload, so maybe up to 65 people that they're working within community, and they're able to spend more time that's required to work with those individuals to build their understanding of their rights, connect them to again, mainstream community support, but also support them in developing innovative ideas when that may be required. So, for example, in building circles of support and connecting people to greater supports that they wouldn't have otherwise had. So I suppose when we look at the navigators model, which is recommended as part of the NDIS recommendations, and to be clear, we obviously aren't 100% sure what navigators will look like once it does roll out. There is certainly elements of true local area coordination built into it, but there's opportunity for it to be more closely aligned to that original intent of true local area coordination, and for those two pieces to come together. Finally, the point I would raise on this, Mark, and this is also why we would push for the principles and the design principles of true local area coordination to form a part of this, is because those principles and that way of working, it greatly supports and breaking down the barriers for called participants, called people from with disabilities within community, breaking down those barriers, having someone embedded in those communities to work with individuals to support them in accessing material. Right now, we've got an issue where the NDIS is quite a complex scheme and model to navigate for people in community. But when you're working with people from called backgrounds, where English perhaps is not their first language, it becomes all the more complicated for people to get the services and supports that they need. So, yeah, thank you.
I'm interested to know a little bit more about, I suppose, the gaps in the services, particularly with the COLD community. Government has sort of have indicated they're starting to do a bit of that analysis now, but in your experience, and I suppose also talking to families and organisations, what do you see as some of the gaps that currently exist, and what needs to be delivered?
I think the first thing that comes to mind is that, I guess firstly, just to build a little bit of context, there's been a great deal of programs to date that have had a lot of success in working with people with disability from core backgrounds, children and young people, of course. through ILC programs, through community connectors, through local area coordination, through community hubs, that have really achieved some amazing outcomes. One of the gaps that we've got is that we haven't found a way, or at least to my knowledge, we have not found a way to be able to pull together all the learnings that we've made, all the successes and the outcomes we've been able to achieve, and the formulas for achieving that from all of these different programs, and some of them have been absolutely amazing, to be able to help us to inform, what foundational supports, for example, should look like. So that's the first large gap that I would point out. The second thing I'd say is that in terms of how organisations, community, the sector even works with called communities, people with disability, it can be quite segmented in some ways. And what I mean by that is there's a lot of providers, agencies, organisations doing some great work, but in terms of what they're learning, in terms of what is needed in various geographical locations, there's not necessarily a central body that's able to connect the dots with people and organisations. For example, to be able to say, hey, if you're going to work in this particular location of Sydney, you need to know that there are some significant gaps here for called communities, or there's high cases of fraud or people taking advantage of people in these specific communities. You might need to be aware of that. Or we've got low therapist support for Arabic-speaking communities in Liverpool. Whatever it may be, it would really help. And this is one of the reasons why one of the recommendations we're making is, could we have some kind of a body that could, act as a bit of a conduit and a connection for all organisations working with diverse communities. One thing I also just wanted to point out on this note is that I think as a called specialist organisation, one of the things that we see and often feel is that working with diverse communities is sometimes a bit of it's perceived as an afterthought when we're designing and implementing programs. And that's really problematic. And as an example to what I'm saying, if you look at the NDIS rollout, we started rolling out in 2016, so following the trial. 2 years later was when we saw the first called strategy. So what we'd like to see is that if we are going to work toward foundational supports and a new model across New South Wales, which has, obviously significant amounts of diversity right across the board, I'd like to see that we're looking at this from a called perspective from the get-go, and it's not an add-on component that we need to think about once we've done it. It's looked at now, and we're looking, and if it's benefiting people in terms of a model and approach and principles, if it is benefiting people from core backgrounds with disabilities and children and young people, therefore, with disabilities from core backgrounds, then it's helping all people, because it means we're embedded in community and we're able to give that information support to everyone.
Before I hand on to my colleague, I just want to ask, a lot of the submissions we received and the witnesses have talked more about the foundational support for the early years, but young people, it's also that school leaving and sort of up to the age of 24 really. But what role do you see the states playing in providing that support for the I suppose the high school year for young people who are not on the NDIS? How does that fit into the piece?
Well, I think that's a great question, and I don't have an answer for that one. But what I would say is that's where there's definitely opportunity for us to work with, for that to form part of a consultation to work out what are the best supports for young people who are making that transition, because it is quite critical. Even if we're looking at the out-of-home care sector, people making that transition, from the out-of-home care space, people can be going through with disability or certain vulnerabilities can be going through significant change and need significant amounts of support. So I know I don't have an answer for that one, but I do think that that is a critical thing to look at and to get the right people in the room to discuss it and come up with solutions.
That's fine. I might hand to Deputy Chair.
Thank you. And thank you very much for coming along and giving your perspective. I guess my question really is, what did we lose when we went to NDIS, and what does this move towards foundational supports in the state again, I guess, create an opportunity for, from your perspective?
If I could ask, just specifically, when you talk about what did we lose, are you more referring to services, or are you talking about knowledge?
Look, I guess everything. So we've heard from previous witnesses. There's been, as we've moved from what we had before to NDIS, we ended up with, sort of more individualised services, a bit of a division between those on NDIS and those who aren't. But also a fragmentation of services and a lack of knowledge of how you navigate each of the services, I guess, and where to go.
Yeah.
Particularly for people who are coming from another country, who have just arrived. Have we, from your perspective, do you think that we've lost some of that sort of landing, I guess, and ability to sort of network and refer people along with NDIS, and how could we sort of change that going forward?
Yeah, that's a great question. I would actually say that we've both lost certain things, but we've also gained a lot too. So in terms of, and I'll start with the former, the Ability Links program in New South Wales was actually rolled out to support that transition, and it was a great initiative by New South Wales government to support the transition of the sector of community into NDIS. So for those that aren't sure what Ability Links is, it actually does tick a lot of the boxes in terms of being very closely aligned to what True Local Area Coordination was about. So you had linkers, and we, SSI, played a key role in that, in supporting called communities. So that was more 75% of our participants at that stage for the 6 years that we ran it, worked with called participants. Now the staff members that we worked with and we employed were from community, so they were from diverse, most often from diverse backgrounds, working in community across the state, connecting people, working with people in a very innovative way. So we would do a lot of community consultations across the board to get a sense of what community needs. If there was a lack of awareness of what the NDIS was, for example, and a lack of translated materials, this might become then a program that we work on within the state, or certain areas within the state, to support people to get the information they need. If we found through community consultation there was a lack of connection across various community groups, which was required, whether it be to develop a peer network of some sort to then lead toward capacity building outcomes, then that's something we would do. We'd start to work on a peer network and so on. So it was quite innovative. It was very flexible. And again, this is something I'm more than happy to provide more information on later. But that, we haven't had anything like that since. And the outcomes that were achieved through the Ability Links program were amazing. In fact, it was a program that didn't just work across the disability sector. It worked across all sectors. It was focused on people with disability, and for us particularly those children and young people from called backgrounds. But it was, but it worked across housing, education, because there might have been people who, even to this day, wouldn't have been eligible for NDIS, but they needed support in gaining access to education and, so we would find ways of linking them into appropriate services and supports to get them there, or link them into housing and so on. And to a large extent, and this goes back to your question a little bit earlier, Shadow Minister, that around the world where this model has been used, it hasn't necessarily just been used in the disability sector, it has been used across multiple sectors, so you've got people joining those dots. So that is one of the things that I do feel that we've certainly lost in New South Wales, this incredible program with incredible outcomes. And I think there is opportunity for us to find ways to weave that back into the future through sector changes. In terms of what we've gained, though, and this is one of the interesting things, is that local area coordination today, whilst I would say that it is more plan-based and focused, over the last 10 years, and to give a little bit of context, Partners in the Community are organisations across Australia who run local area coordination or early childhood services. But Partners in the Community, and SSI is one of them, have done some amazing projects and programs, community development-based, community capacity-based programs in community, across Australia, doing very interesting pieces of work that have been evaluated, that do have recorded outcomes, that to a large degree, the community often, not community so much, but I guess the sector often isn't aware of. So I think there is a lack of awareness of what has been done through these various programs. And, we've talked about peer networks, and this is one of the things that the Partners program has been able to implement over time. There's been projects that work across the intersectionality that we see within the sector, where you have people from young people from CALD background with disability who also identify as being from an LGBTQIA+ community, where they're struggling to make connections, or there's a lot of fear in the community around that. LAC is a program that has developed projects and events to support people who are facing these kinds of unique barriers and challenges. Again, I'll be brief, and I'd be more than happy to provide more information on the type of work that it does, but a lot of these community development initiatives, activities are widely unknown, which is unfortunate. So I'd say that we have gained a hell of a lot through that process, and that is also something that we could use, those learnings that we've achieved across the Partners program in Australia, we could use that to help us to inform future. And one final thing I would say is that that's something we probably didn't take as much an advantage of in terms of the information linkages and capacity building program that has had amazing projects across the board for many years. But I'm not sure that there's ever been an evaluation process that took place to take the lessons learnt from all those different projects to be able to help to inform us as to where are the service gaps, where is the need, and what type of projects have organisations run that have been highly successful, that have been cost effective, and that can be replicated. So I think that is something that it's a missed opportunity that we could take advantage of.
That's an excellent answer. Thank you.
Thank you very much.
Madam Chair?
Mr. Martin?
Thank you. And thank you for being here today. In your view, and with the benefit of your experience, how could we best improve the partnerships or the relationships between government departments and CALD communities?
Thank you. That's a great question. What we know works, and these are some examples. And mine tends to go a little bit bigger picture and a little bit further into the future here. But what I would firstly say is what we know works is when there is a relationship and a strong relationship between community and all layers of government, but also depending on what social issue that we may be looking at. So, for example, if we were looking at employment, then we'd be looking at local businesses and community leaders. But when there is that strong relationship between all these different layers, that's when we're most likely to start to see some progress, when there's really good, when there's buy-in and ownership across these different layers. It's not government's responsibility to fix everything, and it can't be. There's got to be a joint relationship and joint responsibility taken to work through these things. Now, when government are working with local organisations and community-based and place-based organisations, and are actually actively listening to what's going on the ground, what's needed, what challenges are being faced, and what works. That's one of the keys in this, right? But also working with community leaders. So it's not just community organisations, it's community leaders, and they could be religious leaders, people of high influence in specific community groups. That's also critical that they are connected. One of the pieces of feedback that we've had in a number of different forms over many years, through various community consultations that we've done across South West Sydney, people often say, if we can't, and this is one of the disadvantages of having programs come and go, is that you lose those connections as well quite often. And what people will say is, if you're not here and we can't see you, you don't exist. You can't help us. And when there is that disconnect, that's when you've kind of lost any sense of ability to bridge that gap. One of the challenges that we're aware of in certain geographical locations, and if we were to look at, say, Leppington in New South Wales, for example, where it's high diverse population, and it's definitely a really it's a great growing area. There's low social infrastructure in Leppington at the moment, and what that means is that it's even more difficult for services organisations and certainly for government to be able to break down some of those barriers. So what's happening at the moment is that people are often core communities are relying on word of mouth and what they're hearing. They're using WhatsApp platforms to communicate, who to go to for this, that, and the other. And it can be highly effective, and it's a great way but if there's no connection between, community organisations or government or any way of being able to use that channel as a way of sharing positive information, useful information about what to access, then it's also an opportunity for misinformation too. The final thing I'd say in response to that is more broadly, I think that the idea of having some form of a statewide advisory committee that can work on developing a program like foundational supports is a great opportunity to I guess, connect all those different layers, to connect government to the grassroots. And it's also an opportunity to start to build in more of a systemic and methodical approach to working with called communities and called people, and reaching those children, young people that need the supports they need.
Thank you. Thank you very much, Chair.
Thank you. Any questions from government members? No? That's fine. All right, that comes to the end of the session. But first of all, thank you very much for coming today, but also for the work that your organisation does, supporting families and the Cole community as well.
No.
Thank you.
Thank you so much.
That concludes the morning session, and we'll be returning at 1:45. Thank you.
Thank you so much. Appreciate your time.
Thank you. Ready to go. Thank you very much for coming this afternoon. Before we commence with questions and opening statements, I'll need to ask that all our witnesses state their name, the organisation, position, either swear the oath or take the affirmation, of which I understand the words are in front of you. And for those witnesses who are online, I understand that it has been emailed through to you. We might start with Mr Johnson.
Thank you, Chair. My name is Matthew Johnson. I'm the President of the New South Wales Special Education Principals and Leaders Association and the National President of the Australian Special Education Principals.
Thank you.
I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much.
Hi, I'm Patrick Damani. I'm the Member Support and Research Officer at the Federation of P&C Associations of New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Thank you. My name is Gemma Quinn. I am the CEO of the Federation of Parents and Citizens Associations of New South Wales, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Ms McPhee?
My name's Elizabeth Libby McPhee. I am the Secretary of the ICPA New South Wales. I solemnly and sincerely and truly declare and affirm that the evidence now given by me shall be the truth, the whole truth and nothing but the truth.
And Ms Strachan?
I'm Annabelle Strawn, President of Isolated Children's Parents Association. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. And then for those in the room at the moment, Ms Strawn's video isn't showing, so it's a black screen, but we can certainly hear you. Would anyone like to make an opening statement? No?
I would, Madam Chair, if that's acceptable
That's
to you.
fine.
Thank you for the opportunity to present today. The Federation of Parents and Citizens Associations of New South Wales represents the voices of parents and carers in our public schools. We speak today not just as an organisation, but on behalf of the thousands of families who are doing everything they can to ensure that their children with disabilities or developmental needs have a fair start in life. Our submission highlights what families across the state are telling us, that they are waiting too long, travelling too far and paying too much for the essential supports that their children need, if those supports exist at all. From Dubbo to the South Coast, from Western Sydney to the Northern Rivers, parents are navigating fragmented systems with long diagnostic delays and a postcode lottery that determines access to care. We support the vision of the NDIS review and the Disability Royal Commission, particularly their calls for foundational supports outside of the NDIS, integrated service delivery and rights-based approaches to inclusive education. But we need to make those reforms real, especially in our schools and our regional communities. We urge the committee to make bold recommendations and take practical action. Joint investment in early supports, embedded health professionals in schools, reform of diagnostic pathways and culturally safe and a well-trained workforce in every corner of New South Wales. Ultimately, what parents want is simple: to see their children happy, learning and included without having to fight for the basics. With the right support in the right place at the right time, we can give every child in New South Wales that chance. Thank you.
Thank you very much. Ms Strachan or Ms McPhee, would you like to make an opening statement?
Annabelle, do you want to go?
Well, we're very much in the same as the P&C, very much along those same lines. So, yeah, very happy to support what the P&C have just said.
That's fine. Well, we might commence with questions. And I'm happy for this to go to all witnesses. It's around the transition for young people from, particularly from a school to work, additional study, accessing other services. A lot of the submissions we've received has been very much focused on those early years, which I'm happy to touch on a little bit later. But keen to hear your views about the gaps that exist at the moment to support that transition and what needs to be improved.
I'd like to comment on that if I can, Chair. One of the biggest challenges within our special schools and settings is for students with significant disability and complex needs. the transitions that people usually think of going from year 12 to education, further study, or work. That's something within our specialist schools and settings that starts in year 9, year 10, year 11, year 12. It's a really long process to be able to work with parents in what's going to be the best outcome. But one of the challenges is that whilst in the schools, the students are accessing a heap of support. The parents get a lot of support from us in our schools, our school counsellors, interagency interactions, therapists and all the rest. But it really comes to just a complete stop at the end of year 12. And it's another trauma that our parents face, because when every other mainstream year 12 parent is celebrating hopefully a really good ATAR or something like that, and the next phase of life, for our students with complex needs, where they go next is a lottery. And trying to find that best fit, or something that, where the parent can see their child going, yep, that's where he belongs or she belongs, this is going to work for them, is a real challenge, because there's no real coordinated supports apart from our schools and our deputy principals and executive and teachers picking up the parent and driving them around all the various institutions and supports that they might find for their child, and to be able to see which one's going to work. And it's, again, with a lot of the submissions, it's the lack of interagency coordination around that. But it really is just a steep cliff that our kids face at the end of year 12. And it's a huge transition, but to where?
Yep. And any of the other witnesses like to comment?
I would like to echo Mr. Johnson's sentiment, because that's certainly what we hear from parents. And I think to take the parent lens, this is something that parents think about from early childhood, from even before the point of diagnosis. This isn't something that we get to a stage in a child's life and think, okay, we need to start preparing for what happens after school. But parents know that that burden falls on them because of the fragmented nature of the supports available to them. So they begin this process of trying to set up structures as a family to support their child or young person once they leave school. And that is an incredibly disproportionate experience in the regions as opposed to in Metro Sydney. Access to support then becomes critical, and to take the metaphor of it being a steep cliff to face at the end of school, we hear from parents that they feel like their children are very much at risk of falling off that cliff when they leave the school system if they don't take on the personal burden of making sure that that child is supported and safe outside of the school system.
Mm-hmm. Yes, Libby?
Thanks very much for the opportunity. I just wanted to raise a couple of things here. ICPA New South Wales, or Isolated Children's Parents Association, are all about the equity to access for education. And I think it's a good point here that I can make that, and you talked about transition to work, transition to secondary school or beyond. We are at the moment calling for a tertiary drive subsidy, and that's literally to get children to university. Once they've finished year 12, whether it's been on distance education or whether they've been at boarding school, wherever they've been, they are now facing the problems out here of getting to a university, which can be Armidale or Sydney or wherever. We don't have the public transport that they have in the city, and these students don't have or can have an Opal card, but it's no good to them. They can't access public transport. They've got to make a huge journey, potentially overnight, to get to somewhere like Armidale, carting all their luggage, their computer, their clothes, their linen, whatever it has to be. And they have to negotiate, get themselves, their parents have to take them to Dubbo potentially to get on some sort of public transport. Then they have to probably overnight in Sydney to then make the journey to Armidale next day. Meanwhile, they could have made a 600k trip if they'd had a car or some assistance to get across the northern part of the state. But that doesn't happen. And unfortunately, it's our calls on deaf ears at the moment. We really do hope that the government will look at that scenario and try to help these students. At the moment, if their parents can't help them, they're not able to do it. They just have to forget about the study and perhaps just go to work and not get a diploma behind them. And that's not helping these students. It's a real exclusion to what they should be allowed to have in their access to equitable education. So we're hoping today that something like that might come through this Foundation and Disability Supports inquiry. Again, also distance education students, they are, when they move on to secondary school, they are not able to get much support. We're calling for school 2P1 and TP2 schools to be made hubs so that these students can go and access the schools. They are already signed up to public education through distance education, but then they have to stay at home because that's how it's been, and try and do their education from the lounge room, limited internet, whatever it might be. But we're asking that these children should be allowed to go to a public school within reach of them. We're talking about very remote schools here, schools where they don't have another opportunity, and that distance education has been their only opportunity to study or do their schooling so far. It is difficult, obviously, when they get to secondary school, it's far more difficult for them. So we're asking that they get those facilities, be it a library, some internet, an actual schoolroom to sit in, and they're being taught by distance ed, so they really just need a supervisor in the room, and that could even be a camera these days. There's lots of very good cameras that could keep an eye on them, and someone could be monitoring that from the office or wherever. And generally their siblings are going to the same school. And in some cases we know these children have had repeated year 6 because that's the end of their schooling. That's where it ends for them. And that's, to us, that's not acceptable. And it's very disadvantaging for them. And just, we really do hope that things like this inquiry will bring that forward as well. The other one is, of course, the preschoolers. We have them out here. They're unable to access the school buses that are travelling. We're asking for a preschool drive subsidy to get these children to a preschool to get some sort of pre-schooling before they actually go to school. Parents are having to drive, anything up to 200 k's one way to take these kids because they cannot access a school bus because of safety reasons. This is what we're being told. Meanwhile, their siblings are on the bus, but the parents are prepared to do it, but they're doing it at their own cost, and that cost is extraordinary when you start to think about that each week to take that child into school and stay there, pick it up and take it home. So meanwhile, the others are on the bus. So we're hoping that this inquiry also will look into a preschool drive subsidy.
Thank you very much. Just following on from that and around and it was touched on before about the interagency and government sort of collaboration. From an early childhood perspective, we've heard things like having hubs and allied health professionals in schools. When you're looking at young people, so not the early childhood years, how could that model work? Like, what are some of the suggestions or solutions to be able to ensure that these young people are getting access to those services? Would a hub model work, or needs to be a lot more flexible or fluid?
I'd like to comment on that, please. The hub model is, for me, the way to go, especially with our specialist settings. For example, one of my previous schools had 150 students. Those 150 students only had 2 paediatricians between them all, but all of the students had to go individually to those paediatric appointments, whereas pretty much the entire cohort for that paediatrician was sitting right in my school. And for students with complex needs, just the sheer stress for a parent trying to take a child into a doctor's surgery or waiting room and possibly be 45 minutes late for a child with significant autism, it's a really, really stressful thing to do and something that parents dread. And there's models across Australia. Queensland, for example, in their special schools have occupational therapy, physiotherapy, speech, which are Department of Education employees within the school. And so they actually get to know that child through their full 12 years, K to 12, experience in that school. So it's a consistency. And then the parents are accessing those additional supports outside of the school with the NDIS. Also, school nurses would be another fantastic thing, because a lot of our school learning support officers or teachers' aides in New South Wales are the ones doing sometimes suctioning, medical procedures that really are the domain of health, not education. And having that kind of model within the special schools, I think, would be incredibly beneficial to parents and especially to the students.
Thank you. Anyone else like to comment?
We do think that the hub model also is an effective model, and I think we really underscore in our submission that need for consistency throughout a child's life, and to be looking at the access that a person has to particular supports and particular individuals throughout their journey of accessing support, even beyond school. That consistency needs a dedicated strategy with regards to workforce retention, to make sure that when a model is set up, such as a hub model, that gives a young person consistent access to the same continuity of care throughout their journey.
Mm-hmm. Thank you. Yes, Ms.
I wanted to also say we totally agree with the consistency model, but we are also about the fact that we think that the students should be getting access to allied health, things like speech pathology, very early in their time, and it's quite often only diagnosed when they start some sort of school. And at the moment we're finding in rural areas that they have to wait long waiting lists, get onto long waiting lists. If people are coming to visit, of course, there's a real call for it, so they're finding it really difficult. Parents in some cases are prepared to travel to a more regional centre, say Dubbo, and visit somebody with their child for speech pathology, because they realise that it's really important that they get onto it and try and access help for that student so that their learning is not impacted or affected. And so we're really about the fact that they should be given some support to access it in a regional centre if that's what they're prepared to do, and just try and skip the queue and get that child some assistance for that child before too long, because we realise those early years are really important.
Thank you. Ms. Strong?
Our waiting lists out here are up to 18 months and longer. Also, the consistency of the same person we have, they're not consistent, like they might only be here for 2 months. So when the child goes again next time, it's a start again. So for those children, it's very traumatic. And also in the Department of Education, the psychologists, school counsellors can't diagnose conditions such as ADHD and autism and mental health conditions, which that is the only people that we really get out in these very remote areas. So it would be great if we could have some sort of allied health supporting these people.
Thank you. I might pass to the Deputy Chair.
Thank you, and thank you to all of you for coming along, giving evidence. Something that a previous witness was talking about has been playing on my mind. They were talking about they made the very good point that part of a foundational support framework should really be trying to upskill and capacity build for families. But also, you would argue, presumably, this will come to an actual question rather than a statement in a minute, but that should be across society. So whether it's enabling teachers to be able to deal with a range of disabilities within their classrooms, or whether it's health professionals or whoever, which made me, I guess, think about whether or not the introduction of NDIS and the funding being so segregated between those who are on NDIS and the 90% or something of people who are with disability who are not, whether we have in the process, I guess, lost some of that responsibility within broader society, whether it be education, health, or wherever, for continuing to upskill and capability build so that we are able to deal with people, particularly children, of all abilities and levels. Do you think there's something in that, and do you think that is a product of kind of NDIS, or is it just something else? Maybe I could start with you, Ms. Quinn.
Oh, I absolutely think that is both accurate, and also this siloed model. It was always going to result in that fragmentation. And I think that the burden is really falling on parents from a very early age to go, okay, well, that upskilling that needs to occur for me and my family is now my responsibility. We've got parents who are having to become an expert in all sorts of areas of support for their child that is navigating completely new territory for them. We have parents reporting that the sheer burden of trying to keep up with the number of things that they need to learn and understand to adequately support their young person is resulting in them having to reduce their capacity to work or leave work entirely. So there's also a financial cost to society as a whole, with parents having to pick up that burden because we've failed to have access to those supports in another area. And I think a greater focus on how we address that would have economic benefits for society as a whole because of that disconnection between parents and the workforce that results from having a child with complex needs.
Thank you. Anyone else want to comment on that?
Yeah, it certainly is siloed. I've worked across a range of special schools. One is that were called behaviour schools or learning centres for students with emotional and behavioural difficulties, and then ones with intellectual disability. And each of these students were interacting with other agencies, sometimes coming in contact with police, with juvenile justice, and all of those agencies were doing their role with that student, and then we were as well, but none of us knew what each other was doing. And that's the real challenge, that we need some kind of navigator, something that is multi-agency, to be able to look at, especially high-risk students, but more broadly in your context of looking at, well, how do we get that support spread? That's what we need to have, because when you look at a lot of the students, whether it's significant disability or even trauma, you know, most of those students or that family that's going through those challenges, most people in the street would identify that family in knowing that they're having trouble. But, you know, we're in a society now where that's very much blinkered and you get on with your own world, and we've lost a lot of that sense of community. And that makes it a real challenge because, as Gemma's hinted at, that, and our friends from the Isolated Children's Association, that it's not until school when all of a sudden there's this surprise, this child's got challenges, because the parents don't really have to confront or see that, or they might not think their child has an issue until all of a sudden the rules-based formality of school becomes that challenge. And that's 5 years gone, missed, where intervention and early intervention could have made the world of difference, and especially for students with disability and complex needs. If we get that right then, that's a cost-effective whole of society benefit, because you're not starting from scratch again. And that's a real challenge, and that's what we need, is that some kind of coordination there. And one of the biggest problems is too that families and schools trying to interact, simply having the time to do proper meetings, and with a multidisciplinary team, because we know that that is the most effective when we have everyone from that. But that's usually schools taking their own time to ring and get those people connected. And it's another job for us and for principals in our special schools and in our mainstream schools. We constantly feel that we're doing a lot of other agencies' work, and we need that help. We need that kind of hub model where everyone has got an MOU of how we work together, not just individual schools of great practice going on their own to try and solve the problem.
Thank you. Ms McPhee?
Yes, I just, from Isolated Children's Parents Association New South Wales, I just wanted to say we totally support what Ms Quinn and Mr Johnson have said there. And in our submission, we have outlined that we would like to see relevant ministers from health and education working together to enable access for parents and carers of remote students to access vital allied health support through funding and or subsidies that are not being covered by the NDS. And I think that's really important at the moment, because we know the NDS does do it for some, but there's as you pointed out, there's a huge cohort out there that aren't under NDIS and therefore don't get any assistance. And those parents are left alone with those students to try and access help and navigate the challenges that they've got.
Thank you.
Thank you. Mr. Down?
I wanted to ask about the existing funding streams in public education for disability. So we've got IFS, we've got low-level adjustment for disability. How do you think they should be affected by a shift to foundational supports?
It's a really challenging area when it comes to looking at the funding for our special schools and support classes. The real funding that comes from the government is the resource itself of staffing. So it'll be the teacher and that school learning support officer on that class. Integration funding support, or IFS, as you mentioned, is only available within mainstream schools, not available within the special school. So that ranges from small amounts to larger amounts, depending on the child's need, and schools will then use that targeted money within the school to be able to support the student, usually with teacher aid time, SLSO time, to be able to support their needs. Sometimes pooling it towards a resource, so that there could be an additional teacher to be able to help and do withdrawal work. As far as that impacting the foundational supports, it's a difficult thing. It's like the nationally consistent collection of data. When we're looking at that, you can only be disabled once. So you can't have multiple disabilities mentioned. It's a primary disability. And so that's one of the real complexities. Queensland, for example, has an extensive plus category on top of the NCCD to be able to cater for that. And so that's an additional funding stream that schools can apply for to be able to support that child with multiple comorbid disability. So it is a challenge, because with the NDIS, if that has been identified early enough, that child's got that package which can see them through. But for other students, they might not access specialist support within a support class or in a special school until later in their life. Sometimes it might be right up until the start of high school. And that's that real challenge, that there's no particular funding that follows the child. It's really around triaging what that child's needs are through local placement panels and access request, and seeing how many students, how many vacancies you've got, whether they can get in. And a lot of the time too, parents are unaware of what is available. And sometimes the first time that a parent knows that their child might have a disability is when an access or placement panel has sent them a letter of offer for a support class. And that might come as a surprise for a lot of parents as well, because they thought, our child's having a few difficulties, but they didn't think of it as a disability. And then once you go in, it's the assessing that takes place with our school psychologists and external paediatricians. So it's, unfortunately, we're in the era where if you get the label, you get the support, but if you don't get the label, it's up to the generic resources of the school.
Isn't that what the low-level adjustment for disability is supposed to cater for those who don't have the label effectively?
The low-level adjustment for disability?
Yeah.
Yep. Within my sector of special schools, that's not a funding stream that we have access to. Yeah. That is an overall resource with the school's budget within mainstream, for them to be able to put that whole of school resource across to be able to support students, absolutely.
And I suppose my kind of follow-up question is, the sort of hub model is kind of contingent on this idea of having specialist support in place, but obviously the need is contingent on the profile, the disability profile of the students in the school, and that varies over time. And so you kind of, and this is the sort of perennial problem, which is that you've got a tension between sort of funding for a program or tying the funding to the specific student. In terms of the hub model, there's a risk there, isn't there, that you'll have additional resources in one place and not in another where there might be the need. Do you have a kind of comment to make about the sort of various pros and cons of those two approaches?
Yeah, I disagree with that, that they would be an idle resource.
Not an idle resource, but like in terms of equity of spreading the resource fairly across the system so that everyone's got access to a minimum level.
Yeah, thank you. It's essentially with students who are in mainstream schools and can access integration funding support are the students who should be in mainstream. And with our special schools, we've seen over time that the complexity of need has just increased. And so the most complex multi-disability students are within the special school. And it is just that intense. Students, and by the nature of the department's own processes, if you get offered a support class in mainstream, that's less need. If you're getting integration funding support, that means you can be within the general school population without withdrawal with some additional supports. So when you're coming to the pointy end of the pyramid within a special school, where I'd see the hubs as the first place to go as a pilot, those employees would soon be swamped with the amount of work and the caseload that they would face.
So you're not proposing the hub model for mainstream schools?
I think so. It'd be beneficial, but mainstream schools have also got access to larger budgets to be able to be flexible and to innovate. And we're very much stuck to that structure of being funded by staffing and our classes. And we need those supports because the children deserve to have professional health support within the school. And so it's part of the educational process rather than all these little silos still happening before or after school or on the weekend.
Sorry, do I have more time?
Yeah, otherwise Scott Barrett.
Oh, look, I think that's fine.
We might go to Mr. Barrett.
Thank you, Chair. I might start with the ICPA, if I can, please. And we heard earlier about some of the formal parent capacity building arrangements and the formal peer support. A lot of people in rural and remote areas don't have that same largesse of community of shared experience in their areas. I just wonder what we can do or what government can be doing to assist build that sense of community for those more remote people that have that lived experience, shared experience.
Annabelle, did you want to answer that?
Well, in our case, I think mostly for us, the best way would be through remote allied health. If we could, like Royal Far West, would be very helpful for us in our situation because travelling is just such a long way from anywhere. And also in some of the communities, the parents aren't really themselves not able to help in that way. So that's when it could go through the school and the school would be able to help the children and support them through any extra learning that they needed. I guess that's, and for us also the early intervention is vital because that would help. So many parents just know if there were any trouble and any support they could get early rather than wait. If you go through distance education, you might be in high school before you really realise that there is any problems, and that's a long way down the track, and then you've got the poor child has to go through school with all different sorts of issues. So
I'd like to come back to that, unless Ms McPhee, did you have something to say about that sort of community of shared lived experience?
I was, Mr. Barrett. I was just going to say thank you for the question. Annabelle just touched on it. I think the program's called the Beginnings, Early Beginnings, or Brighter Beginnings, sorry, is the word that they actually use. And we really want to see an extension of that program. You know, there was the Healthy Kids bus stop, which has been around for years, and it's had the funding withdrawn from it. So we are concerned that, you know, children moving forward are not going to get a community approach across all of the areas about some of those health things. But of course, the Brighter Beginnings is going to supposedly give them an early intervention, which is what Annabelle's spoken about. The other thing was within our submission, we have suggested that the Department of Education ensure more accessible school-based platforms for assessing and diagnosing any learning and wellbeing support difficulties for children living in rural and remote areas. So we hope that this submission will take that forward as well.
When we're talking about, I guess, missing that early intervention, that early identification, and we heard Mr. Johnson, you talked earlier about you sometimes feel like you're doing the jobs of other agencies within schools. Ms. Quinn, you talked about the flow-on effects of the lack of services that are available. I just wonder if our children are being missed when it comes to that early intervention, or they're not getting the services that they do require, what impact is that then having on our resources of the broader schooling community and the broader student body?
I might start answering that one. It's a huge impact and workload at the school level, because if the family doesn't have or hasn't accessed supports, it's then our job, and it's, you know, I don't want to say it's a burden, but it's a workload issue of being able to try and connect them with supports. And also, you know, there's with Indigenous families as well, that can be a really confronting thing when you're trying to link them up with government agencies, and that might cause some trauma that they might feel like they're being judged on their parenting when you're trying to look at getting assessment for their child, and also the shame around that as well with migrant communities as well, where they don't really understand the interface of what's occurring, that we're trying to get support, but trying to manage that in a really equitable way, in a sensitive and culturally safe way, is a challenge as well. But it's the time within that school's work hours to be able to, identify the family, meet with the family, be able to meet with the child, look at their needs. And when you look at the Disability Standards for Education, the biggest time to get it right is on enrolment, to be able to really find out what the needs of that child are and what the wants of the parents are. So then hooking them up with all those services, then the school trying to coordinate that, have meetings with those interagencies, and then try to foster that support and keep it going. So it's not just one-off interventions. That's a real workload for schools, and we're not staffed for it.
I'd like to pick up on that, if I may. I think that in our non-specialist public schools in particular, the proof is in the pudding. The fact that we have teachers and parents reporting to us that they're relying on teachers to be everything from the diagnoser to a specialist agency of support tells us that we're missing something here. We have P&C associations across the state being approached by school principals and asked to contribute additional funding to the school budget to pay for SLSOs. That is indicative to me of a broken system. We have parents reporting to us, as touched on in our submission, that there is an over-reliance or heavy reliance on an external diagnosis in order for a school to step in and offer support to a child that they themselves have flagged requires additional support. And I think that is suggestive that we need to look at alternative models of funding public schools and resourcing our teachers and additional staff to ensure that those needs of children that are being clearly identified are being met. I think that part of that is going to need to be a look at the way we train our teachers at the university level to say, well, if you are being asked to carry this burden, are we doing our job in equipping you to be able to identify the needs of every child that is going to be in your classroom? And while we have specialist schools, we know that children are presenting in non-specialist schools every single year at enrolment that have more and more complex needs, multiple diagnoses or not diagnosed but potentially do require multiple diagnoses, and a teacher is being asked, in addition to all of the other children in their classroom, and that's not just one child who maybe has additional complex needs in that class, it can be multiple, it could be everyone, and we aren't investigating exactly what is needed there to supplement the funding to make sure we are capturing all those children.
If I could quickly add to that as well, as with initial teacher education, there's no real part of initial teacher education where you're taught how to work with adults. And that's what our teachers are being increasingly asked to do as part of those multidisciplinary teams. And it's a real skill set, being able to do that. So I just wanted to add to that.
I would echo that completely, and I think that the relationships with principals and with teachers work incredibly well in a lot of schools where the teachers and principals have developed that skill set themselves. We also see the breakdowns in communication that result all the way going through to a complaints handling process tend to be resolvable from the outset had the communication skills been built in the first instance to support a complex discussion or a challenging discussion to happen between a teacher, a principal and a parent.
Thank you, Chair. That'll be all from me, unless Ms McPhee or Ms Strawn wanted to add something to that from a rural and remote perspective.
I was really just going to ask the specialist schools, are there any regionally, or are they all in the city?
They are mostly metropolitan or large regional.
I was just thinking, like, we live near Dubbo and there's definitely not one there. Orange is the only larger regional centre?
For West, yes.
Yeah. I think that's a sad thing too, because parents from very remote and rural areas would be able to access, if they were in these regional areas, that would make a huge difference.
There being no other questions from members, can I thank all of you for appearing today, but also for everything that you do to support young people and families as well. So thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you, Ms Howe, for appearing today. Before we commence, I need to ask that you state your name, organisation and position, and swear the oath or take the affirmation of which I understand the words are in front of you.
They are indeed. A bit daunting just being me, and my apologies that it is just me. Other members of the organisation were either ill or in meetings.
No, that's fine.
Yes, so I'm Sally Howe. I am the President of the Australian Association of Special Education New South Wales chapter, also Vice President at a national level, and I am also an expert panel member on the Institute of Special Education, which is just worth mentioning because I know they put a submission in as well, and we're very much on the same page, those two organisations. So yes, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Okay. Thank you very much. Would you like to make an opening statement?
Yes, I was just going to kind of flag a little bit of my, about, just very quickly about ACE, but also a wee bit about my background, which I thought might be useful for panel members to know where my perspective on things comes from. So ACE is actually celebrating its 50th year this year. And the entire history of ACE has been around advocating for the needs of students with disabilities and special education needs in the education context. So we are an organisation about, obviously from our name, special education, even though that term has become a little bit contentious. We've never been about a special school as special education. Special education to the organisation is actually teaching practice, specialised teaching practice. So that's very much what we're committed to. ACE does have its own journal, which is the Australian Journal of Special and Inclusive Education, which is one way that ACE aims to, provide information about evidence-based practice and that sort of thing to the special education community. We run an annual conference which is, highly attended, bringing in, people from overseas and around the country to present at that conference and have workshops. So that's a little bit about the background of ACE. But just very, very quickly, I thought I might also just flag with you that I've been worked in the field of special education or supporting children with disabilities for some 40 years, which makes me feel terrible when I think about it in those terms. But the roles that I've had have allowed me to see a lot of different inquiries over 40 years, a lot of recommendations, a lot of ideas about what might work and what might support children and students better, some of which have been taken up, others that haven't. So I have worked as a support teacher in a mainstream school. I've worked for a non-government agency providing consultancy support for children with disability, enrolled across, Catholic, independent and public schools. I've worked at the Department of Education head office in disability programs. And I finished my career up as a principal of a special school. If I think about things in terms of this particular inquiry and the cohort of children being young children, I think I would have to say that the most rewarding part of my career was actually in the 1990s, and that was when children with disability first started being included in mainstream schools. At that time it was called integration, which is no longer an acceptable term either. But the way that the government and the Department of Education responded to that move at that time, I think, possibly does provide a model of how foundational supports can be provided in a more equitable way across schools. That early learning program that I was part of employed a early learning consultant, which was the role I had in Western Sydney, in every region. I think at that time there were probably 8 regions across the state. To be in that role, you had to have a special education qualification. And in our submission, that is, again, and what we kept, what is a major focus, and even just listening very shortly to the minimal amount of time I was in the room with the other speakers, it keeps coming up, like how are schools actually meant to support, children in the school setting? Because let's face it, they spend a lot of time in school, and anything that we can do to help teachers with that, I think is a really good idea. The notion that a classroom teacher can do it on their own is just not realistic. ACE really does strongly believe that every school should have a highly qualified specialist teacher with a range of skills that, if the panel are interested to look at the standards on the INSPED site, that's what we believe, key specialist teachers need to know. And included in those skills are those ones that were mentioned around collaboration, because the environment that exists today with the NDIS is a very, very different one, and it is, just so vital that there is collaboration and communication between anyone who is trying to support young children in the education system. So that's just a little bit about my background.
Thank you very much. I might start with a couple of questions. And I suppose wearing both your Australia Vice President hat and at a state level and your experience, you look at somewhere like Queensland where they have a number of programs to support young people with disabilities in schools and it's run through education. Do you think from a New South Wales perspective that support should be coordinated through education, or is it something that needs to be, from a health perspective, working in with our schools?
I think I do lean towards the education coordination from the perspective that there is a general feeling, or I have a general feeling that since the introduction of the NDIS, that disability is becoming increasingly medicalised. Just even the notion that children need to have some kind of medical or formal diagnosis to receive the educational support that they need in school, just doesn't make a great deal of a sense to me. It's children's educational needs that should be driving a lot of the support that they get. Now, I appreciate that NDIS provides a lot outside of the education system, but I'm just kind of talking from the education system. It's problematic at a school level that children, some children receiving NDIS support from clinicians, that the advice that clinicians are giving families is, practically incompatible with the school setting in which the children, actually are. And it's not about commitment of teachers. Oh, we don't want the children. I can give a personal example where, the advice coming from a clinician about the behaviour of a child who had seriously self-harming injuries, and the advice that the person gave to the school and the plan that was written for the children bore no resemblance to what, as an experienced special educator and also working in a school context, was possible to actually do for that child. And it is very problematic that, that the focus on recognising that specialist training can provide a really powerful and, essential way of, supporting parents even to navigate what their children's needs might be. It's also, I think, a little bit problematic that when there's money attached to something, it tends to be valued much more highly. So, as a principal, I have experienced the situation where, child gets $40,000 behaviour plan. Parents will place much more value on that than they will place perhaps on a school and a system that have been supporting, their child. So, I would like to see a greater recognition and greater coordination at a school level, yes.
My next question before I hand on is regarding the functional behavioural assessment. Could you provide a little bit of an overview of that? And it's referenced in your submission.
Yeah. So when we talk about a functional behaviour assessment, and again, some people are kind of a little bit anti because it is associated a little bit with the applied behaviour analysis approach to education. But really, an effective functional behaviour assessment of a child actually, looks at the whole environment and context of the child. So, you're identifying variables that kind of account for the most variance in the behaviour. So when does a behaviour of concern occur? When doesn't it? And what's its intensity? But what is the actual variables in the environment
that might lead to those behaviours. There are things that can be done in a classroom to reduce, say, some environmental variables, but it's also looking at what is the purpose of the behaviour for the child. So, what has prompted the child to do that? Behaviour is viewed as being purposeful. Children are behaving for a reason. We need to understand what the reason is. And if you understand then, what's the environmental context, what's the function of the behaviour, and then you can actually develop a plan that is perhaps going to support the child better, but also provide, an intervention that is going to support the child perhaps to manage their behaviour. So, in more modern discourse, it would be a plan that maybe helps the child self-regulate better, helps the child recognise when things are getting stressful. But you really need to understand, yes, the function of the behaviour. Why is the behaviour occurring?
And just to clarify, the assessment is all done by human as opposed to any AI ability?
Yes.
And how do you also address any unconscious bias that may be present in the assessment process?
I don't think I have an answer to that one. I mean, again, I would say, that, again, classroom teachers need the support of specialists. Teacher support. I don't think you need a psychologist to do it. I don't think you need an occupational therapist to do it, although you might have dialogue with everyone that the child's interacting with because you want a full picture of when or when not things might happen. But again, a well-trained specialist teacher is, that should be part of their training. Again, the whole notion around having really highly trained specialist teachers in schools is that they can support and even coach classroom teachers as well. So in terms of bias, yes, one would hope. But I guess that's part of your training, that you're made aware of maybe that such things exist, but that's a fairly individual matter. I don't have a magic bullet for that one.
I just wanted to pick up on this. So is functional behavioural assessment different to the functional assessment that the department is referring to in terms of... in our previous inquiry, we looked at this question around the gateway for accessing IFS. At the moment, it's diagnosis-based. There was a suggestion from the department that they have a preference to move towards functional assessment.
Right.
And I'm wondering whether that we're talking about the same thing. That's the first question.
Okay, so I think probably what they're talking about a little bit more is probably a bit more consistent with the approach of the nationally consistent collection of data, which is a functional needs assessment. So, a child might have a disability. How does that disability actually affect their functional needs within the classroom? And I would very much be in favour of every child being supported to reflect their functional need, regardless of whether they have a diagnosis of any sort. So
how is that different from a functional
functional behaviour analysis is really a method or an idea of looking at when there are behaviours of concern.
Yes.
And so you are looking at when those behaviours occur, what is the function of the behaviour? Whereas functional needs might be, that child has a reading problem. That's going to impact all these different aspects of their education. How are you going to provide an adjustment to address the child's reading difficulty?
Are not both assessments directed to the same thing, which is what kind of adjustments are you going to put in place to support that child?
Yes, I guess the outcome would be, but I would say that, functional behaviour assessment is a term that is used in the research literature. There are particular, parameters around it and how you actually do it. And a functional behaviour assessment would result in a plan of how you are going to support the child. Yes.
So my next question was really about, it appears that the department, there is some resistance somewhere around shifting from a diagnosis basis to a functional assessment.
Right.
And I wonder whether maybe you would have some insight as to what might be the impediments to the department shifting from that basis.
I haven't worked in the department for a while. I suspect...
Because you talked about the medicalisation.
Yeah,
obviously,
I suspect...
having a functional assessment is a means to avoid that sort of medicalisation. Yeah. And, of course, at the moment, it's a gateway to funding. And so...
And if you look at the education standards, they do talk about an imputed disability, and if you have an imputed disability, that is really saying, yes, you haven't got a formal diagnosis, but, it can be seen that there is something that is affecting your access, to the curriculum or to whatever's going on in the classroom. What could be the department's reluctance? I suspect... maybe a fear that it will just, really balloon and the expectation will be that much more is provided. I mean, a very common cry, and I think I even just heard some discussion when I was just sitting over there, is about, more SLSO time. That's not necessarily the answer. I think the department might have some concern that if you don't have diagnosis as part of the, mechanism for triggering supports such as SLO time, which, does obviously have a cost, that they might be worried about that. But I would say that if you really do a good assessment of a child's needs, it's not necessarily that you need to have a teacher's aid. And many of us in the field would even argue that sometimes the fallback position to say this child has a level this disability and therefore they get X hours of SLSO time, is not actually the best way forward. What does the child actually need? And it might not be a teacher's aid. But then even the use of teachers' aids in the classroom is a whole area that really needs to be addressed. The original idea of teachers' aids was not necessarily that the teacher's aid was going to sit next to the child with a disability and have responsibility for implementing that child's program. Part of the model was meant to be, well, actually the teacher's aid could go and sit with the children who don't have need adjustments, who have been set on a particular learning task, while the teacher spends the time working with the child with a disability. But often what you see in classrooms, as more and more children are included, is that the talk about whether it's going to work or not is dependent on how much teacher aid time there is.
Do you have any questions? I'll check. Mr. Barrett, do you have any questions?
I wasn't going to, but I will just jump on the back of that point that was just made then about the best use of the teacher's aid and the fact that the teacher's aid is not student aids. I wonder how we can more utilise that point, given what we're hearing that sometimes the resources of the schools are being diverted into other areas that they weren't sort of designed to handle. Into areas that would and should be covered by allied health in those areas, and how we can better utilise that teacher's aid role.
I'm sorry, I'm not quite understanding. Do you mind just explaining to me a little bit what you mean by that diversion?
I guess I just wanted to hear more about what you were just saying. I thought it was a really good point that you raised about the teacher's aids and how they can be better used, and wanted to hear more of your thoughts on that.
Oh, okay. Well, I mean, how they can be better used, we would argue, ACE would argue that that the allocation of teachers' aid time really is as a teacher's aid, and I think you said yourself, like they're not student aids. Again, it does again come back to, okay, well, what level of specialist support is there within the school? Is there a specialist teacher who can actually, more effectively train teachers' aides and talk to teachers' aides so that we have a system whereby teachers' aides can be used to support anyone in the classroom, so that the child for whom time is being allocated does actually get teacher time. It is a concern, as I mentioned. Again, it comes down, to training. I think that we all do recognise, and various reports and inquiries have found that the classroom teachers really do not feel confident to actually take on the teaching role of many students with disabilities in their classroom. And I think if we can provide more support to build their support, whether it be through, co-teaching models with a specialist teacher, whether it is part of our initial teacher training, then I think that effective use of teachers' aides can be incorporated in that training, just so that it's not the go-to. But, yeah. Does that answer your question, or...?
Yeah, thank you. I just think that was a really good point that you made.
There being no other questions, thank you very much for coming this afternoon, and also for the work that you've done over 40 years as well, supporting young people.
All right, thanks very much.
Thank you very much. Miss Scarf, can you hear us?
Yes, I can. I could see you and I couldn't hear you, and I was worried something had gone wrong. Yes.
Thank you for coming, participating this afternoon. Just so you know, we've got online two other members, Mr. Scott Barrett and Mr. Mark Buttigieg, and then we have the members here in the room. Before we commence with questions and an opening statement, can I ask that you state your name, your organisation and position, and either swear the oath or take the affirmation? I understand you've been sent those words.
Yes. I'm Angela Scarf. I'm Angela Scarf. I'm the Senior Policy Advisor for the Australian Association of Social Workers, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Would you like to make an opening statement?
Thank you. Yes, I would. Good afternoon, and thank you for the opportunity for the AASW to address you today. The AASW sets the standards for and represents the social work profession in Australia. We have more than 17,000 members nationally, of whom 4,400 or so live and work in New South Wales. We're a self-regulating profession, so the AASW is the body that sets the standards for the education, the ethical conduct and professional practice for social work in Australia. Before getting into the details about the service system in New South Wales, I want to spend some time outlining the worldview of social workers, the way we go about our work, because I think it'll illuminate the points that I want to say later. as social workers, we take what's called a person in environment approach. We think that what matters is the interface between a person and all aspects of their environment. So our analysis takes in all aspects of these two domains. So that's a person's health, their physical state, their mental state, their worldview and belief system, any conditions that they are born with, but we also look at all aspects of the environment in which they find themselves, their family, their community, their social status, their economic circumstances. And we refer to the process of assessing this as a biopsychosocial assessment, and this is something that takes time, and it's best done through the medium of a respectful relationship with someone. Now, when it comes to intervening, social workers similarly cast a wide net. In terms of directly improving things for a person, we undertake direct interventions that improve their well-being and help them reach their full potential, but we also look at those social and environmental factors. This means that social workers often are addressing the underlying or systemic issues in a person's environment that lead to, say, discrimination, unfair treatment, disadvantage. And social workers can also advocate at this level. And often that means social workers are advocating across several service systems to see whether people are getting the services that most appropriately meet their needs. I'm sure it won't surprise you to hear me say that social workers are found throughout the health, disability and community sectors. This means that even if social workers are not directly employed within the NDIS, many of our members are in services that intersect with it, in hospitals, in early childhood services, in schools, child protection, but also family violence and mental health. And because of what I've told you about the way we analyse all aspects of a person's situation and advocate across all systems, social workers are in a very strong position to identify how all these systems could or should be working together, complementing each other to build a unified and coherent response to all aspects of a child's situation. Now, we really welcomed the recommendations in the NDIS review for a reinvigoration of the service system around the NDIS. We see that as an opportunity to strengthen the holistic and strengths-based early intervention services that embody best practice in the way that you identified in your library's discussion paper. Many of our members before the NDIS worked in exactly these kind of services, doing exactly this kind of work. And this means that from our members' experience, we can identify the elements that we think are necessary for these early childhood supports, like the ones that you described, to succeed. Now, one of the main ones is that all children and families, including the very vulnerable children that so many of your speakers today have been talking about, have equal access to the holistic biopsychosocial assessments for children in the context of their family and community that we've described. Access to these assessments, when I say they should be accessible, that's about their location, their waiting lists, but it also means that they're free of stigma, that they're welcoming to families of all cultures and backgrounds, and that they're conducted by the sort of qualified professionals who can take time to build a relationship with a child, observe children and families together, and also who know the service system well enough to be able to formulate ideas of where that family should go. So this, you can see that we're already talking about a locally available, strongly functioning universal service system that's free of stigma. So you mentioned in your paper your Brighter Beginnings assessments for children in early childhood and schools. I'm thinking of the sort of things like the similar kind of assessment but happening earlier, say from the platform of maternal and child health. Now you can see already that this is really, really different from that single-dimensional checklist of are you or are you not eligible for the NDIS. or another project, because we're talking about a multi-dimensional respectful assessment. But you can already see that if someone's not eligible for the NDIS, it's up to that person to go back to another system and undergo another eligibility assessment. Whereas what we're talking about and what our members would like to see is something that sits outside all systems so that people only go through this process once. Now, as well as a strong universal system, this also requires a thriving system of early interventional supports, both general and targeted. Now, we see this as a really positive opportunity for improving the whole childhood service system rather than just being a cost. For example, we know of lots of members, and I've done this work myself, of people providing intensive wraparound supports to vulnerable families where there's a child with a disability or with extra needs, because that kind of work can build the parents' capacity, but it can also support the needs of every person in that family and help them in the way that they relate to each other. Because if we can keep a family together and functioning with that sort of skilled, holistic family support, and if we can keep that family connected in its community and its employment services and schools and local sports services, we're keeping that family away from child protection, family violence, mental health, and the alcohol and drug services. So we see the work that this committee's doing and the work that it opens up as a really good opportunity to lead, to a really strong community services sector. The AASW would be delighted to work with you on that, and I look forward to continuing this conversation with you now. Thank you.
Thank you very much. I've got a couple of questions before I hand on to my colleagues. Firstly, in your submission, and I must say you're one of the first I've come across, where you've talked about the role of local government
yes.
as well. Could you just outline what role you do see local government? Because a lot of talk about foundational supports or NDIS has always been a state-federal collaboration.
Yes, indeed. But when we think about a lot of the things that I've been listening all day to your conversations, and people have been talking about hubs, about place-based supports, a lot of that work of pulling services together into a holistic response relies on people knowing the service system. And local government are a really important part of the service system that we have already. And also, I think that they're like a foundation that could be drawn upon more actively. For example, in the maternal and child health space or early childhood, that there are already services there, but there are already staff in some local government areas that know the area, know the community sector that's working in the area, and some local government services already have those sort of coordinating kind of committees that could make sure that services are meeting all their not leaving any gaps and meeting the needs of the local community. So I do see a role for local government in this.
Do you have an example of some of the local government areas, whether it's New South Wales or in another jurisdiction, where that is working well? And there are identifying gaps or?
Look, the examples I have, I'm as old as the hills. I was doing work with schools and young people before the NDIS, and the examples that I have, and similarly of our members, relate back to what things were like before the NDIS, so that the city council in which I worked did have a sort of a youth coordinator position, and all of us who were providing services for children and young people met regularly, and that included schools, it included community health and various allied health providers. And we just looked at what the services were, where the gaps were, where people should be extending or strengthening their services, and funding sources, and how to make sure that submissions went in from people who could provide services that weren't there, and how those of us in schools and youth groups could make sure that the young people we knew of got into them. So, for example, there was a city council in Melbourne's northeast that was running disability-specific services, but had a little bit of money left over. And schools and youth groups knew that there were lots of young people in the area who didn't have enough to do and had a lot of time on their hands. And this city council had a music studio that it was letting out to sort of musicians and community groups. And so we decided that on one afternoon after all the after-school programs would be to come, we got a youth musician and a youth worker to help young people set up rock bands. Now, they were for young people with disability, as well as young people who didn't have a disability. They sorted themselves into it wasn't a rock band for the young people with disability. They sorted themselves because some of the young people on the autism spectrum were absolutely sensational at some things. This, cost, it ran on the smell of an oily rag with leftover money, with staff who had a bit of time. It kept young people off the street. It helped their education. It was one of those beautiful little things that cost nothing, met all sorts of needs. But it was disability funding that went to the local government. So then once all that funding was pulled out of the NDIS, that program died overnight, and the young people who were not eligible for the NDIS were left with nothing. So it's examples like that I just remember that worked really well. And I've talked to a lot of members in the NDIS and around the NDIS in preparation for you today, and there are other examples of things like that. The one that I was talking about in my opening address was in more detailed. It was with families that do have really highly specialised and complex needs, and examples of how you can wrap services around them before the children and young people get to the NDIS.
The other area I want to explore a little bit more was the role of the navigator role, which has been coming up, and how you avoid that position becoming, I suppose, another layer of bureaucracy, rather than focusing on upskilling and capacity building with parents.
Exactly. I have a lot of concerns about when I see the word navigator used, because I think a lot of people are using it in different contexts with different meanings, and when something's not there, it's very easy for it to become Alibaba's cave of everything that we want to be done. Social workers are taught and use the skill that's slightly different from navigation, and that's what we call case management or care coordination. Now, I do take your point about not being an extra layer, because we've got to make sure that the role I'm about to describe to you similarly does not become an extra layer. But it's different from navigators. Navigators sound to me like it's just sort of like pointing somebody in the right direction. What specialised support coordination in the NDIS do, and what old-fashioned case management, and is still done by some social workers, is taking all the services that a family is in contact with, or a young person is in contact with, and making sure that they not only do they not work against each other, it's stronger than cooperating. It's making them cohere into a unified, tailored response. So it's not an extra layer of bureaucracy. It's not an intermediary. It's a more active, making sure that everyone is in the room at the same time with the child, the young person, or their family, and working out, making sure that the family have a chance to say what they want, for everyone to hear at the same time, and that we're all going to do it. There's an element of clinical governance in it. There has to be arrangements between all the agencies who are already involved with that family. It has to be funded properly because it takes time. People have to be released from their case management, from their sort of therapeutic supports. But when it works, it's like the icing on the cake. It's like the system is bigger than the sum of its parts. Now, that's a really important role. It can be really good. So it's slightly different from the navigator role, which is, I think, being envisaged as just pointing people to the right services, assuming that those services exist.
Thank you. I might hand over to the Deputy Chair.
Thank you, Chair. And thank you very much for your appearance today. If I could just ask you, Ms. Scuff, we talk about, the ideal world of if we had a sort of a proper set of foundational supports for people across the state. But one of the things that keeps coming up and that worries me is the workforce capacity issues. Can you talk a little bit about the workforce shortage in the social work sector and I guess what we can do if we wanted to be serious about it in terms of attracting more people and retaining more workers in the sector?
Yes, workforce is a huge issue, and we at the AASW are members of Allied Health Professionals Australia, and I know you've also spoken to them, and a lot of the things that I'm going to say also apply to the other professions in ARPA. But yes, social work is it's a growing profession. There are real workforce challenges that we acknowledge and that we know about. The thing that is critical in terms of a social work qualification is the requirement that people do field education. That's 1,000 hours of supervised field education, and that's unpaid. Now, for a long time, that's been our biggest challenge. But one of the changes that's come from the federal policy recently, you possibly didn't notice that, but the ability for students on placement to then get that stipend, and so we are paying a lot of attention to that. We, as the AASW, we do determine those educational standards, and we have built flexibility into our courses, so they're not courses that you have to do straight through. You can take time out. We appreciate that students need to take time to support themselves, and also we did a lot of work around the Job Ready Graduates package to make sure that social work subjects were funded at the level that required students to pay lowest. So there are workforce challenges, we know, and we know that also, even though it's a great temptation to allow people with lower level qualifications to do that work, we also think that the risk that sits around the work that social workers do means that we do the standards that we've set, we're conscious that they are high. The families that we're talking about and the children we're talking about often are on the cusp of referrals to child protection. And this can be serious, and we know that families in which a person has a disability are overrepresented in family violence and drug and alcohol. So it's important not to downplay the level of skill that's required, because we are talking about children and young people and families at very high levels of risk.
Thank you.
Mr. Barrett, do you have any questions? No.
I'm pretty good, thanks, Chair.
The only other question which has been asked more broadly across a number of the witnesses is that ideal pathway of accessing or working with a family through that sort of continuous care approach. Do you have any comments more broadly on that and what that ideal pathway would be?
I don't want to sound cute and annoying, but for us it's very much that every family has their ideal according to what they want and their goals and needs. And a lot of what I was saying about taking time to do assessments and using your skills and doing observation is to do with giving people the time and showing that you're trustable so that people can tell you what they want. It's very easy for us professionals to assume that we know what is best for a family. And when I worked with young people, so often I realised that I had underestimated the goals and desires of the children and the young people for their lives, and that I would be confronted with children and young people whose other workers thought that, oh, this is good enough, they're doing well enough. But actually, that young person had already decided what they wanted, and we were letting them down by deciding too quickly that they were on this pathway. You see it a lot in children in out-of-home care, and the agencies, the foster carers think that they need to be in some kind of TAFE, some sort of academic light program. If you talk to that young person, they may well tell you that actually they're going to be a doctor so that they can make to, or they're going to be the clinical psychologist so no one goes through what they went through. And so we have to have a system that is flexible but strong enough for each child and young person's ideal pathway to happen for them. And that's what I mean about the holistic assessment early, which is different from the checkboard, are you eligible for this program? We need to be building in time for that family and that child or young person, because the child might have told their parents, and we need the parents to be safe enough to tell us what that child or family wants, so that if it is that child or family wants to be in a mainstream school so that they can go on and be whoever it is they want to be, I think that we are strong enough and flexible enough to set up a system that enables that child or pathway, to be on the pathway they need. When I say us and we, I have read the paper that your library got to do for you, and I've seen what supports are already there, so that things like I mentioned your Brighter Beginnings. See, my vision is that if Brighter Beginnings were funded to the extent that it could be and everyone had time, that the foundation is there to find out what those children want and to set up the ideal pathway for them. So I really don't want to, I know it's annoying when people don't give you a short answer to the question, but having read your paper and having seen what other people have said to you today, I think there's a long answer to that, and we can do it. I've also heard a lot of concern from the committee about quite responsible concern from parliamentarians about allocating resources fairly across a whole state and across all your systems. And it has occurred to me on a couple of occasions during the day that it might be worth pointing out that, the taxpayer is already paying a lot of money on families and children whose needs were not met early enough. So our members work with people in the mental health system, in the drug and alcohol system, in the family violence system, in youth justice. Our members who work in youth justice estimate that half the young people in youth justice should have had a disability identified ages ago and should have had a better schooling experience than they have a long time. So I don't want to just come here and tell you that you've got to spend heaps more money. I think the foundations for a really strong early childhood system are already in existence, and they represent a reorganising of resources from the tertiary end of the system into the early end of the system.
That's great. Thank you very much for appearing today.
Thank you for listening.
Oh, actually, sorry, question from Mr. Barrett.
Can I just jump back in, Chair, please? And can I circle back, Ms. Shafe, please, to some comments you made earlier about the band that the kids are involved in? We also heard earlier from Ellen about how proud she was to be part of her netball team. I could tell you stories about kids that I've played cricket with and against. So I just wonder if we could spend a bit of time, because we have it, on the importance of those, I guess, that covert support, being part of a club or a group or a sporting organisation, and how that can be better utilised to add this support.
Yes, yes, yes. And it's everything we know about neighbourhoods and communities, isn't it? And that the people who are the coaches, if they know that one team member behaves oddly at times for a good reason, that's all that they need to know, and that the team just needs to be able, and the coach can help the team work around that. And so I think that in terms of the foundational supports that are being envisaged, so at this stage I'm talking about the general ones, not the early childhood ones. There are those resources and light touch and online, those kind of things can really come into their own. But that gets back to the local government that I was talking about before, because it may be that local government is the appropriate person to be able to say to our football teams, okay, there happens to be the carer gateway or I forget what it was called, but it was in your document. There are resources on there for all those of us who are working with young people with special needs. Look at them. These people are in our teams. It can work really well. And that it's not only in terms of the services that the children and young people receive, it's what they give to that team as well. The thing about the one person in the rock band who can drum like there's no tomorrow, the one bowler who can do it, so that's their chance to shine, to see that, yes, this is what I bring. So, yeah.
Thank you.
Thank you very much. Thank you very much for coming this afternoon, and also for all the work that you do.
Thank you. Thank you so much.
Thank you.
And then we'll have afternoon tea break till 1:45 or 3:45. Sorry. I think we're ready to start. Welcome back, everyone. We do have a couple of members of Parliament who are online as well. But before we commence with opening statements from ENCOS and also questions, I'll have to ask that you please state your name, the organisation you're with, your position, and then also swear the oath or take the affirmation, the words of which I understand are in front of you. And I might start with Ms. Wright.
Hi, my name's Olivia Wright. I am the Director of the School Gateway Project at ENCOS, the New South Wales Council of Social Service. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
My name's Cara Varian. I am the CEO at New South Wales Council of Social Service, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Would you like to make an opening statement?
A very brief one, Chair. I'd like to start by acknowledging the traditional custodians of the land on which we are gathered today, the Gadigal, and pay my respects to the elders past and present. I also acknowledge any First Nations people in the room or online today. ENCOS and the community service sector support the most disadvantaged people in our state, and decades of this work has taught us that vulnerable children can thrive if we support them and their families to break the cycle of poverty and disadvantage. At Ashcroft Public School in southwestern Sydney, 40% of children at this school living below the poverty line, and it's a community of incredible cultural diversity, with 75% of the children from households where English is not their first language. And that's where Olivia works as part of our Marung project. There is a young boy, I'll call him Daniel, and Daniel lives in social housing with his dad and 3-year-old brother. And Daniel's dad looks after the boys alone. Their mum is in prison and has been in and out of incarceration since he was born. They don't have a family GP or regular health checks, and Daniel did not go to preschool. And through the Marung project at Ashcroft, which is an integrated service that connects education, social services and the health system to take a whole of child and whole of family approach, ENCOS has set this up with the school. And through this program, Daniel was given a health and development check when he started kindergarten. The results show that he was behind it across all key areas, and Marung has put him in an intensive speech group. He's seen the Marung paediatrician, and his teacher has made changes to help him in class. Marung's work with Daniel's dad to improve outcomes across the whole family as well. And Marung suggested that after assessing Daniel's younger brother, that he was also found to have delays and now also sees a speech therapist and goes to playgroup as often as possible, which is part of the school infrastructure as well. Daniel and his brother still have some way to go, but they have made significant progress, and they will keep getting help that they need along their way to reach their full potential. I tell this story because Daniel's story is not rare. About 70% of the children that were screened through this program needed extra help to reach their developmental milestones. But after Marung provided this help through a coordinated health, education and social service approach that looked after the whole family, the follow-up screening showed that the number of children with delays had dropped to 40%. The outcomes we see at Marung teach us some key things: that any support system for vulnerable children should help the whole family. It should support families where they are and respond to their unique needs. It should be easy for people to access in a single trusted local environment, and it should give families a trusted person to guide them through the services. And this is what we need to build in the development of this new system, as well as improving the existing system as well. Thank you.
Thank you very much. I might start with questions before I hand over to the Deputy Chair. First of all, thank you for giving that story regarding Ashcroft, which does a great job. And I'm interested to learn a little bit more about the supports that were provided, because I suppose the evidence that you showed just then is that not all young people that might need support need it indefinitely. And to have a reduction by sort of 30 odd 40% is huge in a 6-month period. So what were the types of supports that were provided, whether they were intensive or just general wraparound?
Yeah, I make the point that I think most people in this committee know that there is a huge intersection between people experiencing disability and poverty, and so when we're designing these systems, we need to understand that there is a connection there. But I'll hand over to Olivia on the details of the interventions and support systems.
So when we screened all of our 4 and 5-year-olds, we discovered that 71% of them were flagged in missing at least one, but more likely 2 or 3 of the developmental milestones. And at the time of doing the screening and initiating the project, we assumed it would be a case of, so we'll discover who has extra needs, and we'll either contact NDIS or we'll refer them off to the public LHD funded supports. And of course, the scale in a school, 71% meant that the scale of the number of children and the amount of support that was required, there was no way that we could get 40 instances of speech therapy for the number of children. And so really the way we responded was a patchwork approach. We brought all of the classroom teachers into the room. We have a school-funded speech pathologist in school, speech therapy in the school. We have an OT program, and we established small groups that children were taken out of classrooms and given a 10-week program with the speechy. Children were taken out of classrooms and given a intensive program with the OT. We were able to do some one-on-one supports for those children who were at the end of the spectrum and required the most support. As Cara said, we have a paediatrician in the school, so we were able to refer those to the paediatrician or out to community peds. So it really became a patchwork and a moving feast of how to support these children. But what that meant was that we could also go in and assess after a short period of time. And as you say, we could move because we knew that some children just needed a little boost to get up to a level that required them to meet the milestones. And so we were able to do that constant continuous sort of referencing back to whether the children had made progress.
And to do that would have required, obviously, the school principal and the support of the teachers. How did that process come about in bringing them with you on that as part of the program?
So the way in which we work now and how we began this was the school was recognising that the scale of the problem, to use a word for want of a better word, was increasing, but also that the way in which the standard processes that they'd been using for years was not working. So really they were completely on board to look at, well, how can we change the way we're working? And the understanding that if we don't integrate and bring these services into the school environment so that parents can access the services, so to try and remove as many barriers as possible for families whose children were identified as flagged as needing interventions. The teachers were on board, but they haven't had to do vast amounts of work. It hasn't changed their processes other than for some children it was identified that we would need in-class adjustments. But for the most part, we've employed the only additional position we've employed in the school was an SLSO, a student liaison support officer, whose specific responsibility is to manage these interventions, this program of interventions. The rest of the project really sits inside the standardised school processes, the learning and support process. But now we're very deliberate at ensuring that all of our younger students, 4 and 5-year-olds, are screened initially and then pushed through the standard education process, learning and support process.
Great, thank you. And Just one final question before I hand on to my colleague. Thank you very much for your submission. One of your recommendations is around a task force and looking at foundational supports. I'm mindful that the government announced a task force last year, and I'm interested to know, I suppose, the level of engagement that is expected with the sector and with others in looking at foundational supports here in New South Wales and the service gaps in particular.
So at the moment we look forward to being engaged with that task force, but that hasn't happened yet. And I think it's very important that there is co-design and equal representation from both government and non-government agencies. But I think the Marang project itself shows the challenges that there are just within the government, having the different parts of the department, or the different departments working together. And so part of this implementation task force needs to be bringing all the relevant parts of the government together, including the Ministry of Health and the Education Department and the Social Services, but equally with all of those social service and disability services that are provided. And in a context at the moment where there is enormous pressure on those services because the need is outstripping the funding that's available to deliver services, it's very important that the government considers how it can fund the participation in that task force, because there just isn't an ability for services to kind of do it on top of their business as usual. And I guess the third component is to make sure that everything that we do is grounded in the experience of people that have lived experience.
Thank you very much. I might hand over to the Deputy Chair.
Thank you very much, Chair, and thank you to both of you for coming along today. We've heard a lot. It's interesting. I think, coming into this inquiry, there was a lot of talk about funding and how much was required and where. And obviously, when you're dealing with the community services sector or education or health or anything else in the state, more funding is always welcome. But what we've heard a lot from people so far in this inquiry is that a lot of the need around foundational supports is actually about coordination and redirection and retargeting as well. To what extent do you think we could make a big difference in terms of providing the early intervention support that people need through that sort of smarter coordination and sort of, leveraging the facilities and skills that we already have within various parts of schools and health and community services, and how much is actually just a need for there to be far more services and far more money coming into the sector? It's a big question, I apologise.
I guess to the first part, we talk about it in terms of access, and it's the trusted relationships that people have to be able to go and seek help or to understand what services are available in the first place. And we see in communities all the time that that can be very hard to build, and so we would encourage this system to use the existing social infrastructure that's in place rather than trying to build, wherever possible, to be using existing schools, neighbourhood centres, community organisations, rather than trying to build something new, because obviously that would be starting from a baseline of trust, a baseline that doesn't include trust that already exists somewhere else. And then the other part of that is that the system is incredibly fragmented. The sector talks about the ping pong effect, and so people will go to their trusted organisation, be sent somewhere else as a referral. They can't take them because of capacity issues. They come back, and all of that degrades that trust. And so I think that speaks to that issue around coordination. It's also just a very kind of complicated system, and so if you're not a health professional or a social service professional, or even, and one of the things that I have found interesting about the Marang experience is that I think part of the motivation for those teachers to be part of it is because they felt helpless to know where to go for support. And Marang has shown them what's possible by connecting properly to health and the social service sector. But there is another component of that, which is the location, and the ability for people to get to those places for support, and that's particularly difficult in regional and rural areas. The other side around, whether we just have enough volume of services, I can't express how consistently I'm hearing from people that they are finding that the needs of the communities are growing in a way that they haven't seen, and really very old heads, like wise heads of the sector, are actually coming to me and saying, it's too much. I'm too tired. I can't say no anymore to my community. I'm going to retire rather than endure because I'm overwhelmed by this. And there is a volume problem as well as a coordination problem. And you will see in our submission that we do recommend a linker role to help with that navigation, and that we strongly believe that it needs to be focused on areas of socioeconomic disadvantage and cultural diversity. But it's both of those things. I think you shared an experience about Swahili families, and it probably demonstrates what I'm talking about.
Yeah, I agree with Cara that I think your question about targeting and using coordination is really important. And there's so much data. The AEDC data that was released this week shows where the pockets of need are that for addressing children with the greater need of developmental vulnerability. But it's really got to be contextual, and therefore even in those targeted environments you can't just have a single approach. The story Cara's referring to is we have completely new to the school 5 families in the last 12 or so months who speak Swahili, and before now they've never had any African or children of African origin. And so there's just been no way to engage this family, and using Google Translate or any of the translation services available have got us to a sort of point of existence, but nothing more than that. One of the children of one of these families, we have great concerns about behaviour and ability to access their education. And it wasn't until last week we employed a Swahili-speaking SLSO, and only for 2 days. So it's 2 days a term, well within the envelope of funding in the school's budget. And she sat down and had a conversation with the mother in a way that's culturally appropriate, obviously in language, and now we're miles ahead. We're going to refer this child to the paediatrician, and who knows what will come from that. But I think it's really important just to reiterate that it has to be targeted, and I think the socioeconomic disadvantage is a massive correlation with the developmental vulnerabilities, but also that it has to be contextual to the place. CALD communities, regional, rural, are all going to experience different disadvantage to accessing supports.
In your submission, you referenced children being, I guess, taken off of NDIS before they have found other supports. How common is that, and how much of a problem is it?
What I know is really anecdotal, and so it's very difficult for us to tell you that this is affecting 10 or 10,000 kids. But we are hearing stories regularly through our members that the children are not able to access services because they've been taken off, and that there is a vacuum of information about how long they'll need to wait and who they should talk to in the meantime, and it's causing a great deal of concern. How big that problem is, I'm not sure.
Thank you.
I just want to delve into some of the details of the Marang case study. So, where was the genesis of it an initiative from the school? Was there an initiative from an NCOS partner organisation? Was it, like, where did it come from? How did it come about?
The project is philanthropically funded, and it was initiated as an idea that there is a very successful model that's run out of Victoria called the Our Place schools, which are both government funded and philanthropically funded approaches to integrating services into the school environment, into the school setting. And so we received some philanthropic funding to explore that same approach or a similar NCOS, yeah.
Oh, right. So it's directly NCOS.
It was directly, it was within our interest because we were keen to see what the integration of service systems looked like in a New South Wales practice and policy, in New South Wales setting. And so we worked closely with DCJ at the time to identify a community that met some criteria, which included the deep socioeconomic disadvantage, but also other measures that we were interested in engaging with, and Metro was one of those criteria, and so we landed in Southwest Sydney, Liverpool, and ultimately Ashcroft Public School. But it was a process that we both came to in the end. Ashcroft Public School, as I said, had very low school attendance. They had a lot of children who were not, they had very low academic performance.
How big is the school?
320, including its P6, so there's a preschool, on-site school preschool. There's a SAC, a Scholars Community Centre. So they had the environment was right and met the sort of criteria that we had proposed, and as I said, there was a lot of buy-in from the school leader, the school principal, but also the DEL and the EDD. So I think it was ultimately a mutual decision. We did a lot of research using the Transforming Early Education and Child Health Research Institute at Western Sydney University to understand the community need, looking at the data across the sectors, but also engaging with the community. We ran forums with, I think, up to 80 families, with the students, teachers, social service organisations. And from that built the Murrung model. And the word Murrung means belonging in Darug, and that emerged from the consultation with the community that they didn't feel they belonged to anywhere.
And so how many specialists are involved in the
assessment
process?
I have a great visual that I could show you. There is philanthropically funded is myself, the NCOS director role, and then we have a Pacific Islander Samoan SLSO and the Swahili speaking SLSO. Other than that, the specialist roles are funded either by DCJ, by the school. There's potentially one health funded role, but we have the paediatrician is privately engaged but Medicare funded. The speech therapist, the OT are all education funded specialists.
Is this just a 1-year project?
No, we launched in August 2022, so we're into our 3rd year. So and ideally it'll run beyond the scope of our philanthropic funding, which ends in December this year.
And so in total, how much does the project... I'm just trying to get a sense of how replicable this model is. Like, if it's an expensive model, like, it's all, if we can create the best possible model, with the resources, but if it's not something that we can then duplicate in other needy areas, then, it's...
So it's a very it's a fairly tricky question to answer, and one that we're grappling with at the moment. But there are other examples of school-based hubs that have emerged in communities like Ashcroft, and they are all funded in different ways, and they come from different parts of the community that support them. So, for example, in the Sydney LHD, there are 9 hubs that are all funded out of so the LHD. It's not hugely. We're looking to expand into a couple of schools that are getting new preschools in, with the 100 new preschools in the Liverpool LGA in the same network. I don't think that it is much more than, I don't know that we could put a number on it, to be honest, but it's not a vastly expensive. And I think we've done some very crude mapping of where we believe, of the schools and the areas that we believe meet the same need. And there are, while there are over 2,000 schools in New South Wales, it's probably down to 100, 150 schools that you could potentially use an approach like this.
LGAs.
Yeah.
So.
And I think the LGAs are identified by those that have a higher than 30% child poverty rate. Was a criteria, an arbitrary criteria that we've used to make that recommendation.
Okay, thanks.
Thank you. I've just got a couple of questions. You do a lot of work around sort of mapping cost of living pressures and also obviously the increasing poverty in different areas. Have you done any of analysis overlapping that with sort of need for disability supports? And if so, are there particular areas of more need than others that you've been able, and I understand you might need to take that on notice.
I am happy to take that on notice. I would say that we have our economic mapping done, and we also kind of know that there is a correlation between people experiencing poverty and people that have disabilities. So there is a higher proportion of people with disabilities in that socioeconomically disadvantaged cohort. So I would say it would be a fairly clear and consistent map. Like it wouldn't be that different from each other. But I'll take it on notice.
And then how easy would it be then to just, I suppose, map where the services are and where those gaps in services?
It's something that I think that the whole of the social service sector would benefit from, is that a more comprehensive map than currently exists.
And the final one is just around the universal screening that used to operate, I think it was a Mount Druitt project and an Albury project. Are either of you familiar with those, which I know are no longer funded, but how does that differ to the work that's done with Ashcroft? Or where it was done?
I think you're probably referring to CUBS, the Checkup for School in Mount Druitt, and that is now funded, I might be wrong, but I think that was philanthropically funded initially, and now I believe has been taken into the Brighter Beginnings program by the Western Sydney LHD, however still operates as it was designed, and I would say fairly similar. We certainly are well connected with the with the Mount Druitt team and have modelled a lot of the way we designed our own screening program in the first year on the work that they've been doing. They also use the Teach Research Institute as their academic partner. And the Albury one is different. The Albury, unless I'm not familiar, the Albury program that I'm familiar with is a high school-based screening program to determine mental health and homelessness.
Yep.
Yes. Again, I would only say that I know it from a desktop perspective.
Yep. No, that's fine. Any other questions from our members? No? That's fine. Thank you very much again for appearing and all the work that you do as well.
Chair.
Thank you.
Committee.
Thank you very much, everyone, for coming in this afternoon. Before we commence with opening statements and questions, I'll need to ask that all the witnesses please state their name, the organisation that they're representing, and if they have a position. And then also you'll be asked to either take the oath or affirmation, the words of which have been given to you. I might start with Ms Robinson, because you've done this multiple times.
Yes, and I still need the form. Zoe Robinson, the New South Wales Advocate for Children and Young People, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms Stacey, would you like to?
Yes, sure. Lauren Stracey, CEO of Youth Action, and I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Ms Azaz?
Aisha Ayaz, I'm a member of Youth Action. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
My name is Eliza Tate. I'm at Youth Action New South Wales, and I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Yes, Ms Blackhouse?
I am Emily Backhouse, Aboriginal Participation Officer at ACYP, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Yep.
My name's Sonia Vujinic. I'm here on behalf of ACYP, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Would anyone like to make opening statements?
I think there are opening statements all round. I just want to start by acknowledging the traditional owners of the lands and pay my respects to elders past, present and emerging. Also want to acknowledge that I feel like I've achieved a goal and become obsolete, because there's amazing young people who you'll hear from today. But also just to acknowledge that this hearing and listening to it today, we are talking about our littlest people who often don't have voices in things like this. So I want to acknowledge all the people who have appeared and lifted up some of the people who don't often get heard. And I think that has been an incredible theme. And may we only do better by our young people and our littlest learners as well. But I will let Emily and Sonia read their opening statements on behalf of ACYP.
Thank you.
Yeah, okay, I'll go first. So good afternoon, Chair and committee members. I too would also like to acknowledge the traditional owners on the lands on which we meet today, the Gadigal people of the Eora Nation. I pay my respects to elders both past and present. The land on which we all live, walk and work was and always will be Aboriginal land. Thank you, committee, and Zoe Robinson for giving me the opportunity to appear today and to share my experiences of navigating the disability support services for young children. My name is Emily Backhouse, and I'm a current employee of the Office of the Advocate for Children and Young People, but I'm also a kinship carer for my young nephew, who has been diagnosed with complex medical needs, and I knew I was going to get upset and teary, so I apologise and bear with me. Prior to taking on the care of my nephew, I had little knowledge of the disability sector, only knowing what I knew directly from children and young people during consultation. It is important to recognise, thank you so much, it is important to recognise and appreciate that the services we have accessed have made a very positive impact on the health and development of my nephew. However, I have also come to learn and experience the strain and demand for these services, particularly in regional areas and for early intervention perspectives. Our experience hasn't come without its challenges and jumping through many loopholes, a process that shouldn't be so difficult. Being a full-time working parent and kinship carer, whilst also navigating a sector with the additional complexity of out-of-home care, hasn't been easy, and nevertheless worth the battle to ensuring my nephew is receiving the early intervention care that he deserves to be able to increase his chances of a better quality of life. Though I'm sure many of these will be highlighted throughout the questions, I'd like to share some insights that stand out particularly to me. These are the need for better communication and connection between providers. Unfortunately, I've found there to be no communication between the public and private health providers, often leaving it up to families to know and remember the final details that would typically be case noted and shared among practitioners. In particular, especially if you're having to travel between locations to see these providers. The funding and recruitment for community health, in particular in regional areas, is leaving such strain on waitlists and the time between referrals, whether these are being self-made via the GP or a paediatrician, and children being seen can take a month, 2 months or a year to be seen. I don't want to speak for others, however, there is potential that families are turning to AI to help kickstart the therapy to prevent further regression. I know because I did this due to waiting an extensive time to be seen for a physio. Recognising the work of early childhood teachers and their contributions to support children. We ourselves are very lucky to have a daycare who have walked and worked hand in hand with us to ensure that they are also providing the appropriate care and support in their environment, as well as aiding in therapy time. Early intervention, understanding and appreciating the importance of early intervention. Despite raising concerns and knowing that something wasn't quite right from very early on, often I was being told to wait until he was 2 years old to start investigating into my concerns. I couldn't imagine the impact on his development if I just let it be. We should be normalising early intervention early, ideally as soon as these concerns are raised. My hope would be that disability support services become easier to access in regional areas, that families are given opportunities to build their skills in advocacy, education, and to know their rights when accessing services to better protect themselves and the care being provided to their children. I hope that we acknowledge the unsung heroes of those who support families and their children and young people. And most importantly, and I'm sure unsurprisingly, that we provide better space for children and young people to be able to participate, to have voice, and to get to make decisions and provide feedback on the care that they are receiving. Thank you.
Thank you very much. Sonia?
Good afternoon, Chair and committee members. Thank you for the opportunity to speak today. So my name's Sonia Vujnic and I'm 21 years old, and today I'm speaking as a carer for my brother, who has a profound intellectual disability and some of the most severe behavioural challenges seen in the state. Caring for him has been one of the greatest privileges of my life, but when adequate support isn't there, it can become exhausting and isolating. Almost every support we've tried to access, whether through the NDIS, education or health systems, has been a battle, and when we do finally access help, it often disappears just as quickly as it came. Because of the severity of his behaviour, most mainstream and even specialised services turn him away. He has been rejected from respite services and disability day programs, sometimes without even meeting him, because providers aren't trained or don't have capacity to manage his behaviours. We've been told he is too complex for services that are specifically designed to support complex children and young adults. The irony is devastating. NDIS plans look good on paper, but funding means nothing when providers won't work with young people. We've had funding for support workers that went unused because services wouldn't accept him as a client. We've had therapists cancel services mid-treatment because his behaviours were too difficult to manage. We've had to repeatedly explain his disability to systems that should already understand how lifelong and intensive these challenges are. The result is a profound lack of consistency, the very thing people like my brother need most. He thrives on routine, on people he can trust. Instead, he gets turnover, gaps, and instability. This is a chance to fix a system that fails those with the greatest needs. My brother is not too hard, he is not beyond help. He is a human being who deserves support, dignity, and safety, and so do the carers who fight for them every day. Thank you again for the opportunity to share my story.
Thank you very much, both Emily and Sonia, for coming today, but particularly sharing your experiences. Before we move to questions, I'll just see if Ms Stacey or either of the two of you would like to make statements.
We do. Thank you so much. Good afternoon, and thank you for the opportunity for us to appear today before the committee. I'd also like to begin by paying my deep respects to the Gadigal people on whose land we're meeting today and honour the traditional elders past and present. Youth Action, for those who don't know, is the peak body that represents young people and youth services across New South Wales, and we represent over 150 member organisations and have been working alongside young people for over 30 years. And what we want to do is really progress the vision of a society where all New South Wales young people are supported, they're engaged and valued, and that their rights are realised. Our submission into this inquiry is grounded in the voices and lived experiences of young people with disability across New South Wales, And through consultations with more than 100 youth services and direct engagement with young people 16 to 24, we heard really clearly that the current system is fragmented, difficult to navigate, and is often leaving young people unsupported. We want to acknowledge that there has been some transformative impacts that the NDIS has made for many, but we also recognise that it has left significant gaps, especially for young people in regional communities, Aboriginal young people from culturally and linguistically diverse backgrounds, and those with complex or coexisting needs. Foundational supports we see as essential, and these are really the everyday supports that help young people access education, participate in their communities, manage their health and mental health, and also find secure employment. They are the vital bridge that, particularly for young people who are not yet diagnosed, are on wait lists or are ineligible for NDIS. But right now these supports are really inconsistent, they're underfunded, and they're often not youth specific. So Eliza and Aisha will now speak to us some of our recommendations, and they'll be also elaborating on that in terms of their lived experience.
Thank you very much. Good afternoon. My name is Eliza Tate, and I'm an 18-year-old student at Blackwattle Bay Sydney Secondary College. As a young person living with a disability, navigating the education system, I know firsthand how critical foundational supports are. At 13, I was hospitalised against my will. Soon after, I was excluded from a private school, not because I lacked ability, but because they lacked the will to support my needs. I was labelled too complex and too difficult, and repeatedly made to feel like I didn't belong. That exclusion hurt, but more than anything, it made me angry. Angry that systems built to serve young people were failing the ones who needed them most. What I want this inquiry to hear clearly is tying access to foundational support to formal diagnosis creates a harmful binary between those deemed eligible and those left behind. Foundational support must be youth-specific, flexible, and accessible before diagnosis.
Good afternoon, members of Parliament and everyone here today. My name is Aisha Ayaz. I'm 16 years old and a young person with lived experience of disability. Today, I would like to advocate for more inclusive and accessible foundational supports for young people with disability. For a long time, I lived with an undiagnosed condition that significantly impacted my ability to function. It took 2 years to receive a diagnosis through the public healthcare system, and during that time, I wasn't eligible for any disability supports. After I finally received treatment, I had to put in a lot of work to regulate my daily life and catch up on the time I had lost. I was fortunate to access education through Sydney Distance Education High School, which allowed me to work at my own pace and access special provisions. I believe we need to offer support not just after diagnosis, but throughout the diagnostic journey, and take a more inclusive approach to how we define and support disability. Thank you for the opportunity to share my perspective and experiences. I would now like to highlight that we believe the following are essential recommendations to consider when developing a successful foundational support system. First, develop a youth disability action plan for New South Wales. This should be co-designed with young people with disability, grounded in a rights-based social model and tailored to their unique needs. Second, build a fit-for-purpose support system for young people, delivered in accessible and youth-specific community settings like youth hubs. Third, find a truly coordinated service ecosystem. Currently, families and young people bear the burden of navigating siloed systems. No one should have to become an expert in disability, education, and healthcare policy to access basic support. We need services that communicate across departments, sectors, and providers. Fourth, upskill the workforce that supports young people with disability. Invest in training that builds capability across services to ensure they are safe, accessible, and responsive to the real experiences and needs of young people.
Fifth, integrate disability inclusion into education. Increase investment in mainstream education settings, including teacher training, inclusive policy and practice, and capital works, so that all young people with disability can thrive in their learning environments. Despite having documentation of my support needs, I was repeatedly denied basic accommodation in school. That institutional failure contributed to a steep mental health decline and ultimately pushed me out of the HSC ATAR system. Education should be inclusive by design, not dependent on a young person's ability to fight for it, prove they're struggling enough, or tolerate bullying and neglect. Sixth, guarantee access to early intervention and diagnostic supports. Like many others, I spent years in visible distress, but without access to diagnostic pathways. Research shows that girls, socioeconomically disadvantaged students, and those part of a racial minority are significantly underdiagnosed and consequently cannot access support. Seventh, tackle geographic inequality head-on by funding local infrastructure, outreach, digital delivery, and community-led response so that no young person is left behind due to postcode. Eighth, support Aboriginal people with culturally safe services. As a young person with a disability, I stand in solidarity with my First Nation peers. The disabled Aboriginal community is hurting. The death of Kumanjai White, a young man with disability, underscores systematic racism and use of excessive force.
Thank you.
Thank you very much, and thank you both of you for coming today, and also being so open about your experiences. We're going to ask a few questions. It's quite informal, even though we're sort of sitting in this environment. And anything that you don't want to talk about, you can either just say, look, I really don't want to talk about that, or you can also say, I'll come back to you on with that. So feel comfortable chatting about anything that you'd like to. So I might actually start with Emily, just from a regional perspective. You mentioned you were told that there would be a 2-year wait time. Was that because of lack of access to services, or was it because that was the advice? I was saying, come back 2 years, wait and see what happens.
Yeah, so that was based on the advice, pardon me. So I had raised very early on concerns of development issues, and I was told from those practitioners it's not typical to actually intervene so early and to wait until he was 2 years old until you were able to visually be able to determine and visually be able to assess what those lack of developments were. Yeah, so that's really unfortunate. And I think when we're thinking about early intervention, obviously earlier the better. And it actually took us to go and see a private paediatrician to then, when I was listened, and then it kind of was full circle. We went and saw the private paediatrician, and then we had returned back to those health professionals who then said, oh, they are right, and you were right, because obviously by that point we had some form of diagnosis.
Thank you. And this is to both Emily and Sonia in relation to, I think it's fair to say both of you are quite young as young carers. What support is given to you to help you navigate the system, to help you in your role as carers?
I think for the both of us, it's obviously very different experiences. So I understand and I definitely accept my privilege of having DCJ as part of my support network, as far as I would say that. So I think it's very different, but I think also as someone with an education like I have, it's also kind of the support that I also rely on, and the situation might be very different for Sonia.
Yeah, I don't personally have any support networks that reach out to me. I do think it's also quite difficult for my parents because they also come from a non-English speaking background. So I don't think there's any specific supports for carers in terms of my experiences, but I'm sure it would be more the supports available for my brother that would help them, make their job easier.
And I'll ask a couple of questions. First of all, I might start with Alicia, just in relation to, and you touched on having to have a formal diagnosis. And I wanted to understand a little bit more, how did that, I suppose, impact your education, having to wait for someone to formally diagnose you with disability or some learning challenges?
I'm sorry, you said Eliza.
Oh, sorry, Liza.
So I didn't get diagnosed till I was 14 years old, and by this point I was very, I had experienced multiple points of education, private, public, specialised. I had been in the hospital system, and so that really had affected where I was currently. I think if I had foundational support before, it might not have gotten to that stage. And I think I'm a young person, I'm a young girl from a privileged background through my race and socioeconomic area, and I still immensely struggled. So part of why I feel the need to advocate is because in our recommendations we talk about people in remote areas, we talk about Indigenous communities. They have it so much harder than than people in the cities who are still struggling.
Thank you. And Isha, you talked about the need to have a youth-specific disability action plan. I'm interested to know, what do you think would be good in that plan that would help young people?
Well, a part of that plan is that it should mainly be co-designed with young people. So we would like to strongly advocate that young people should be involved in the process of creating that plan. But personally, I would like for there to be more focus on accessible services, some support systems with education and health. That would be great to see.
Thank you very, very much. And I might hand over to my colleague, Abigail Boyd.
Thank you, and thank you to all of you for coming along and sharing your experiences. I might start with you, Ms. Tate, because quite a lot of what you said really resonated with me. But one of the things that I've been thinking a lot about today is the impact that exclusion and ableism has on the ability of young people to get the support that they need. To what extent do you think that I guess the lack of access to services is sometimes driven by that medicalised model of disability, where we need to have some sort of diagnosis before you can just get sort of ordinary support?
The medical model that currently underpins all our servicing is damaging young people. Just behind me, I'm sure he wouldn't mind me saying, one of my peers has been excluded from school due to the fact of exclusion, of bullying, of ableism. It's the same story as me. And if we had services which saw us as whole people and saw us as kids, not just our disability or the fact that we don't have our paperwork, if we had more compassion in our systems to go, this is a 13-year-old who wants to get to school, they're trying really hard and they're not able to because of this discrimination, I think it would change every kid in New South Wales with a disability's lives.
Thank you. That's an excellent answer. Did anyone else want to talk about that as well? And I guess I worry, now that we know that only 1 in 10 people are on NDIS, and that often that is used as a gateway in order to get services and to get the support that people need. But there is now a huge number of people who just are seen as not requiring the same level of support, and perhaps where, as policymakers, perhaps making it more difficult for people to get services because we are encouraging a binary in a way, or is that this lack of inclusion, is that something that resonates with you as well?
I mean, I move forward because we talk about human-centred design, and that's not what we have. We have a system that people have to find their space in that system, versus actually, if you think about a wonderful 13-year-old who is communicating and maybe telling you the things that they need, it's not up for us to then find where they fit in the boxes that we've created. It's us to say, okay, well, now we need to make sure that that can happen for you. So help us understand. And if that's not possible either, let's work together and figure out how we can communicate what is needed. But human-centred design has been misused, I think. Having come from a consulting firm who made plenty of money talking about it, I think it's been misused because we no longer put the individual, unique human at the centre of something. We ask you to fit into a system and fill in forms that make sense for a system. But also, we need to remember that there are rights to things. So as a young person, you have a right to education. And we're talking about an education setting and we're excluding you from that. As you well know, Ms. Boyd, ACYP's view is the reason for that better be pretty good, because that is a fundamental right that young people hold. And then if you take that to people who perhaps can't communicate reasons why, and particularly little people, little learners, and they're not having those conversations, again, it has to be a very good reason when that is something that we should be creating spaces for you to come into and have the benefit of those spaces for outcomes that matter to you. And so I think we've kind of lost humans at the centre of many things, but especially when you're talking about young people who might have disability and even little learners who have undiagnosed spaces, shouldn't we start by saying, let's create somewhere where you feel like you can come, and then let's figure out what you need. And I think Emily said the words beautifully, and let's walk together on that.
And just to build on that, I think, you know, one of the things that we heard in our consultations that some of the young people here were part of was that that whole challenge created another set of challenges that they were then having to navigate. So, you know, you were having to advocate for yourself at school, and the energy that took then impacted your mental health. Or, you know, you were having to pull resources from other parts of your world to be able to maintain education, which meant that you then collapsed when you got home. You weren't able to engage in family in the same ways. And similarly, young people were also speaking to the fact that when they were able to engage with the supports that they needed, being able to, you know, go to your psychologist, for example, and learn some skills that might support you in another domain, and then being able to go to a specialised youth space like a youth centre, a youth hub, something like that, where you had supportive adults to be able to hold you while you enacted those skills, actually meant that you got better benefit from the thing that you were accessing treatment for. Because if you haven't got the opportunity to generalise that, if it only happens in a clinical environment, the learning doesn't get embedded in quite the same way. So I think that, you know, there's lots of opportunities where we can broaden out what we think of in terms of this kind of support to be able to create whole ecosystems, really, which can hold young people as they develop.
But also, I think, as Sonia said, if English isn't your first language and you have to navigate that, and you have to try and articulate what it is that you think you are seeing in a young person in your life, or you are feeling and going through in your own life, that is a complexity, again, that I don't think that we've managed to design well in any system.
I like that concept of designing whole ecosystems around children and allowing people to then be able to, and supporting, I guess, in order to be able to thrive. So I guess then if we're looking at, you know, recommendations coming out of this inquiry as to how the government should be viewing its, you know, its role in laying out foundational supports for the future. We've heard a lot about, and you've mentioned it today, the idea of having, you know, coordination and making sure that there's someone who's there to sort of make sure people are getting the bit of the ecosystem they need at that time. Is there also an opportunity there for those, I guess, those connecting, supporting kind of hubs, whatever we want to call them, also playing a role as almost in an advocate's role for each child in order to have their rights met? Is there an element of that could be sort of built in?
I don't want to take away from that, because I think certainly listening today and listening to people speak, obviously there is amazing organisations and communities who spend a lot of time connecting and advocating and all of that. And I think that absolutely continues, and the ecosystem is very true. I think when we're thinking of it from a government and policy lens, if we start with rights and what people should have, and we design it that way, then we're not negotiating away things. We're not creating spaces where you have to almost build another avenue to advocate for it. You should be creating spaces where people can step in, and that is what, you know, that service is about, is saying we've created a space, and everyone talks about it, youth hubs, one-stop shops, whatever you want to call them. They are places where someone can come, or someone can go to that person and say, what are the things that you need? And then it is our role to make sure that you have those things. And so I think we still have to start with what people have a right to, as opposed to expecting it still to be carried by community people, by carers, by individuals. We have a role and a capacity in that space to say, actually, we're going to do our best to enable and ensure, and we're not going to negotiate any of that away.
Thank you.
So I might ask Eliza, Aisha and Sonia just about, and I'll come back to you, Emily, as well, but in your case, what would be the one support that your parents would have benefited from that wasn't there in your circumstances? Is there one type of support that you think would have really made a big difference that wasn't there when you needed it, or when your parents needed it?
Should I go first?
Sure.
I think possibly someone there to support them who they could culturally connect with as well. Because my parents are from a Serbian background, so you can talk to caseworkers and things, but it would still feel a bit foreign at times. And I also don't think there was much mental health support for them and for carers. There is a focus on how do we help support my brother, but there was no one really supporting them. So I think that would be beneficial.
I would like to bring up that personally I would have liked to see some support regarding disability specifically and support within education. Sorry, my mind just went blank.
Would you like me to step in? Yeah. I completely agree. I think education is a really key cornerstone of when kids are struggling fundamentally. You know, you're at school 5 days a week, so if you can't get there, it's really difficult. I think something that my parents struggled immensely with was when I was not enrolled in a school and I didn't have access, where do I go? So my previous school gave us a list of about 30 different other schools, and they were all for kids who could not speak, who had very complex needs, which in my case just was not what I needed and was actually really degrading. Oh, you can only do life skills, which just isn't the case. So I think having someone to step in there and go, here's a space that your child can learn in, that they're not an between really complex needs and competitive academic environments with no support.
Okay, I would like to speak on it now. So one support that I would have liked to see would have been in regarding diagnosis. So since my diagnosis took so long, it was mainly because we went through the public healthcare system. With private, it would have cost something around $2,000 to get that diagnosis. And with public, we had to wait 2 years because there's so many people who are also seeking a diagnosis. And in the time that it takes, the condition can actually get a lot worse, and it can then impact mental health, education, and just their daily life. And also within school, there was kind of a lack of support due to academic achievement, because even though I was doing okay in school, I was missing a lot of classes. I was struggling to keep up with the workload, and it was very draining for me mentally. I remember just coming home from school and just not even being able to get out of the car because of how physically and mentally drained I was. So definitely like some support within school with learning special provisions I would like to strongly advocate for with people with disability. And with diagnosis, I guess some kind of funding or help with speeding up the wait list. The main reason that it took so long with the public healthcare system is because there were only 2 doctors at that hospital who could diagnose that. So with thousands of people trying to get that diagnosis, it would have taken forever for a lot of people.
Okay, and Emily, perhaps you could speak about, a type of support that wasn't there that you needed as a carer.
Yeah, I think, look, again, I do acknowledge my privilege of having DCJ as a support network, despite the complexities that lay there. But I think for families, particularly where I'm from, the lack of support comes down to staffing, and actually being able to access those services within our local area is very far and thin. And so having to actually transport, whether that's interstate or locally being an hour and a half away, that's not available to every single family. And so I think taking that into consideration, the demand and the need versus the staffing ratios and how we're actually supporting families within that time. Like I said, I turned to AI to utilise the smartness of AI to try and figure out how I could best support my nephew, because I don't have a background in the space that he was needing that. And so, trying to find ways to kind of, fill that gap without, exhausting carers further, which is really important. I don't think there's enough emphasis on the impact that it's having on carers and on families, particularly those that have more vulnerability, that those wait lists are then having on them.
Mr. Barrett.
Thank you. First of all, I think Zoe and Lauren, you guys could have stayed at home.
Thank you. It's a good thing.
Quite an impressive panel you've pulled together. The question I'd like to ask, and Zoe, you might work out where I'm going with this. I wonder where, and I think it was Eliza that talked about the belonging and that sort of acceptance. Where else can you go to get that? And this is a question for everyone. To get that belonging, to get that acceptance. And I'm thinking also outside the standard disability support services groups that might be available to you.
So when I first got diagnosed, I did not see anybody else in my life that I could go to. I felt really isolated. And so I actually joined a social group for my specific disability. And this was really great. And now I no longer go to them because I'm in specialised pathways where my peers do have similar stories to me, but I would love to see more groups like this one. You know, it helped people with travel if they couldn't go on normal travel groups due to their disability. It helped them with sport, that sort of thing. And that they're just fundamental things. They're fun things that teenagers and kids, they want to get involved in, and sometimes their disability doesn't allow that.
And and I will open this up to everyone, but so being involved in the sports and those sort of other teenage activities, how much of an outlet, how much of a support is that for you?
I cannot say enough how much I've enjoyed just being a teenager in the later part of my years. It has been amazing to not be at doctor's appointments, not be, struggling at home, feeling isolated. I love going to school. I love playing netball on the weekends. I love seeing my friends, and they're just the things that you want every kid to experience.
Anyone else like to add to that?
I mean, I think that Eliza put it beautifully in the sense of belonging is what that young person finds and chooses where they find that. And so I think it's the responsibility of those in all of the communities and spaces to ensure that there is access to a variety of spaces that can happen. For the benefit of the young people at this community, I think Mr. Barrett wants to get to talk about crochet and wants to know whether you're interested in crocheting, because he seems to be pushing that in the young people right now. But I think it is, this is the second time I feel like we were going down this path, Mr. Barrett, but I think it is that young people, we can't define what that space is for them in terms of where their belonging is. Our role is to enable that to be good spaces and many spaces. And if they are telling us that is a space where they find their belonging, then we should make sure that they have access to that and create more spaces where young people feel like they belong.
Mm-hmm. And in terms of belonging, some of the things that we heard in our consultation was that there was something kind of magic about youth-specific spaces that meant that young people felt that they could ask for what they needed that was different to other spaces that they were in. So there was something about the way that youth workers and the specialists who work with young people were able to make it known to them that they could say exactly what they needed, whether it's by visual cues, whether it's by the way that the space is set up, whether it's by the way that they engage with them, that made it really, really obvious to them that they belonged. And so, I think when we're talking about that opportunity for increasing training and investment in training for people who are supporting young people, being able to invest in those kind of things so that whenever a young person walks into a space, they can ask for exactly what they need so that they can belong, whether that's sport or other recreation, would be really great.
Yes, and it is that covert support that I am talking about, that being part of a cricket club or a netball club, or as Zoe referred to, a crochet club, whatever it is, where you can find your tribe, where you can find people and find that belonging.
The other thing, Mr. Barrett, before we move on, is that I think when the work was done around social media, and I would be remiss not to say that young people talked about, they recognise the pitfalls with social media, but it's also a place where for some people who cannot or aren't feeling at the right stage, or for various reasons it's not accessible to be in a space, they can find communities online. And so that's one of the things that young people, when we talked about the social media age restrictions, or when we talked about that space, we did hear from young people that for many, it is where they can find a sense of belonging.
And could I also speak on that?
Please.
I am a student at Sydney Distance Education High School, and when I first switched to that school, I really noticed a huge change in the environment and the way that students felt when they were there. Because there are a lot of students there with lived experience with disability, so it kind of made me feel very included and like I belong, because everyone there had been through similar situations. Everyone was incredibly friendly and kind to one another, and I haven't noticed any issues with bullying so far. So it was quite a safe space for me, and I really enjoy going to the hubs because all the teachers are very supportive. They check in on you. All the students are very friendly. The staff members, the office workers. It's a very nice environment to be in.
Yeah. Starting with you, Emily, if I could, we've heard the evidence and we've seen submissions talking about how much worse conditions are for people in regional areas. I just wonder if you could shed some light on why you think we are facing greater difficulties in regional areas and metro areas.
Yeah, for sure. Look, I think the last person who appeared, and I apologize, I don't remember their name, but the need is so much greater than what we actually recognise. We are living in towns who, once upon a time, there was a couple of streets, one high school, one primary school, and those towns are booming. They are, there's thousands and thousands more of families who are moving to these regional areas, and we're not catering to that. We have families who are, having these difficulties accessing these services, who are having to outreach and to go to other locations to access these services. Look, I'm not privy to what happens behind closed doors, and I'm not privy to a lot of things, but I think from my experience, there's a lot of staff turnover because burnout is so contagious, and it's something that is, I think, really affecting regional areas. The demand is there, the quality of work is most certainly there, but there is just dire need for more. And I guess as an example, to access physiotherapy, we were on the wait list for 6 months before we got a phone call. And the phone call that I received was, we don't actually have this service in your area, but you currently travel to another area where you can access this service. Do you want to go there? And of course, without a doubt, I said yes. But there are a lot of families who cannot travel to that location to access that. So their young people and their young children are then missing out. So I think it's a combination of funding, of staff turnover, of, I guess, maybe communities not actually recognising that need. But then I think, unfortunately, the flip side to that is that childcare centres and early childhood educators are kind of the spine for that. They're kind of really trying to recognise and support children within their environments to kind of not, I guess, let that regression keep on falling behind. And so that's when families are turning to things like AI to kind of contribute to that development, or are turning to private specialists who, again, can cost quite a lot of money, and we're in a cost of living crisis, so not everyone can actually afford to go and travel, but also then pay the money to see private specialists. But in small regional towns, there's a long wait list for community health providers and for private health providers, and so you're kind of a bit at a loss for that.
Anyone else care to talk to why we think there's such a disparity between metro and regional areas?
I think with the cost of living crisis, there's probably just a lot of pressure on suburban areas, and the pricing for the suburban areas are going up quite a lot. So then people who can't afford to live even in suburban areas would then move to regional areas. So that could put a lot of pressure on them to have more support services for young people. And since they're not very strongly funded, there might not be as much support systems available there.
Very insightful. Thank you very much.
Thank you.
Thank you. Any other questions? Yeah, if I may. So next week, the Treasurer of the state will hand down a budget, and there will be funding announcements, and there will often be sort of policy announcements attached to the budget. If it was your budget, what would you want to see in there that would make the most difference in terms of creating a more supportive environment for children with disability going into the next sort of year or two? Imagine you've got a magic wand.
Look, I'm happy to go first because obviously I had my long list of hopes in my opening statement, but I think obviously at its very core, more support services for younger children for early intervention that is actually early and that is actually targeted to what they need. But I think also really importantly, I think I would really appreciate a bit of an education piece for families and for carers to actually acknowledge and to understand their rights when accessing services and not just, falling down for the trap of listening to GPs and paediatricians. They do great work, but I think there's a lot of times, especially when there's such a strain, it's so easy to just push to the side and put into the too hard basket. And I think that's happening more and more, especially with this strain of services. And so I think getting families to acknowledge and to understand where they can sit. And I guess from my perspective as someone, again, who's, very well educated, very well realmed within this kind of space, I find it very difficult to do things like NDIS applications and to fill out forms and to remember details. And so I think creating some sort of thing where we can build that communication between practitioners. There is no communication currently. And so when you're having to jump between public and private, and especially in different local health districts, that's causing even more complexity. And so, look, I know there's many things in there, but I think, again, a piece around younger children, we are missing their voices and we're missing their participation, and we're relying on parents and families and carers maybe a little bit too much to tell us what their young children need when they can actually tell us themselves. And so that would be a really nice, hopeful dream.
Excellent.
I agree with Emily. I think some kind of way to navigate the process of accessing help and understanding all the procedures involved will be beneficial. I also think increasing training for disability support workers for very complex cases would be beneficial, because there's a broad range of cases and no two people are the same. So I think from my experiences that would be quite helpful.
I would like to say that personally I would like to see more NDIS funding that's inclusive to many disabilities, because there are a lot of young people with disabilities who aren't eligible for NDIS either because of their age or it doesn't impact their life enough, even though they are significantly struggling due to their disability. And not having that support could not only make them struggle a lot more, but it would also put stress on the parents to try to find support systems that are affordable for the young person, and it can just be very difficult overall. And also teacher training to support people with to support students with disability, because currently they aren't fully educated on how to support young people's needs, especially in the circumstance of disability.
I understand that politics is all about money and budgets, and so I'd like to make a comment on something that wouldn't cost any money.
Well done.
And I think if we could have NESA understand, and probably New South Wales as a whole, understand that people with disabilities don't necessarily have a low IQ, and it's not something that you have a disability so you have a low IQ. And so if we could have students like my peers who are saying they're getting straight A's but they're really struggling, an easy fix is we start recognising twice exceptionality within our policy, within our education policy. There's currently no guidelines on NESA about a student who is both disabled and gifted, and so having that would help a whole lot of kids who are currently dropping out.
Can I jump in as well? Because I'll just speak from the perspective of the youth sector. We talk a lot about the fact that at Youth Action that we need to take a rights-based approach to the way that we work with young people, and that I think that is critical and fundamental to this all. But I think we need to invest heavily in the early intervention and space for the 0 to 5s, that kind of early years. But adolescence is the second wave of neuroplasticity, and so we need to really have some solid investment in that space as well. And the benefit of investing in that particular developmental period is that we have these absolute legends over here who can help inform it and help co-design it. And they not only bring what they know now, they are also very closely, their childhood wasn't long ago, so they can also reflect on what they needed and what they were missing out on. So, being able to have investment that is really driven by young people's voices, that has a rights-based approach, that really looks at that whole person would be fantastic to see.
Mm-hmm. Excellent.
Something else that I'd like to add, and this is again based on my own experience, but some form of investment for working carers, because what I'm finding, and I will just acknowledge the fact that Zoe and ACYP have been very empathetic and understanding to my situation, and I appreciate it. But there are some working carers who do not meet many thresholds, and so then they are having to actually take unpaid leave for a certain amount of times to attend to things like appointments. I'm very lucky, very fortunate. I have my time that I take to I guess cater to my nephew and his appointments, but many families don't. Many families are single income households. Many families are relying on that single income, and so they're not able to actually take that time away. And so, again, I think trying to find a way, I'm not sure how, and it costs money, I'm sure, but I think if we're investing in working carers better, we're actually going to be benefiting the well-being of carers, but also their children who, I guess, place hold of that as well.
I mean, I'd love the idea of having the pen on the budget, but I think what we've heard today is, I get that we need to build things. I get that there's infrastructure that needs to be committed to, but it seems like if we nurtured the good things that are going really well, if we harnessed what people have said today and around this table about what has had a good impact on them, and we started to shift money into things that perhaps we can't, and I don't mean this disrespectfully, I get why it happens, but perhaps we can't cut a ribbon. But what we can do is see people feel something, feel like they belong somewhere, have a space where they can go to. I feel like we shift money into those things, and we can't necessarily always articulate it, because sometimes it is about the fact that someone at this table talked about the fact that they are enjoying their teen years for the first time. Whatever we did in that space that made that possible, let's invest in that. Whatever we're doing that allows a person to care for their nephew, let's keep doing that. So I think it has to look like many different things. But also I think, wouldn't it be amazing, and perhaps this is a challenge, and I can do this because it's my last 6 months and I can be cheeky, wouldn't it be amazing if the Treasurer sat with some of these young people as they were designing a budget and tested, was this a good investment? Does this make sense for you? Does it make sense for people in the future?
I love that. Yeah. And I think on that final note, I'll say thank you, but particularly to the four of you for coming today and sharing your experiences. It does make a huge difference, and all of you are doing such an amazing job. You should be really, really proud. And thank you to both Ms Robinson, also Ms Stacey, for coming along, and the work that you do, particularly for young people across New South Wales as well. And that ends our witnesses for today. So thank you very much again.
Yeah.
Great.